Okay, a very good morning to one and all. Welcome to the day 2 of 31st Annual Scientific Meeting of Indian National Association of Study of Liver. Let's start this day with the name of the Lord sitting above. Jai Jagannath, everybody. And let's start with the special interest group. I'll request our chairperson to please join me on the dais. Requesting Professor S.P. Singh, President INASL, Chairman of Kalinga Gastrology Foundation, to please join us on the dais. Also requesting Professor Dr. Ajay Duseja, Secretary General INASL, Professor and Head of PGIMER, Chandigarh, to please join us on the stage. Can we have a good round of applause for both the gentlemen, please?
Hi. So good morning, everyone. Welcome to this special interest group on, we're calling it MASL D, oblique NAFL D. So the format is that we had around 357 abstracts which were submitted. Out of the 380 something, we actually selected out 357 abstracts for presentation in this meeting. Of those, 10 abstracts went on to the oral session, 5 in the plenary, and 5 in the young investigator. So we were left with 347, and they were really of good quality. So what we have done is, in all the 8 SIGs, we have again chosen 2 abstracts each, which were the best ones, to be presented here in the oral session. So in the SIG on FLD, we have first the presentation of 2 abstracts, which will be followed by a 30-minute session on Meet the Experts. We have all the experts on MASL-D here with us, and then we will have some discussion on the subject. So without wasting any time, can I request the first presenter for the abstract, and he is Dr. Arun Walson. So let me read out his, paper. His paper was Safety and Efficacy of Oral Semaglutide in Overweight Diabetic Patients with NAFLD and Interim Analysis. Over to you, Arun. Thank you.
Good morning, everybody. I bring greetings from my hospital, Amrita Hospital at Cochin. And I acknowledge all my co-workers without which this study would not have been possible. So, MASL-D or NAFLD is a big problem. 25% of the world population currently is afflicted with NAFLD. Studies say that 50% of in the urban population, urban Indians have NAFLD, and 5 to 7% have NASH or MASH. And 50 to 75% of obese people have NAFLD, 65% of diabetics have NAFLD, and more worryingly, NAFLD increases the CVD risk by 2.5 times and HCC by 10 times. So the problem is we don't have a gold standard treatment as on date. So the current, we have a lot of promising molecules, many entering new trials, many getting terminated abruptly, but everything, the mainstay of the treatment is achieving sustainable weight loss and lifestyle modification. But it's very difficult to attain weight loss, and even in people who've attained weight loss, they regain weight in no time. So GLP-1 receptor analogs are a pleiotropic set of molecules which have multiple effects on various systems, thereby reducing blood glucose and have favorable metabolic outcomes. So there were 2 studies published on one on MASL and one on the obesity, and they found that there was significant resolution of NASH without worsening of fibrosis, and percentage change of body weight and weight reduction in excess of 5% with injectable semaglutide. So then we thought that injectable drugs have its own problem and patients are not very keen on taking injections. And once semaglutide became approved for diabetes, we planned this study. So this is a prospective single-arm open-label pilot study conducted in South India, and we included obese diabetic adults with NAFLD, and we took a convenient sampling of 50. So the aim was to assess the efficacy and safety of oral semaglutide in overweight diabetic patients with MASL, and the key primary objective was mean change in liver stiffness measurement and CAP, and mean change in BMI, HbA1c, AST, and lipid profile. And we also studied treatment emergent side effects. So the inclusion criteria, as I mentioned, were adults with BMI more than 25, and we have either an imaging or liver biopsy diagnosis of MASLD and an ALT level of more than 50. And any patients who had documented anaphylaxis hypersensitivity, significant ethanol, pregnant or lactating mothers, and family history of medullary carcinoma thyroid were excluded. So this is a simple study design. Obese people, diabetic with MASLD, mean duration of diabetes of 7.8 years. We had 59 patients with a mean age of 50.4 and a male to female ratio of 1.6:1. We excluded 2 patients who subsequently underwent laparoscopic sleeve gastrectomy, 2 non-compliant to drug and 2 intolerant to drug. We did baseline labs, APRI, FIB4, and FibroScan, and included them in a dose escalation. The dose was convenience more than anything. We found that people were not tolerating more than 7 mg dose in our subset. So we started them off on 3 mg, and anybody who tolerated 3 mg for a week, we updated it to 7 mg. And we followed them for 24 weeks and repeated the same at the end of the study. So these were the comorbidities of the patients and the drugs. So the confounding drugs like saroglitazar, statin, vitamin E were stopped. Metformin, oral hypoglycemic agents were continued, and insulin was continued. And these were the comorbidities of the patients. They had significant, like expected, dyslipidemia, hypertension, CAD, and thyroid dysfunction. So the primary outcomes, there were significant change in APRI, liver stiffness measurements, and CAP. You can see in the graphic given here, in the LSM, in the CAP, and in the APRI score. Amongst the secondary outcome, there was significant difference in ALT levels from baseline. There was significant difference in body weight, BMI, and HbA1c in these patients at the end of the observation period. And also there was significant difference in cholesterol, LDL cholesterol, and triglyceride. And these were the treatment emergent effects, but none were led to stoppage of the drug. So the limitations of my study were that it's a single standard, open label. We did not do biopsy, and follow-up was for just 24 weeks. And in summary, I would like to say that oral semaglutide was safe, efficacious, and well tolerated in overweight diabetic patients with NAFLD. There was significant reduction in liver stiffness, CAP, BMI, ALT, and lipid profile. There were no significant treatment emergent adverse effect, and we need a randomized placebo-controlled trial with histological endpoints to be sure about the efficacy of the drug. Thank you.
Thank you, Arun. I think the paper is open for any questions and comments. Yes, Ajit. Yeah.
So have you tried to look out for lifestyle modifications, whether they have tried to improve upon their dietary habits, or they have started doing some physical activity? Because adjusting for these factors is also very important when somebody knows that he's suffering from fatigue.
Very important. We have also done that. So during the visit 2, the patient was seen by a dietitian. We had given a proper diet counseling and exercise counseling, and each week we had the dietitian and the exercise therapist call them on phone to check. So that was what we did. So the effects of exercises are always a confounding effect. I agree with you.
So you can think of adjusting during statistical analysis.
We did not adjust for the exercise level, and this is an interim analysis. We plan to do so.
Thank you.
Hi, good morning. Nicely done study. The issue is, in the long term, is going to be difficult to do a histology-based study with large numbers of patients given the environment. So maybe something you can think about is whether to do a randomized control study, but follow them out in a larger version to clinical outcomes or to non-invasive measures of cirrhosis, because several non-invasive tools now are actually pretty good at diagnosing cirrhosis. So if you take a group that clearly is not cirrhotic, and then you have a randomized controlled trial trying to see whether you're preventing cirrhosis, I think most clinicians will agree then that would be very clinically useful.
Thank you for that lovely insights. I will.
Arun, you said that you had an escalation of the dose as per the tolerance.
Yes, sir.
So can you tell us of all these 50 patients, how many tolerated 4 milligram versus 7 versus 14 mg?
Sir.
And also we know the GI side effects is the major issue with the GLP-1.
Yes, sir.
So how many in each dosage they had that?
Sir, so we started off. This was like a pragmatic observation that people who we started with 7 mg, once they're not tolerant, they don't take the drug further. So we found that giving 3 mg, kinds of get the patient confidence, and only 2 people were non-compliant. They were emergent side effects, but then predominantly GI. But once counseled, they were ready to continue taking the drug. So we gave 10 days of 3 mg, 7 to 10 days of 3 mg. Followed by 7 mg. We did not use the 14 mg dose because of intolerance in our population.
Okay, quickly, sir, Dr. Rao, and then another last
You
question.
said there was a change in the LSM, isn't it, after the end of the
Yes,
study?
sir.
Huh?
Yes, sir.
It was significant.
Yes, sir.
So within a short term, a change of an LSM depicts that it is only the inflammatory component is the one which has been decreasing.
Yes,
this has
sir.
been shown in HCV also.
Yes, sir.
So is there any short study, but still just wanted to know correlation between ALT decline and then LSM decline?
Yes, sir. So, sir, we have not analyzed that yet. We would do that, sir. This was just a interim analysis. We would be looking at that.
Apart from GI side effect, hair fall is one of the major issue with
Yes, sir.
semaglutide. Do you encounter with
No,
this?
we did not, sir. Only we did not encounter that, and we had used the CTCAE side effect profiling, and we did not find that, sir.
Thank you, Arun,
Thank you,
and congratulations for this wonderful work. Continue to keep doing the good work. Thank you.
Thank you, sir. Thank you.
So the next presenter is Dr. Deepangshi Agarwal from PGI Chandigarh, and she'll be presenting her paper on effectiveness of time-restricted intermittent fasting in patients with NAFLD, a randomized controlled trial. Deepangshi.
A very good morning to everyone. Today I am going to present the research work which was done in our Department of Hepatology at PGI Chandigarh. As we all know, the lifestyle interventions, including dietary interventions and physical exercise causing weight reduction, are mainstay treatment in NAFLD. Amongst dietary interventions, intermittent fasting is a recently highlighted concept, with 3 commonly practiced regimens being 5:2 fasting, alternate day fasting, and 16:8 time-restricted feeding. So how does fasting helps? Fasting leads to disruption of delayed hours of eating, and during those meal-free intervals, body restores the metabolic circadian rhythm. There is data that intermittent fasting causes weight reduction and improvement in glycemic control and dyslipidemic profile. However, data on the effectiveness of intermittent fasting in improving liver disease activity in patients with NAFLD is deficient. There are fewer previous studies which have studied 5:2 fasting and alternate day fasting in NAFLD. However, to the best of our knowledge, till date there is no study in time-restricted feeding on NAFLD patients. All the previous studies had a shorter duration of follow-up, only for 8 to 12 weeks. So our main aim was to compare the effectiveness of calorie restriction by intermittent fasting with standard calorie restriction in patients with NAFLD. This was an open-label randomized controlled trial conducted for a period of 1.5 years, with each patient being followed up for up to 6 months. Our study participants were NAFLD patients who were overweight or had class 1 or 2 obesity up to a maximum BMI of 35 with age between 18 to 70 years. They were non-cirrhotic, non-diabetic patients and were not receiving any pharmacotherapy for NASH or any weight loss drugs. So after screening for inclusion and exclusion criteria, all the patients were randomized and allocated into 2 groups, standard of care calorie restriction and intermittent fasting group in 1:1 ratio. Each study participant underwent a baseline physical assessment, all the blood investigations were sent, blood pressure recordings were made, and a baseline ultrasound and fibroscan were done. Also, for each participant individually, daily calorie requirement was calculated and they were advised 30% daily calorie restriction of the daily calorie requirement. However, in the SOC group, they had to consume those calories spanned over routine 3 meals throughout the day, whereas in intermittent fasting group, they had to consume those calories within a time frame window of 8 hours with a continuous fasting for 16 hours. They were allowed only clear liquids during those 16 hours, and standard exercise regimens were advised to both the groups. Our primary outcome was reduction in hepatic steatosis, inflammation, and fibrosis based on non-invasive methods. And our secondary outcomes were to look for reduction in body weight, BMI, central obesity, achievement of target weight reduction, and to look for improvement in the metabolic profile. This is the consort diagram. 273 patients attending liver clinic at PGI Chandigarh were screened over a period of 1 year, and based on our exclusion criteria, 205 were excluded, and finally 68 patients were enrolled. However, during the course of follow-up, 6 patients in each group had lost to follow-up, and lastly, 28 patients in each group completed follow-up and were included in the analysis. Coming to results, there were no significant differences in baseline characteristics of patients in both the groups, except for total cholesterol and LDL cholesterol, which was significantly higher in the intermittent fasting group at baseline. After analysis, we found that improvement in hepatic steatosis, both on ultrasound and fibroscan with controlled attenuation parameter, were significant in both the groups with no intergroup significant differences. However, intermittent fasting was better than standard of care calorie restriction in improving hepatic inflammation in terms of mean reduction in ALT levels and also percentage reduction in ALT levels, as a higher proportion of patients achieved more than 50% reduction in ALT in IF group. We also calculated the FAST score, and the mean reduction in FAST score was significant in both the groups. And post-intervention, the FAST score reduction that leading to increase in the proportion of patients with ruled out probability of NASH was significantly higher in IF group when compared to the SOC group. In hepatic fibrosis, the mean reduction in LSM on fibroscan was significant only in the intermittent fasting group and not in the SOC group, and a significantly higher proportion of patients achieved more than 20% reduction in intermittent fasting group and not in the SOC group. Also, we calculated all the non-invasive scores for hepatic fibrosis, that is EPRI, FIB4, and NFS, and significant reduction in all the scores were seen in both the groups, but a significantly higher proportion of patients in intermittent fasting group had reduction, so that leading to that they were ruled out of significant fibrosis and advanced fibrosis at the end of 6 months. Also, coming to secondary outcomes, both the dietary interventions had significant and similar reduction in body weight, BMI, and central obesity. However, the percentage weight reduction which was achieved in the IF group and the proportion of patients who achieved target weight reduction, which was 5 to 10% of the baseline, was significantly higher in IF group. And the proportion of obese patients who became non-obese at 6 months was significantly higher in the IF group. Lastly, amongst the metabolic profile, the mean reduction in fasting blood glucose, total cholesterol, and LDL levels was significant in IF group and not in the SOC group. And also, both the groups had significant improvement in hypertensive control without any intergroup differences. So this was our first randomized study to assess the effectiveness of intermittent fasting by 16:8 time-restricted feeding regimens conducted over a period of 6 months. Time-restricted feeding by 16:8 pattern is a practically more sustainable way of dietary intervention when compared to other methods of intermittent fasting, since in 5:2 fasting and alternate day fasting, due to severe calorie restriction on the fasting days, there is a higher tendency of severe binging on non-fast days. The two weight loss regimens were also equally effective in hepatic steatosis, but intermittent fasting was better in improving hepatic inflammation and fibrosis. And also, the intermittent fasting improves metabolic profile. Since this trial had a longer duration of follow-up, so the changes in liver stiffness on fibroscan can be justifiably correlated to actual change in hepatic fibrosis when compared to the previous studies who had shorter duration of follow-up. Lastly, I would like to acknowledge some limitations, since there was the self-reported dietary compliance by the patients, which could have led to reporting of inaccurate calorie consumption by the patients. The enrollment was temporarily hindered due to COVID-19 pandemic. Also, long-term adherence to time-restricted feeding is still unknown and requires studies with a longer duration of follow-up. Only non-invasive modalities to assess hepatic disease activity were studied in this study. Thank you.
Thank you, Deepakji. So the paper is open to any questions and comments. Yes, Dr. Ashish.
So what was the eventual calorie consumption in both the group after?
For each participant, we calculated daily calorie requirement according to 30-35 kilocalorie per kg per day.
So
And
that was planned. What was the eventual?
given eventually 20-25 kilocalorie per kg per day.
Both were
Both
equal.
the groups. Only difference was the time frame in which they had to consume the calories. In SOC group, they were consuming like normal routine daily meals from morning till night. However, in intermittent fasting, they had to consume within 8 hours, like 10 a.m. to 6 p.m. or 11 a.m. to 7 p.m., which was better suited for the patient.
So calorie consumption eventually was same, but
Same.
There was slight difference in, better outcome with the intermittent
Yes.
fasting. Thank you.
Yes, Professor Ernst.
Thank you very much. A really elegant study. Great. Congratulations on the work.
Thank you.
One thing I wanted to take exception to, you said that a limitation of the study was the use of non-invasive biomarkers. I think it's a strength. I think it's a really nice piece of work in that respect. I wonder, though, if you've had an opportunity to look at the individual patient level, at patients whose liver stiffness improved and, for example, had a fall in ALT or a fall in FIB4. I think that would be very interesting to look where they intersect in people.
Okay, we shall definitely look into it.
Yes, Dr. Arka. Dr. Sanya.
Bangshi, excellent work. Just one thing I wanted to know is, what was the compliance level in the intermittent fasting? Everybody completed the study? Was everybody compliant to the intermittent fasting, and did you ultimately, those who were not compliant, was this an intention to treat analysis, or have you excluded them?
The compliance rate was noted to be around 83%. As I earlier told, 6 patients in the fasting group as well as 6 patients in the SOC group were lost to follow-up. Patients were compliant to the both the dietary interventions equally.
Yeah, just to extend, that was actually part of my question. What measures were taken to, assess compliance other than the patient self-reported? Because, patient self-reporting is notoriously unreliable. Yes. And I think if there's a limitation in your study, that's probably the biggest one that I heard. Were the patients in one group called and with the same frequency by a study coordinator, or were they only seen during clinic visits, or what was the actual protocol?
Okay, so each participant in both the groups was followed up telephonically every fortnightly and physically every 3 monthly. Also, we took into confidence the patient's family members at every physical visit that the patient is following or the dietary advice or not. And the patient, we had a significant rapport with the patients. If the patient would themselves miss the diet, they will themselves report to me that I missed the diet today.
Thank you, Dipangshi, for that wonderful work. Congratulations. So we move on to the second section of this SIG, which is the section on Meet the Experts. And it's my privilege to invite the experts for this session, Professor Arun Sanyal, on the stage, Professor Meena Bansal, Professor Quentin Anstey, and Professor Jeff Lazaras. I will also request the panelists to be there on the first row, please. Dr. Varun Mehta, Dr. Deepika Kedia, Dr. Manish Mandrai, Dr. Sanjeev Kar, Dr. Ajit Badoria, Dr. Suvadeep Mitra, and Dr. Pratap Behra. So the format is, we have one moderator, Dr. Arka Dev from PGI Chandigarh Hepatology, and he would be taking us through maybe a case scenario, day-to-day case scenario, and the questions regarding the case scenario would first go maybe to the audience. Dr. Arka, is that right? And then maybe to the panelists first, and then you can have the expert's opinion on that case. Thank you, Dr. Arka.
Right. So first, I'll just give you the case summary. So this is a 47-year-old male. He's a resident of Jammu. He was referred for incidentally detected fatty liver on ultrasound and executive checkup. Otherwise, he is asymptomatic. He consumes alcohol around 10 to 20 grams per day. He's a non-smoker. There's no history of diabetes, hypertension, thyroid disorder, or other metabolic comorbidities. On examination, his anthropometry revealed a BMI of 22.5 kg per meter square, which is lean by Asian standards, an abdominal circumference of 98 centimeters, and a waist hip ratio of 1.04. So he did have central obesity, again by Indian standards. The pulse, the hemodynamic, he was hemodynamically stable. There was no pallor icterus, cyanosis, clubbing, etc. The liver was palpable 1 centimeters below the right costal margin with a span of 14 centimeters. Spleen was not palpable. There was no free fluid per abdomen, and the other systems were within normal limits. His complete blood count was within normal limits. His liver function tests revealed an elevated AST-ALT between 1 to 2 times of the upper limit, and the renal functions, electrolytes were normal. With respect to the metabolic and etiologic workup, his HbA1c was 5.3 with the fasting blood sugar levels of 94. The lipid profile, triglycerides and HDL were normal. Thyroid functions were normal. His HOMA-IR was 2.2, suggestive of early insulin resistance. Viral markers were negative. Autoimmune workup, including the antibodies and serum IgG, were within normal limits. IgA, TTG was negative. Ceruloplasmin was normal, and iron profile was normal. On imaging, the ultrasound revealed hepatomegaly along with grade 3 fatty liver. There were no other features of portal hypertension. APRI was 0.9 and FIB4 was 1.9. On FibroScan, the LSM was 8.9 and the CAP was 343. So the first question to the audience, I think we can have a show of hands or somebody can volunteer. We now know that there is this conundrum about the nomenclature of NAFLD. So where does our patient fit in? Does he fit into NAFLD? And by current standards, would he be fitting into MAFLD? Or by the recent Delphi consensus, MASLD, does he fit into MASLD?
Audience, please. 1, 2, 3. How many of our choice 1?
How many of you think that he falls into NAFLD? So I think we have got 4, 5 hands. How many of you think he fulfills the criteria of MAFLD? So again, 4, 5 hands. And what about MASLD? Right, so most of you feel that he would fit into MASLs. Can I have the comments of the panelists followed by the experts? Dr. Manish, please.
So actually with this new nomenclature, it's probably easy with the criteria. So he has one cardiometabolic risk factor of increased waist separation and abdominal circumference. So he fits in that young male. If in the spectrum of MASLD he has a dysfunction which is related to development of deposition of fat in the liver and insignificant alcohol intake. So if we go by the present nomenclature which has come, he fits exactly into MACL.
And would he fit into MAFLD?
Yes, because the FibroScan is also elevated. It is going into F2, F3. The cap is beyond 276. It's about 333.
If you look at the MAFLD criteria, what you find is that any patient, Dr. Varun, would you want to comment? Okay, so if you look at the MAFLD criteria, any patient with hepatic steatosis who is either overweight or obese or diabetic would automatically become MAFLD. But if they are lean, non-diabetic, then they would require an additional criteria to be called MAFLD. So this patient would not be fitting into MAFLD, but obviously he would be fitting into MASLD. So can I have the comments of the experts? Ajay sir, please.
He's drinking
we have the international.
He's drinking significant amount of alcohol. 20 grams is not good.
So he's drinking 10 to 20 grams of alcohol. So that would still be fitting into MASLD alone, not MET-LD. Ajay sir.
You know, we're just commenting that he only has really one metabolic risk factor, and it's a soft one, really. So certainly MASLD fits, but he does not have more than that would put him in anything else. And to Deepika's point, I mean, his alcohol consumption is low enough to be considered MASLD and not MET-ALD.
Yeah, I mean, there are several questions. You know, we can sit here and argue about case definitions all day long without resolving anything. But one is the guy really drinking 10 to 20 grams per day? He's an executive, and I know a lot of executives in India. I've yet to see anyone who only drinks 10 to 20 grams per day. So that's question number one. That's actually an important question, because given that everything else looks okay, a couple of things are a little worrisome. That is, platelet counts only 155,000. That caught my attention. That I would have expected it to be a little higher. The other is your liver stiffness is increased. And something we don't really talk about, let's just talk about the patient instead of that, which classification they fit into, is that if you took the same patient and did a fibroscan 3 times in a row, the degree of or on 2 different days with a different operator, the degree of variance is up to 30%, which means if you get a liver stiffness of 8.9, which is say 9, truth lies somewhere between 6 and 12. So you have to be sort of aware of that piece. I think maybe that's something we can talk about.
Yeah, sure. So I think the point he was trying to make was, and we analyzed our own data. Are you showing that data? Yes. So the applicability of these MAFLD and the MASL criteria in lean subjects. So this is what he's showing here. Please.
Yeah, the other piece is that the MASLD criteria, the metabolic criteria, it is designed to cast the net wide, so you don't leave anyone behind. Number 2 is it's aligned with the classic Alberti paper on metabolic syndrome. So it brings us sort of more in alignment with what our colleagues in diabetology are used to, thinking about.
Yeah, absolutely. I mean, just to come in on that one, really, I think when the MASL definitions were put together, it was about coming up with a structure that allows you to retain the best of the past. And what you want to avoid at all costs is a situation where the definition changes and all the cohort studies, all the work that's been done up to now ceases to be applicable. So MASL is very helpful in that sense. I mean, certainly in the European NAFLD registry, it was an over 98% overlap between the two, and I think that's a really important reassurance. It'll be interesting to see what your data is like in that respect now as well.
So basically what we found is that the lean patients with NAFLD, they would be underserved by the MAFLD. Almost more than 50% of those patients would be missed out because a large portion of them would not be diabetic, and then they would need an additional criteria to fulfill it. And that additional criteria includes HOMA-IR, HS, CRP, which are not done in routine evaluation of these NAFLD patients. Whereas the MASLD, with respect to the obesity, it takes into account both BMI and central obesity, which makes much more sense and makes it easier for us. So what is the relevance of central obesity in the sense that the definition of lean is currently based on BMI alone? So how many in the audience feel that central obesity should also be considered when we are defining what we call lean? So I think majority of the audience feels that that should be done. So can I have the panelist, Dr. Varun, maybe just tell us a little bit about the shortcomings of BMI and how central obesity would help?
Actually, the presence of central obesity means basically a dysregulated adipose tissue. Basically, central obesity has got a very high clinical correlation with the HOMA and with the dysregulated adipose tissue. So inclusion of central obesity in further definitions would definitely bring in more patients into the ambit of the lean NASH, and naturally these patients would be at the they should be more resourced to get a cardiometabolic risk factors actually sorted out in these patients.
So, ma'am.
Yeah, no, absolutely agree. I think part of the problem is not many people measure waist circumference in clinical practice. We don't. We need to start doing it, and we focus on this disease.
And ma'am, do you think these BMI cutoffs are kind of arbitrary? So like a BMI-based stratification should be abundant? Should we do away with this categorization of lean, overweight, obese, NAFLD, and then the common people, the general practitioners, they begin to feel that the lean may be less severe, overweight, obese. So a BMI-based stratification of the severity, that should be done away with?
So, you raise a very interesting issue because the BMI extends along a continuum, right? And so there is a risk of end organ disease that also goes along a continuum. And so these cutoffs were put because there was not like there was a very clean break between the risk scores as you go along, but people needed to create categories. So anytime you create categories of something that's a continuous variable, you create error around the boundaries of those categories, right? So what we really need is a metabolic risk score, a single number that if your metabolic risk score is below this, it's like a continuum where you go from a green zone to an orange zone to a red zone. So we don't unfortunately have a PCR for a metabolic risk score, but that's what we really need in the field rather than creating more categories of things.
Absolutely. Yes, sir.
There's another point. You might have patients who have a normal BMI and a normal waist height circumference. But if you actually subject them to some kind of impedance biometry or DEXA, it will be surprising that they still might have central obesity. So probably we will not be able to do away with BMI because BMI is an easily accessible score. And assessing central obesity, you'll actually require various techniques like DEXA and other things to assess. So that might become a problem for a normal clinical practice otherwise.
So,
yeah, one more problem with the waist circumference, because it's sometimes very difficult to measure. It's not uniform. If the patient is bloated, had just some meal which leads to bloating also, and also some people are not measuring right.
Correct.
Yes, some of them are measuring just above the iliac crest, some of them measuring over the umbilicus. So that leads to variation.
Actually speaking, visceral fat is also one of the direct correlates with the sarcopenia, and sarcopenia is in itself a good marker of muscle and the adipose tissue dysregulation, which is the basically central disease in all these patients.
Arun?
Just a point, isn't it, I don't think we'd be able to do it with BMI. Isn't it more logical to get lean, normal, overweight, metabolically good, bad, and good, bad? I think that's the way we should be seeing at these patients.
Can I just mention here, the ultrasound has shown the potential is coarse, but your liver stiffness does not match with that. So I think we need to repeat that, because why should it be less than coarse?
Liver
Usually is in cirrhotic patients.
No, coarse can occur in hepatitis. There's no irregular outline or anything to suggest frank cirrhosis.
Another thing is his LDL is very high.
Yeah.
And I think he's drinking quite significant amount of alcohol, because 20 grams is 60 ml. So, if the patient is drinking 60 ml of whiskey every day, that is 20 grams. You really seriously think that a patient is telling you the truth and just drinking 160 ml drink. So that could be contributing to his liver disease, not per se only his BMI and everything. And also the fact that his platelet counts, etc. low. So that could be a big element of alcoholic liver disease also here.
Yeah, so we'll discuss about the mild to moderate alcohol intake.
Will he then fit into MET ALD, or it is still?
I mean, as per the definitions, it is not fitting, because in a male patient you would want 210 to I believe 350 grams per week.
I think we should not underestimate the abdominal circumference. I think there are already studies are there which have shown that the waist circumference correlation between the visceral obesity. DEXA is impractical, of course, for research point of view, if you want to compare all the three things, but at the ground level, waist circumference should not be deleted.
Right, so again, some data from our institute, what we found is that BMI does not correlate with central obesity with waist circumference. And what is more important is that the liver disease severity, particularly advanced fibrosis as inferred from non-invasive parameters, central obesity is an independent predictor for that, for advanced fibrosis in lean patients. So coming to the severity of lean NAFLD, MASLD, whatever it is, so I like the House's opinion about how severe do they think the metabolic dysfunction in lean patients is vis-a-vis non-lean patients. So how many of you think that it is less severe? Can we have a show of hands? That the metabolic dysfunction in lean NAFLD patients is less severe than that in non-lean patients. So again, I think quite a few would agree. And what about the severity of liver disease? Do we think that the severity of liver disease in lean patients is less severe than that in non-lean patients? So again, I can just see 2-3 hands. And clinical outcomes, are the clinical outcomes less severe in these lean patients compared to their non-lean counterparts? So can I have some of the panelists? Madam?
I think they have more cardiovascular disease and increased mortality compared to obese patients, the lean patients. So I think we have to, apart from looking at the liver, we must make sure that we are looking at the cardiovascular system as well.
Shubhra, since you have done some work on the severity of the liver disease per se with histology and non-invasive, can we have your comments?
So, histologically, the non-lean patients have a less severe histology in terms of steatosis, in terms of fibrosis, and in terms of NASCR and score. So that's what the meta-analysis suggests also, and that's what our experience is.
Okay, can I have...
I think there's some variability from region of world to region of world. There are, like, for example, we published a study looking at a small cohort from Brazil, US, France, and India. And we found in general that the histology was milder in the cohort from India. That could be total selection bias based on, just the place where the data came from. But for example, matched for all other metabolic parameters, in Brazil, they had the most severe, metabolic dysfunction by all biochemical parameters, as well as by the severity of the histology. So, there are factors like microbiome, diet, gene-environment interactions. All of these play into things. So the danger of making a wide sweeping statement that people with lean have more disease or less disease is that at an individual patient level, when you're seeing them in clinic, you're likely to translate that and saying that, oh, you're lean, you probably don't have too much disease. You really don't know. You have to evaluate each patient like you really don't know, and you need to figure that out.
Yeah, just to pick up on that a little bit further, the part of the discussion we're not covering yet is genetic variation. So, and that is pervasive, and I think Arun was touching on that with those different countries and so on. So we need to bear in mind that, carriage of PMPLA3 has substantial interethnic variation, and a number of the others, HSD17, B13, and so on. So when we're faced with a lean patient, that's something else we need to factor in alongside their metabolic dysfunction, I'd suggest. It isn't part of our routine practice yet, but maybe in a year or two.
And I would add environmental factors as well, such as smoking, inhalation of substances, PCBs, lead, cadmium. All of these are cofactors in fibrosis progression as well. And oftentimes people who smoke are lean.
So you want to make any comment? So basically with the metabolic syndrome risk factors, I think what is important is that these patients have an intermediate phenotype. So even though the metabolic comorbidities, insulin resistance, etc., would be less severe than that in non-lean patients, but it would be more severe than that in control groups, so patients without NAFLD. So it lies somewhere in the middle. And with respect to the histologic data, even though the meta-analysis says that it is less severe, what we must understand is that the data is very heterogeneous, as we can see in this table. The numbers are very small. Some studies have incorporated overweight into lean patients and then called it lean. Some have frankly used wrong cutoffs, like the Go Asia study has used a BMI cutoff of 25, even though it has been used, it's an Asian study. But most important point, I believe that age could be a very important confounding factor. Because if we look at this table, everything that is written in bold is a significant difference, whereas everything that is non-bold is no difference. So those studies that have shown a more significant liver disease, there the patients with lean NAFLD were actually younger. Whereas those studies where there is no difference in the age, they do not find any difference. So we know that with age, the liver disease severity, the fibrosis, etc., would worsen. So it could be possible that our lean NAFLD patients are presenting to us late, or it could be just selection bias because of the common perception that patients with lean are less severe. So we are looking at them later. Okay, so we know that NAFLD is a big public health problem. So who should be screened for NAFLD? How many of you feel that all obese patients should be screened for NAFLD in the house? So I think majority would agree that all obese patients need to be screened. How many of you feel that all diabetics need to be screened? So again, the majority feel the same. Sir, what do you feel about? I think most of the guidelines would agree that all diabetics need to be screened with NAFLD, but what about patients who are obese? In the sense that I'll say that the INASL, the Indian guidelines, we have suggested that all obese and all diabetics should be screened. So the ASLD differs from that. And what's your take on that?
Yeah, I mean, I think, like you said, diabetes is clear. That's not even up for discussion. I think with obesity, also with a simple test, screening is quite easy. You want a rule out approach. You just don't want to miss people who have advanced liver disease, and that's what most of the algorithms are aiming to do.
The current ASLD guidelines actually do recommend screening. I think it has shifted. The current ASLD guidelines do recommend screening.
So all obese patients with metabolic comorbid, with additional medical related factors. So
I think one issue is, while it may seem very obvious that everyone with diabetes should be screened, it may not be so obvious to the endocrinologists. And then the other issue is if we're going to screen everyone who's overweight or obese, who's going to do the screening and what tests are they going to use? And if we rule them in, will the hepatology departments be able to receive what I think will be so many people? So I'm not opposed to that approach. I favor it, but I think that operationally there's a lot to consider.
So I would like Dr. Ajit's comment also, because NAFLD is integrated into our national program, and there the initial screening step is not with BMI, but with waist circumference. So sir, if we could have your comments.
So just to share with you all, like India, we have integrated NAFLD into the national program for non-communicable disease. And here I agree with Jeff that it's not possible for hepatologists to do that screening. So this is taken up to the peripheral health care worker level. So whatever we have talked about, so we are including a form which is known as CBAC, which is community-based assessment checklist, which includes 6 criteria. One is age, second is waist circumference. Everybody mentioned that's very important. Third is smokeless tobacco or any kind of tobacco. Fourth is alcohol. Fifth is family history of diabetes, hypertension, and physical activity. So, and they are giving one score to the peripheral health workers, so it becomes easy for them to understand and calculate that score. And if the score is more than 4, then they are referred to medical officer for further evaluation with ultrasound or whatever, or liver function test which is available. So I think screening, and we are screening all who are aged more than 30 years. So in our guidelines, more than 30 years, peripheral health workers should screen all those adults and then refer to medical officer if it is required.
I think that's a brilliant approach. My clinic is in the community and we do something similar. It's almost a syndromic approach. It's self-report and we will miss some people, but we can't possibly screen everyone in the community at this stage. And that's in Spain.
Yeah, I really want to congratulate you and the entire community here in India for being the world's leaders in taking this on as a public health priority. And clearly the way you're approaching is the right way to go. If anything, I would say, think about maybe also a one-time evaluation at the beginning of adolescence, because the ultimate goal is to catch the metabolic ill health at a point where the end organs are still intact. Once you have a stiff artery and you're hypertensive, you've already lost the game. It's like coming in to start the game when you're 3 down, So it's, I think, eventually going to be very important to do it maybe once in childhood, once when you enter, the workforce, and then one at maybe age 30 or 40 or something. But that's just a construct I have in my head. But maybe that's something worth talking about.
Right, Dr. Sane, this is called as a public health approach with different levels of prevention. So like we had a training for policemen yesterday. So that was a good approach of a primordial prevention where we feel like they are not into any risk factors. Some might be in risk factors, that is primary prevention. So not getting these people into risk factors, that is a level of prevention which we are missing it. So when we talk about screening, it's a secondary level of prevention where we want to pick up them early. But I think we should start working in pre-pathogenesis phase where we can prevent coming up emergence of the risk factors and emergence of the disease.
I just want to pick up on what you said, Arun. I mean, this is really forward thinking to have put this into place. And of course, although we're all focused on fatty liver disease here, the benefits will be cardiovascular and affect multimorbidity. Could you speak a little bit to what percentage of the people screened then go through to referral to a medical officer? Is it an overwhelming tsunami? Is it a manageable number? How does it work in your experience so far?
So it's a program which is in a very initial stage. So right now we are into the process of training, building the capacity of peripheral health workers so that they start using, understanding the fatty liver also. So they're using that CBEC form for diabetes and hypertension from last around, I'd say 4-5 years. And for diabetes and hypertension, the plan is to screen all who are more than 30 years and then refer. So it's something which comes up with time. It's not that all people, they are screened at one time and then referred. So it is like a process which is ongoing, and they have to screen all more than 30 years once every year. So the target for a peripheral health worker is to screen at least once every year and then repeat it again next year and then refer if there is somebody who needs care.
Okay, we just wrap up in next 4 minutes. Yeah, sure.
So, sir, should I move on? Right. So I think we skip this because this is obvious. This is the more dicey thing, the management of these patients with normal BMI. So how lifestyle intervention should be working. So I want the opinion of the house. How many of you think that they should be given dietary modifications, particularly with respect to calorie restriction? So I think everybody in the house says that these patients should get calorie restriction. Professor Sanyal, where the lean patients should be given calorie restriction.
Yeah, I do agree. But I think, you guys are oversimplifying. Yes, it's caloric restriction is very important, but you have to maintain muscle mass. And something also, there are several caveats to this weight loss. In your older patient, this is maybe particularly important. For every 10 pounds weight you lose, 7 pounds is fat and 3 pounds is muscle and bone and other things. For older patients above 60, you get a disproportionate amount of bone loss and muscle loss. And so you have to include resistance exercise, some other things to make sure that you're not getting people into trouble. The older patients are also more likely to have more significant fibrosis than younger patients. And we've seen from several clinical trials that overzealous weight loss attempts in the more advanced patient can tip a patient into decompensation. So I think particularly for this audience, which is a hepatology audience, you really have to be aware of all of those caveats as you're talking to your colleagues in endocrinology.
Absolutely. I mean, I think you've really got to stratify again. It isn't a one size fits all, just as we're recognizing that there are different categories of patient with fatty liver. I would very much change my lifestyle management to focus more on activity and exercise and potentially resistance exercise in these individuals to improve their muscle insulin sensitivity and so on. Slightly less focus on, somebody doesn't like what I said, slightly less focus on getting weight off in the absolute sense.
Right, and this patient was also consuming alcohol. So what's the opinion of the house on consumption of mild alcohol use in patients who have got fatty liver? Particularly in a patient who has also got significant fibrosis. So how many of you think that we know alcohol? So I think most in the audience agrees with that. And I think our experts would also agree with it.
Yeah, as soon as you have any fibrosis.
So alcohol's out.
He does have elevated AST/ALT. He has fibrosis.
Yeah, so no alcohol.
No alcohol.
So what about the weight loss target? Should we, I mean, part of it has already been discussed with the experts that weight loss, all right, but we have to maintain the muscle mass or maybe increase the muscle mass. So I think the difference over here would be INASL does not recommend a weight loss. ASLD does not specifically mention about weight loss in these lean patients. The AGA actually recommends a lower degree of weight loss of 3 to 5% based on the Hong Kong RCT. So any comments from the experts about this? So this is the RCT, and what they basically found is that there is kind of a dose-response relationship of weight loss with remission of NAFLD even in non-obese patients. The degree of weight loss required would be lower. So the AGA recommends a 3 to 5% weight loss as opposed to maybe a 7 to 10% weight loss in the non-lean patients. So any specific comments?
Well, I think the weight loss, it depends on where you start. So obviously, if you're a lean patient, you probably don't need a 20% weight loss. But if you're 300 pounds, and there are people in India who are, I was at the airport, so I was early at the airport, so I was entertaining myself with doing a NAFLD's prediction score on everybody walking by. So there were plenty of people who met US criteria for significant weight. So I think you have the full spectrum in India, right? And so you have to individualize. the degree of weight loss. Metabolic benefits occur with only 5% weight loss. But whether you can prevent the disease from progressing to cirrhosis, I think that's a very much an open question. And that's the reason why the ASLD balked at putting a specific number.
So I think our time is up, but if you could just take 1 minute, just do you think our patient merits pharmacotherapy? How many in the audience thinks that our patient who has got an LSM of 8.9 needs NASH specific pharmacotherapy? So I think we have a divided opinion on that.
Yeah,
So,
based
ma'am?
on the one fibrous, I mean, we're not even sure he has stage 2 fibrosis. I think he's more of an F1 right now. I'd probably monitor with these other interventions and follow him longitudinally over time.
Right. So, Ajay sir would like to comment on that.
Not really. The only thing is, if it continues to have, in spite of lifestyle interventions, it continues to have significant fibrosis, then we do take a decision to put him on a drug which we have, other than the lifestyle.
Yeah, sure. Like if his liver stiffness goes to 10, something like that, stage 2 fibrosis, then for sure.
Well, I noticed that his LDL cholesterol was 194 and nobody talked about it.
Yeah.
That's very bothersome. That's going to kill him before all this conversation you're having about the liver is going to get him. And so you may want to pay attention to that. And because, you have drugs approved for NASH that also are good for dyslipidemia in this country. So that may be something.
The Saro works for dyslipidemia as well, and this guy had dyslipidemia. So I think he was put on Saro.
Yeah, he was put on Saro as part of a non-lean trial, and then these were the parameters. Thank you all for a fantastic discussion.
Thank you, Dr. Aka, and thank you all of you, I think, for making it such an interactive and wonderful session. So please join back. Thank you all, and thank you all the panelists for this. Thank you.
I request our chairperson to please join us on stage. Dr. P.N. Rao, AIG Hyderabad. Professor S.P. Singh, President INASL, Chairman of Kalinga Gastrology Foundation. Professor Dr. Ajay Duseja, Secretary General INASL, Professor and Head of PGIMER, Chandigarh. We are about to begin with the Session 1 Dr. D.V. Datta Memorial Oration. Everyone is requested to join back inside the hall. Requesting our chairperson again to please join us on stage. Dr. P.N. Rao, AIG Hyderabad. Professor S.P. Singh, President INASL, Chairman of Kalinga Gastrology Foundation. Professor Dr. Ajay Duseja, Secretary General INASL, Professor and Head of PGIMER, Chandigarh.
1975 and 76, whether you would want to call it as my past glory or a history, because that sees the research potential of Professor Datta. I happen to be a senior resident, just passed out by an MD. I was pushed into the cath lab on every Friday, which used to be used by the cardiologist. And 1975-76, we have done HVPGs, blood flow studies by the indocyanine green. Many of the interventional procedures like a functional hepatogram, inferior venochogram, I think Patrick and then other people will share with me. And that was the research potential of Professor D.V. Datta. Over to you, Dr. Ajay, please.
Can we get the door closed, Sonal? Everybody in, yeah. So on behalf of the Governing Council of INASL, we welcome you all to this, very prestigious Dr. D.V. Datta Memorial Oration. Something about Dr. D.V. Datta, on whose memory, this oration was instituted. He was born on 31st of May, 1934. He graduated in medicine from GR Medical College, Gwalior, Madhya Pradesh in April 1958. He obtained his doctorate in medicine MD from Wickham University 1961. He then went to England, where he worked as assistant lecturer in medicine at the Royal Free Hospital School of Medicine, UK, and pursued research at the University of London. He was awarded the degree of Doctor of Philosophy of that university in 1964. He then went on to United States and worked as a research fellow at Harvard Medical School, Boston, and he was then selected as assistant professor of experimental medicine at Postgraduate Institute of Medical Education and Research, PGI, Chandigarh. And he joined the institute on 22nd February 1967. In 69, he was selected as assistant professor of medicine at the institute, and he was appointed as the associate professor of hepatic diseases in August 1971. He was the founder head of the Department of Hepatology at the institute, and his work in the department received national and international recognition. So, within a short period of his journey at the institute, Dr. Datta earned a name for himself, and as an eminent hepatologist, an excellent research worker, and as a devoted physician. With his qualities of head and heart, he endeared himself to his students and colleagues, and unfortunately, he was snatched away from us by the cruel hands of death on 13th May 1981 at an early age of 47 years. In Dr. Datta's death, the institute lost a medical scientist, the country lost a medical scientist and a hepatologist who had already made a mark in the specialty of national and international levels. Some of the work, we know is the work on arsenic, non-cirrhotic fibrosis, and various other areas. Professor Datta is survived by his wife, Dr. Mrs. Usha Datta, who retired as head of the Department of Immunopathology at PGI Chandigarh. His eldest son, Mr. Deepak, is a mechanical engineer, and Dr. Rakesh is a brigadier in the army. And both their sons are happily married, and they have 3 and 2 children. So, to perpetuate Dr. Datta's memory, the Indian National Association for Study of the Liver, INASL, decided to institute an oration and invite an outstanding scientist to deliver an oration on a subject pertaining to the field of hepatology. And some of the earlier recipients of this, oration include Dr. G.N. Vyas, to Dr. Sheila Sherlock, Roger William, N.C. Nayak, Dr. Billing, Blandis, B.N. Tandon, Kunio Okuda, to name few. So for this year, and to introduce the orator for this year, I'll request our president, Dr. S.P. Singh, to come.
Good morning. It's my proud privilege to introduce the orator of this very important named oration of INASL. Of course, the orator needs no introduction. He is none other than Professor Rajiv Jalan. Professor Rajiv Jalan is an illustrious son of a great father. His father was a very popular gastroenterologist in this part of the world, which includes Bangladesh, Bengal, Orissa, Bihar. And we always, read East, any disease, there are commentaries, there are East meets West. He is East and West, where East has met West. He is a clinician, scientist par excellence. He is professor of hepatology at UCL and is also an honorary consultant at the Royal Free Hospital. He is also the scientific director of the EFCLIF and the previous editor-in-chief of Journal of Hepatology. He took the journal to great heights. It's the #1 hepatology journal in the world today. His main interests are understanding the molecular mechanisms underlying the pathogenesis of organ dysfunction and liver failure, and using the knowledge to develop new therapies. His research has led to discovery of important therapeutic approaches, especially in the field of ACLF. He's got a large number of publications. Perhaps it's around more than 500 with an H index of 110. So, ladies and gentlemen, please give Professor Rajiv Jalan a big hand. Welcome, Professor Rajiv Jalan. The floor is all yours.
Well, first of all, thank you very much to INASL and Professor Rao, Professor Desaja, Professor Singh, and all of you for this very, very kind invitation. When I received this invitation, my thinking was that Professor Datta was indeed an old man. And I was really struck to see that he died at a very, very young age, having accomplished as much as he had done. So his sort of days must have been hundreds of days. Within a matter of a month, he must have done so much work. And I was really struck by his early work, which is really in relation to non-cirrhotic portal fibrosis. And Abhijit Chaudhary, who's probably here, shared a lot of his papers with me, which was the subject of my reading on the flight here. So thank you again for this very kind invitation, a great honor to me, and I'm really, really touched by Professor Singh mentioning my father in this audience. So I'm going to talk about the subject which is very close to my heart, which is acute and chronic liver failure. I think it's truly a time that I think we can start to think about reducing deaths from this terrible disease condition. And I hope that at the end of this talk, you'll believe that there are huge advances already being made, and we'll certainly have the possibilities of doing something around this. And here are my disclosures, and these are all related to discoveries that we have made at UCL and are now in various stages of clinical trials as we are dealing with it as we move forward. So it's a disease with very, very high unmet need. There are nearly 10 million cases per year of decompensated cirrhosis, and it is really amongst patients with decompensated cirrhosis that ACLF occurs. And really, if you look at that number, it's pretty frightening that nearly 2 million patients die from this advanced decompensated cirrhosis, a lot of them from acute and chronic liver failure each year. And if you put that into the context of the amount of work that's been done with COVID, it brings the whole story into, puts it into context. And really speaking, it's really amazing that there is not very much going on. We have no drugs, we have no devices, we have no treatment modalities for this population of patients. And I would encourage the people that are funding liver diseases to seriously think about what we can do in order to modify this disease condition. This is what I'm going to talk a little bit about today. I'm not going to dwell too much on the controversy around diagnosis and prognosis. Suffice it to say that I'll focus on using the Easel-Cliff criteria in terms of my discussions. We'll talk a little bit very briefly about the pathophysiology, which I'll detail in another talk during this meeting. We'll talk a little bit about why we have not had successful trials of different agents in this situation. Talk then about design of ongoing trials, and then end with showing you that following the discovery of this syndrome, what impact this is having, and hopefully convince you that it's worth thinking about and working on as we move forward. So for those of you who are not clinicians, this syndrome occurs in relatively well patients. And here is an accountant who was one of my early patients who was completely well with alcoholic cirrhosis. He was drinking 1 or 2 units of alcohol each day, but leading a normal life. 5 years after diagnosis, he presented to us with an episode of acute decompensation, had ascites, was jaundiced, and he was admitted to the hospital following an episode of pneumonia. So ordinary pneumonia for which he received antibiotics, but within a matter of 5 days, progresses to development of multi-organ failure, and he dies 5 days later. So completely well to dead in a matter of a few days. And this is the typical feature that you see in this population: short period of deterioration, altered response to injury, and very high risk of death from multi-organ failure. So what does he have? And the Piro concept, I think, allows you to look at this a little bit. So he's got alcohol-related cirrhosis. We knew that. His precipitating event in this situation, which is the injury he had, was an episode of pneumonia and infection. His response was occurrence of inflammation, develops multi-organ failure, and dies. And I think it sort of helps you frame the context of where this patient is in a clinical context. And I'm not going to dwell on it too much because you probably know it already. But I think a huge advance in the whole field was really made by the Konark study, which came up with the first diagnostic criteria based on objective data. And I think there are a few points to make here. The first was that this syndrome is not a liver disease, it's a multi-organ disease, because the failure of any organ, liver, kidneys, brain, coagulation, circulation, or respiration, was associated with an increased risk of death. They're independently associated with risk of death, 28-day mortality of greater than 15%. And the second point to make here was that the failure of organs, and it's not surprising, the failure of one or more organs was associated with increased risk of death. And I think it's important to note that if you can see here, the risk of death is absolutely enormous. If two of these organs fail according to these criteria, here, the risk of death at 28 days is 32%. If three or more organs fail, within 28 days, nearly 68 to 90% of these people will die. And this is in a patient who is relatively well when they are outside the hospital and when they're presenting to you. Even with one organ failure, the risk of death, as you can see, is between 18 and 27%. So fundamentally, extremely important to understand, because if this patient does not develop organ failure, then the risk of death is very, very low, about 5%. So the occurrence of organ failure is critical in defining the prognosis of this particular patient. And I think it'd be important that to acknowledge that this is not just European data, but it's been shown everywhere around the world, that on admission, nearly 30% patients will have this syndrome. Another 10% will develop it during hospitalization. Here's a 90-day, 28-day mortality, as you can see, nearly 30% across the world, that color-coded here. 90-day mortality of about 50%, dreadful syndrome. And what is again shown is that if they don't have ACLF, the risk of death is very low. So therefore, what it allows you to do is to risk stratify this acutely deteriorating patient into those that are likely to do well, those are likely to do badly. But of course, the critical issue will be in terms of what happens to these people when they're admitted to the hospital. And I think this gives us a ray of hope. And this is really important data from a combination of 3 agnostic studies done by the E.F. Cliff. And what it shows very nicely is that if a patient who is starting with ACLF goes to no ACLF, the risk of death is like that of a patient with no ACLF. So if, let's say, if you start with ACLF3, as suggested, the risk of death is nearly 90%. If you change them to no ACLF, the risk of death is very low. Same thing with the ACLF2. If they remain in ACLF2, the risk of death is nearly 40%. But if you turn them back within a 7-day, 10-day time frame to no ACLF, the risk of death is very low. So there is a degree of reversibility that is present. And the question is whether we can enhance that to allow for the liver to regenerate, for the liver to recover. And this is really, really important. The central slide in the whole slide deck, that this is not a death sentence, that there is a potential for reversibility. And I think that identifying this reversibility and being able to intervene to do something about it is probably going to give us an opportunity to do something for these patients now and in the future. And I think, again, this is the INASL guidelines that was recently published. And this is really based on the data that I've already shown you, and says that organ failures, as identified by these criteria, should be used for the diagnosis of ACLF. The failure of one or more of these 6 organ systems should be used to define the severity, and the risk of 28-day mortality in a patient with ACLF should be assessed sequentially using the criteria that are defined, because the risk of death is not fixed. It changes with your intervention in this patient population, either for the worse. If you start with no ACLF, you develop ACLF3, the risk of death is like that of ACLF3. So there are opportunities to intervene in this patient population at every different stage. This is a complex slide which is based around the 3 studies, which is Konark, PREDICT, and now the recently published Aclara study. And what this shows is this, that is, cirrhosis and its complications are not stages of disease, which has been suggested by some previous investigators. It is a continuum. That is, a patient with cirrhosis can develop acute deterioration. Our patient had an infection. He developed pre-ACLF when he came into the hospital, rapidly progressed to ACLF, and unfortunately died. But many of these patients will recover. They'll go home. Either they will have further decompensation and enter this cycle. And so therefore, our strategy for the management of this patient, which is going to be the bulk of my talk today, is really based around primary prophylaxis. And our whole point up here is to prevent the occurrence of acute decompensation. In the centerpiece here, which is a 3-month time frame, is really treatment of the acute event. In ACLF patients, a 28-day, and the endpoints here is we need to aim to resolve ACLF in patients with ACLF, improve their survival, and of course, try and do it as cheaply as we can. In patients without ACLF, that is up here, our strategy is to resolve the complication, prevent the occurrence of ACLF, improve their survival at a reasonable cost. In the patient that gets better, we need to start thinking about secondary prophylaxis. So using this continuum idea, we can start to think about this intervening in this patient population at the different stages. So what I've shown you is 2 things. We can risk stratify, and within this population, depending upon where they are in the continuum, we can make some sort of view about how we intervene with them and what is the endpoint for any of our intervention. And I'll be using this to describe the story. But of course, if you're going to develop new treatments, what you need to do is to understand what is it that you're trying to treat. So you need to understand the pathobiology of the disease so you can develop new interventions. And this is a very simple slide, which is based upon many, many data generated by us and by many of you in the audience, and shows one thing which is very clear. That is, as you move from compensated cirrhosis, this is David in the, at home. This is when he comes into the hospital with acute decompensation. This is when he has ACLF. Whichever way you choose to look at it, whatever your PET cytokine, this is what you see. That is, there is an increasing severity of systemic inflammation. But it's not to say that interacting with this inflammation using an anti-cytokine is going to treat this patient population, because the story is a little bit more complex. But this patient has, when they develop ACLF, has what we call cirrhosis-associated immune dysfunction, which indicates that depending upon where you are in this paradigm of compensated cirrhosis, decompensated cirrhosis, or ACLF, although there is this feature of increasing systemic inflammation, what you also have is progressive increase in the risk of infection, because the ability to deal with bacteria is significantly limited. So as you can see here, very marked anti-inflammatory situation in this patient population. So if you take a patient with ACLF, give them an anti-cytokine such as anti-TNF, which is what we did in the early 2000s, you're going to kill this patient. So fundamentally, what you're dealing with is a very markedly abnormal immune response. I don't have the time to show you the data that leads to this hypothetical slide, and hopefully I'll talk about it later in the meeting. Here is systemic inflammation. But what does this systemic inflammation do is induce metabolic failure, endothelial dysfunction, organ immunopathology, which leads to multi-organ failure. But of course, these patients down here are pretty sick. They've got ACLF grade 2 or 3. So you have opportunities to intervene if you're able to find what is the mechanism that leads to the development of this systemic inflammation. And that gives you a paradigm to develop new therapies. And this is what I'm going to focus on here, is to show you the work that we've been doing over the last 10, 15 years, is to see how this landscape is changing, where we have new targets. For instance, we can target DAMPs and PAMPs. We can target the gut in terms of translocation. We can target ammonia. We can target regeneration and inflammation. And we can target this patient that is in the ICU. And finally, of course, liver transplantation. So this is what I hope to show you in the next slides. But before going there, it is important to understand that we are working in a syndrome that's associated with many, many, many failures. And the first point here is that in order to make any new therapy for this particular patient population, what you have to do is to make sure that your intensive care management is appropriate. And you have to agree how you're going to manage these people, when you're going to transplant them, what are you going to use for monitoring, what antibiotics you'll use, when you'll filter them, et cetera, et cetera, et cetera. So your standard of care has got to be appropriate if you're going to impact on the outcome of this patient population. And I'll show you a few instances, and this is data from the recently published ACLARA study. And this is showed really for the first time this point that if you don't manage these patients appropriately, there'll be increased risk of death, because one of the independent predictors of mortality in this study, which is like the Konark study, except done in Latin America, showed that where the patient was admitted, whether the public hospital or private hospital, was an independent predictor of a risk of death. So your standard of care has got to be appropriate. There are many, many, many failures here. As you can see, that's MARS, the relief trial, no significant difference in mortality. That's the ELAD trial, which includes hepatocytes in the extracorporeal circuit, nothing. That is alcoholic hepatitis using steroids. Again, no difference in outcome. This is a large study that we did at UCL, albumin in a randomized clinical trial in acutely decompensated patients, no significant difference in all-cause mortality, infection, kidney dysfunction, or what have you. The recently published GRAFT study, which is using GCSF for the treatment of patients with ACLF flat lines. You know, this is, and I can go on and on and on. I've shown you a few slides. And I think it's important to think about why is it that these studies have been so negative? Is it because the definitions and stratification are not applied consistently? Did the difference in the standard of care confound the outcomes? Were the interventions used not good enough to tackle this multi-organ disease? And was the choice of these endpoints as survival too difficult given the complexity of the disease condition? Is mortality the only endpoint, or should we be thinking about other things? And therefore, we need to think about whether resolution of ACLF may be the first endpoint that we should be thinking about. So I'm going to talk a little bit now about the different drugs and devices. I'm a little bit hampered, as I can see, for time. I'd prepared for 30 minutes. I've got 2 minutes left. Will I have 5 or 7 minutes more? So here is ornithine phenylactate, which is one of the first drugs that we discovered at UCL. It really combines ornithine, which drives production of glutamine, and phenylactate, which is used for treatment of urea cycle enzyme disorders, removes ammonia permanently. So this is a study that was done in the US predominantly, and is a phase 2B trial. What it showed was that in the primary of 230 patients randomized, it didn't hit its primary endpoint, which was time to resolution of hepatic encephalopathy. But if you take out patients that were not hyperammonemic, then this was statistically significant. And this has provided alignment with the FDA, where they've allowed for the provision of this trial, where the primary endpoint is time to improvement of HE, will require 400 patients randomized 1:1 with ornithine phenylalanine intravenously versus placebo. And hopefully this will give an outcome. There are two important points to make here. That you've got alignment with the FDA with time to improvement of hepatic encephalopathy as an endpoint. It gives you a little ray of hope that other drugs that we developed may get these sort of endpoints, which is not necessarily survival. But of course, we need to think about this carefully. The second thing I want to talk briefly about, I'm just going to show you some headlights. So this is a liver dialysis machine that we built, which has two filters. The first filter exchanges albumin. Albumin, as you know, in ACLF is completely destroyed. It doesn't work. And this oxidized albumin is also deleterious because it induces inflammatory response. The second filter is what takes out DAMPs and PAMPs, and I referred to in my previous session that drives systemic inflammation. And we were very happy to see that the results of this trial, which was a randomized clinical trial in 30 patients who were treated for 3 to 5 days, the primary endpoint was read 10 days after the patient was included, showed that the patients that received the treatment resolved their ACLF within 3 days, 3 sessions, and in nearly twice the number of patients compared with the control. Really the first use of pathophysiologic biomarkers to develop a new device and use the criteria in order to stratify patients for therapy. But what was really pleasing to see was that all these pathophysiologic mechanisms that I've alluded to, the removal of DAMPs and PAMPs, inflammatory markers, cell signaling using the plasma of the patient's ligands for PAMPs and DAMPs, albumin endothelial dysfunction were all impacted positively by this therapy. So there is a pathophysiologic correlate to the clinical outcomes that we discovered, and hopefully this will now enter a phase 3 trial. And this is what we are thinking at the moment as to what is the endpoint for the study, what is the population that we want to study. And there are two groups of thoughts here, whether we study ACLF grades 1 to 3 or go to that patient with a very high risk of death. And are these going to be the different endpoints? Is it's time to resolution, 28-day survival, bridge to transplantation? But there is a new concept about win ratio where you can use many endpoints together and give them different weights in terms of how you assess the outcomes. So this is ongoing discussions with the regulators as we speak. What about patients with acute deterioration? And I'm just going to touch on a couple of things here, mainly talk about GTAC. I'll show you the data later on in the meeting. But suffice it to say that what we need to do here is to modulate inflammation as opposed to get rid of inflammation. And we've shown that if you use GCSF by itself, which was trialed here in India, as I've shown you with the graft study, it does not work. But if you add a TLR4 antagonist to it, what you see is a beneficial effect of GCSF by modulating inflammation. So this is a trial which is funded by the European Union, will be a 3-arm study which will compare GTAC, which is a combination, versus TLR4 antagonist versus standard of care, and it is due to start to enroll in September of this year. The primary endpoint, of course, is safety. The secondary endpoints are disease severity, and we study many mechanistic biomarkers. And with the population of patients that we're going for are steroid unresponsive alcoholic hepatitics with ACLF grades 1 to 3. But of course, a patient like David, who's in the community, the question is, what can we do for him to prevent the occurrence of decompensation? We recognize that bacterial translocation is very important. So what we have done is to develop this thing called Carbolive, which is essentially a charcoal. It's a carbon. It's a multiporous, highly engineered adsorbent in the gut. And we've just finished our first phase 2 study, a safety study, double-blinded, placebo-controlled. And what we show is that there is a significant reduction in systemic inflammation, modulation of the microbiome. And this is a kind of study that we're planning at the moment in 120 patients with a phase 2B type study to prevent the occurrence of rehospitalization of cirrhotic patients. And we will include patients with recently hospitalized for cirrhosis with CLIF AD score of greater than 50 to prevent the recurrence of decompensation. I'm moving through this very quickly. I think digital therapeutics is going to be huge as we move forward. And I think that, when a patient recovers from their acute decompensation, the risk of rehospitalization and risk of death is very high. So what we're developing is a digital therapeutic, which is an app-based. The patient goes home with multiple sensors that they collect the data on a day-to-day basis, which beams to the doctor. Doctor can see the patient on a day-to-day basis in their clinical profiles. It measures temperature, blood pressure, heart rate variability, fluids, high mental function, etc. And the clinician can respond to the patient to either intervene or what have you. We recently published the first study where we showed a 38% reduction in hospitalization compared with a historical control group. And what's nice to see is that the FDA has given it a breakthrough designation, and hopefully it's going to start a clinical trial very soon. So that is the design of the trial. And finally, I just want to touch on transplantation, which is here and now, and it's already altering the mortality of patients with cirrhosis, already saving lives. But, it's also time for me to just acknowledge Vinay Sundaram, who died at the age of 42. He's led the field in terms of transplantation in the ACLF world right from the outset. And what this shows is that wherever you start, ACLF 0, 1, 2, or 3, if you transplant them, the 80% risk of death is reduced to nearly 20%. So therefore, very clear evidence of potential transplant benefit in patients with ACLF, but it is not applied equitably across the world. And we were very poor in the UK. As you can see, this is a European perspective. That is only 2.9% of our patients were being transplanted compared with France and Germany, where a lot of these patients received organs. So what's happened, this is a change that's already happened in the UK, where patients with ACLF 2 and 3 are receiving expedited transplantation just below the ALF criteria, and this is starting to make a difference to the lives of patients already. But of course, there are many unanswered questions, and we will address these unanswered questions in this global chance study, which is running in 65 centers across the world, sponsored by EF-CLIF, and many of the centers here in India are taking part in this study, so thank you very much for your efforts. And finally, just again, I don't have too much time, but to say that it's already having observable and measurable impact. In healthcare, reduction in death rates, liver transplantation is now a recognized indication, new INASL guidelines. There's ongoing alignment with the FDA, and it's interesting that I spoke with them about a couple of weeks ago. They're very interested in finding routes to allow drug and device development for this condition. Earlier referral to centers will reduce the cost of these patients, and it is an estimate that we think more than $500 million are already invested into ACLF programs. What is really pleasing to see is that there are researchers from across the world studying ACLF here in India. There's a massive group out of RLBS and a huge amount of work, Basel, USA. And again, research agencies, Europe has invested over 40 million into ACLF research. And we think that there are more than 500 new researchers in the ACLF field, which again is a massive uptake. Finally, we need to see whether it'll allow for improving the equity of access of these patients. With this, I'll just summarize my talk just to say that the clinical characterization of ACLF has really reclassified cirrhosis. The pathophysiology and disease stratification will allow for the development of novel therapies, and I've shown you some of those. Resolution of ACLF is associated with survival, and it strongly supports its use as a potential surrogate, but of course, regulatory alignment is important. Liver transplantation is already saving lives, and I think the least that we can do for these patients is to see if they're eligible. There's several clinical trials, as I've shown you, that are taking place across the world to prevent the occurrence of ACLF, to treat it and prevent its recurrence are underway across the world. And we hope that one or more of these will result in novel approaches. Now, I hope I've convinced you that reducing deaths from ACLF is a realistic goal. But of course, a lot needs to be done, regulatory alignment. And I think this is, the last point is very important, that funders, particularly industry, is very scared of conditions with mortality, which is so high. But I hope that we'll get one or more of these big pharma to get interested in this story. And I would like to thank many of the funding organizations here, particularly the EU, that fund the research that I do, the Medical Research Council, the Wellcome Trust, EFCLIF, that have provided me the data that I've shown you today. But finally, just to acknowledge all the fellows that have been through my lab over the last 20 years to tell you the story that I've told you today. So thank you again for this great honor.
Thank you, Professor Jalan, for delivering this very prestigious oration today and taking us through your journey of ACLF and actually convincing us that reducing deaths from ACLF is a realistic goal. Thank you very much. I'll request you to please come at the center for the felicitation. Put this and put it all in the bag and here. Thank you so much. We move on, and I think this is a postgraduate course now. We'll start with that, with the first session. Before we do that, I think I need to invite Professor Patrick Kamath, I think, who has really guided us in designing this postgraduate course. Maybe you can say a few minutes.
Good morning, everyone, and thank you for joining us for this postgraduate course. Manoj and SP, thank you so much for your warm hospitality, but most of all, thanks to Ajay for putting together this program and the postgraduate course. We've got two symposia, INASL, ISL, which are going to be the highlights of a postgraduate course. Just a few housekeeping details. First, to the speakers, please stay on time. When you get the 2-minute warning, please wrap up. For the audience, please keep your comments short and your questions also short. And finally, the chairs, please try and keep the sessions on time so that we can move on because we've got a really packed program. And with that, I will invite the chairs for the ISL INASL postgraduate course, the symposia. Thank you.
For this session, we'll request our chairperson, Professor Dr. S.P. Singh, President of INASL, Chairman of Kalinga Gastroenterology Foundation, Professor Dr. S.P. Mishra, MLN Medical College, Allahabad, Dr. Sandeep Nejwan, SMS Medical College, Jaipur, Dr. Sri Srijaya, Government Medical College, Thiruvananthapuram, Dr. K.N. Panda, Gastro and Liver Clinic, Bhubaneswar, to please join us on the dais.
Good morning, everyone. We'll start the proceedings by having the first talk from Quentin Anstey. He will speak on biomarker strategies for significant and advanced liver disease at the primary and secondary healthcare level. Dr. Quentin, please.
Thank you very much. I'd like to start off by thanking the organizers and INASL for the invitation to come and speak to you today. It's an incredible honor, and I'm delighted to be here. So I've been asked to talk a little bit about non-invasive biomarkers and really how we can piece together what's available and put it into practice. Those are my disclosures. We're all very aware of the huge public health burden that is conferred by fatty liver disease, the number of individuals who are at risk, and also the very large number of individuals who go on to have significant fibrosis, cirrhosis, and come to adverse clinical outcomes. But the challenge we have is finding those people amongst the many who are at risk, and to do that in an effective and scalable way. We know that it is the individuals with more advanced fibrosis, particularly those with F3 or F4 disease, who are most likely to come to long-term harm. So it's quite sensible that our biomarker strategies particularly target those with advanced fibrosis and also stretch down to those with F2 or clinically significant fibrosis as well. Before I go too far into the various biomarkers that are available, I just want to take a step back for a moment or two and remind ourselves of a couple of fundamentals which help us to understand how best to use biomarkers and also where some of the pitfalls are when we're developing biomarkers. So with any test, what you're trying to do is separate individuals with health from those with disease. And we know that if you draw a single line, there will be a reasonable number of individuals who are either false negatives or false positives. One of the things that is very commonly done, and we'll look at this as we go through, is therefore to use two separate cutoffs, a high specificity and a high sensitivity cutoff. And this, of course, very effectively controls the false negative and false positive rates, but at the cost of an indeterminate zone. Now, as a biomarker developer, this is very appealing because it allows me to game the data and show you the data in the best light with a high positive or negative predictive value. But the reality is, it means that there is a subset of individuals who are not classified by a test. And I'll show you a few cases where this applies. The other thing we need to remember is the setting where we're applying a biomarker. And this is relevant in two ways. Firstly, because our needs differ. If we're in primary care, for example, we probably want to have a test with a high negative predictive value to rule out as many patients as possible and confidently say, this is somebody I don't need to worry about. Conversely, in secondary or tertiary care, we're much more interested in high positive predictive value. We need to identify individuals who we have high confidence levels that they have advanced disease. And it's a balance where you draw that line. The other thing we need to remember is what's called spectrum bias, which is a function of pretest probability. Because again, depending on where your practice is, you will either see more so you may have a leftward skew of distribution, in other words, more mild disease, or a rightward skew. In other words, your population you're seeing in your clinic is enriched for more advanced disease. And again, this alters how biomarkers perform quite dramatically. So I'm going to break the talk down into three sections. The biomarkers we have available today, those that are just around the corner and may be available tomorrow or already are available in some settings, and finally, just a nod towards the future and the hopes for personalized medicine. So let's start off with what we have available today. There are already a plethora of different biomarkers available. The ones where we have arguably the most number of biomarkers, fortunately, are targeting that most clinically significant area, which is fibrosis and cirrhosis. And they're the ones I'm going to focus on in the talk. We start off with the simple panels. The FIB-4 score and the NAFLD fibrosis score are great examples of these. And the one that's most widely used, most widely advocated, is, of course, FIB-4. Now, Already here, we're using those two cutoffs, the high sensitivity, the lower cutoff, which is usually 1.3 for FIB4, and then a higher specificity cutoff, usually something around about 2.67 is often adopted. So we accept that indeterminate zone with this test. We know already that the range of biomarkers that measure fibrosis have prognostic value. Here I'm showing you data that came out a couple of weeks ago from the Litmus Consortium with an individual patient data meta-analysis looking both at histology, FibroScan, but also FIB4, which you can see stratifies very nicely for prognostic value. And what we can also say is that if you serially measure these tests, that allows you to refine your prognostication for patients. So these simple scores fulfill a diagnostic criteria. They tell you about the amount of scarring in the liver today. They give you information on prognostic value and allow you to tell your patients what this means in the long term. And crucially, if you repeat those tests at 12-month intervals, you're allowed with them to refine your prognostication and be able to adjust that still further. And that's very important. When we think about the number of cases who are missed with any biomarker, if you repeat it year on year, eventually you will detect those individuals as their disease progresses. So that's an important point to make, particularly with a relatively cheap biomarker like FIB4. Then, complementing those simple panels, we can have tests like FibroScan, which is very effective, again, at ruling out advanced disease when its liver stiffness is less than 8, but also, if we look at the Bovino criteria, can be used to rule in and further risk stratify individuals with more advanced fibrosis. Some of the tests using FibroScan have been evolved further, and you may well have heard of the Agile 3 and Agile 4 scores. These are some data we published just in abstract form a couple of years ago, comparing simple VCT, in other words, FibroScan, with Agile 3 and Agile 4. And what you can see is that certainly in terms of their positive predictive value, these tests were a little bit better than using FibroScan on its own. But there is a cost, and that is that indeterminate zone, once again, where we're not able to classify some individuals. So although they have value, I personally would stick with just using FibroScan in my routine practice. Moving away from those physical measures then we look at the collagen biomarkers, and these reflect that dynamic balance between fibrogenesis and fibrolysis and the movement of extracellular matrix turnover. Because they reflect those fundamental biological processes, tests using collagen biomarkers have an opportunity to not just be a diagnostic test, but also potentially to have value as a monitoring test and to be responsive to change in therapy. And that's, again, very useful. There are a couple of these that are worth highlighting. The first is procollagen C3, which is a marker of fibrogenesis, and there's a score developed from it called the ADAPT score that has been shown to perform very well as a diagnostic for advanced fibrosis. And then the ELF test. This one's been around for a number of years now. It's very well recognized. Procollagen 3, hyaluronic acid, and TIMP1 are the key components. And certainly there's evidence to suggest that it may outperform simple scores like the NAFLD fibrosis score in some settings. But I'll come back to that in a moment so we can talk about it a bit further. There's often a belief that the more expensive a test is, the better it is. And I just wanted to take a moment to unpick that a little bit. I'm using the ELF test here as an example, but the same principles apply to the majority of other tests. And that is that it very much depends on the pre-test probability, the setting you're using a biomarker in, to influence its performance. So here I'm using two thresholds, the 7.7 high negative predictive value threshold and the 9.8 threshold, which is often advocated in clinical guidelines. The key point, and I'm not sure if this point is going to work, but we'll give it a go. The key thing to look at here is the sensitivity and the specificity of these tests. So very high sensitivity at 7.7, reasonable specificity at 9.8, and goes up further. But if you're looking to actively rule in disease in a primary care setting, the positive predictive value of the 7.7 or the 9.8 threshold is only about 20%. And this speaks to the idea that when you're at prevalences of 5 or 10%, these tests are really not very good for ruling in advanced disease. Where they come into their own, once again, just like FIB4, just like FibroScan, is for ruling out disease. However, as you move into secondary and tertiary care and the prevalence of advanced fibrosis increases, you begin to get an increase in the positive predictive value of these tests. So as we use them and interpret them, we need to be very much aware of the setting. One of the ways you can get around this, and this is the basis for the majority of the current clinical guidelines, is sequential testing. And essentially, the first test, the FIB4 score, rules out a number of individuals with a low probability of advanced fibrosis, therefore enriching the prevalence of advanced fibrosis to allow that second-line test to perform even better. Now, we modeled this a number of years ago using data from the STELLA studies, where you can see this working to essentially reduce the size of the indeterminate zone whilst preserving the sensitivity and specificity. And this is what is now picked up in a number of the current clinical guidelines. Here's some very nice data from the ADANCE group, which came out earlier in the year, putting that into practice in the real world. Now, this isn't simply a fatty liver population. This was a general population, also a group with at-risk fatty liver disease, and a group with NAFLD. And they combined 3 tests, non-invasive with the ELF score, liver stiffness by FibroScan, and potentially, in not all patients, but a liver biopsy. And what you can see is, when one single test was used, there was a relatively high false positive rate. However, the combination allowed you to control the false positives whilst only slightly reducing your sensitivity of the overall algorithm. That's the basis now for what we're seeing, which is a general consensus in all the clinical guidelines, whether European, American, or in the INASL guidelines, to use this 2-stage testing process. FIB4 first, and then either VCT or FibroScan coming on. So in the last few minutes, let's just think a little bit about tomorrow and where we are. We clearly have now available tools that are useful for us and effective in clinical practice. I think there's now no justification in not using non-invasives in our routine standard care. But it's also true to say that there's room for further improvement and we can do better. Again, another paper from Litmus that came out a few weeks ago where we did a head-to-head comparison of a range of wet biomarkers, including some very advanced panels like the serologic panels, but also liver stiffness. And you can see that only 2 of them got significantly over our 0.8 AROC threshold. So there's room to do better. In some territories, MR elastography is more and more widely used to help identify things. And it's really like FibroScan, but on steroids, and I think has some value here. And this is some very nice data from Rohit Lumba's group, where they used MR elastography combined with the FIB4 score, again, to detect individuals with at-risk NASH, with a significant improvement in the discovery cohort and in the validation care cohort for the areas under the receiver-operator curve. But do we really need to go to the expense and cost of MR elastography to be able to identify patients with more advanced fibrosis in our clinics? And I think one of the areas where in the next few years we're going to see more and more use is of artificial intelligence and machine learning in this space. What I'm showing you here is a study that actually was just published in Hepatology a few weeks ago again, where we applied a machine learning approach to some of the cohorts in Litmus to see if we could use readily available information, presence of diabetes, AST, age, HbA1c, plus or minus some additional biomarkers to actually risk stratify patients effectively. And what we found was that these machine learning approaches could potentially be run through standard electronic patient records and would outperform the majority of the non-invasive biomarkers, including FibroScan. So there are opportunities here to work smarter to identify patients more effectively using the information we already have. The final moment or two, and if we can just get rid of that, is to think about the future and what's around the corner. And what we know here is that there have been incredible advances in terms of our understanding of the pathophysiology of fatty liver disease and other liver diseases in general. We just saw that from Professor Jalan, and in fatty liver, again, there's been this exponential growth in the amount of information we have. And so I think we're going to move in the future to this concept of, first of all, a primary risk stratification using genetic information, and then a personalized medicine approach to follow on from that. So to conclude, fatty liver disease is highly prevalent, but what we need to do is identify those individuals who are already with the greatest burden of disease in that large population, and those most likely to progress further forward. We have available tools using FIB4 and FibroScan to do that, but there's room to improve, and there are a range of other additional biomarkers that are coming forward and will help us in the coming years. Just leaves me to acknowledge my funders, the many patients and collaborators, and to thank you all very much for your attention.
Thank you, Quintin. Please join us here. May I invite Dr. Jeff Lazarus to speak on digital health intervention in MASL. Jeff.
So I'm not seeing the slides on the, there we go. Are they? Yeah, there, great, thank you. Thank you very much, Chair, and thank you very much to the INASL organizers for the opportunity to say a few words about something we're frequently discussing, digital health, and I'll raise the question of how much do we actually know about digital health? I'll share an example of a study we ran in Spain, and then briefly discuss both artificial intelligence and, as Dr. Anstey mentioned, machine learning and how we might use them here in the management of MASLD. These are my disclosures. So globally, the use of digital health interventions, what we call DHIs, for example, via computers, tablets, mobile phones, and wearable devices is expanding, along with growing scientific evidence of their effectiveness to help in caring for people with or at risk of liver disease, including MASLD and MASH. The shift in how our care is provided is not occurring uniformly among all healthcare providers. So given the high and growing prevalence of MASLD and MASH that we're all aware of, we wondered, what are physicians' knowledge, beliefs, and attitudes, practices, and access with regards to DHIs for patient care? And we started with this study in Spain. We think it might be valuable to do this in India as a country or in some of your states. I look forward to discussing that with you. Last year, we ran an 18-item survey through the freely available REDCap online platform. We worked with the Spanish Association for the Study of the Liver and the Spanish Society of Digestive Diseases to reach all members of these societies, all the liver experts across Spain. We collected basic information on demographics and their knowledge, beliefs, attitudes, as mentioned, with regards to DHIs for patient care, and particularly MASLD and MASH. And so let me share with you some of the results. We reached almost 300 physicians from all 17 autonomous communities of Spain. And more than 9 in 10 reported understanding what DHIs were. This is self-reported, but only 25% had received any education or training on digital health interventions. More than half had never recommended DHIs to their patients. We found that respondents were more likely to recommend DHIs if they had received this kind of education and training, which makes good sense. So that's already one message for those societies to increase that kind of education and training at their society meetings and for their members. 94% thought that it would be useful to receive training on choosing and recommending DHIs for their patients. So that's really almost everyone felt that although we're told to use DHIs more, it's not really well addressed in the guidelines, and they would appreciate more training on this. Almost 60% reported that they would recommend DHIs if they had time during their consultation, and just over half if they had the evidence of the utility of using DHIs for the patient. So in many ways, we found that we're at ground zero in terms of DHIs, poor education and training, a lack of knowledge and a lack of use. Around 80% reported that they had workplace availability and provision of DHIs like e-prescribing and treatment compliance tools, while only 8% had such access to telemedicine or remote health. So if you look here, we put forward the statement that I think that digital health can have benefits in the following areas. About 2/3 felt in improving general patient care management, a similar number for improving administrative processes, and then it cascades down in terms of improving efficiency of care delivery, all the way down to improving diagnosis efficiency, something Dr. Anstey mentioned, and I'll come back to, because we think there is now emerging evidence that it can help in diagnosis efficiency. So although a high level of familiarity with DHIs among physicians was found, most reported that they don't recommend these tools in patient care management. And addressing these concerns, including the lack of time, the evidence of DHI utility, education, training, and access, may contribute to increased utilization of these technologies overall, and more importantly, to directly improving the health of patients. So this was one first study of its type in Spain. And again, I think it's something we're going to have to study more in depth, and we need to think about in our society's clinical guidelines how DHIs are addressed, the whole range of DHIs, from the one spectrum of, do we know our patients' step count? Do they have wearable devices? Are we e-prescribing and using telemedicine? All the way to, are we able to use artificial intelligence and machine learning to help our diagnostic efficiency? So let me turn to those issues and just try and unpack some of the terminology around this. We've been talking about some of these terms for really a long time, even if they only seem to have come in vogue recently. AI from the 1950s, ML from the 1980s, deep learning from the 2010s. We're talking about computational models that augment, recreate, and support human intelligence, decision tree-based methods, and neural networks. So what can AI do for MASLD? Well, we have the potential to augment the exploitation of massive multi-parametric data, often non-structured and unexploited, with the creation of models that enable machines to learn from data, recognize patterns, make decisions, and solve complex problems fast. We can have enhanced accuracy compared to traditional methods, personalized clinical decisions for patients. We can streamline patient care. It sounds too good to be true. We're also not quite there yet. I would borrow Dr. Anstey's phrase. Some of this is for today, some of this is for tomorrow. The potential AI applications in liver disease in general are really wide-ranging, from multiomics, including the prediction of hepatotoxicity in drug development, natural language processing, so we can have automated interpretation and analysis of clinical reports, for example, real-time biomonitoring to allow for timely intervention for high-risk patients, pathology-based imaging recognition, radiology-based imaging recognition, and in our routine clinical and laboratory data analysis to predict fibrosis, to predict cirrhosis complications, mortality, transplant outcomes, and so on. So what have we learned, and is AI always better? So the current automation and AI applications in MASLD, if we think about imaging, we have image analysis, augmentation, and pattern recognition in terms of demographics and clinical labs, predictive analytics and clinical decision support tools, machine learning for MASLD identification, as already briefly presented from the new study from Dr. Anstey. Using prospective registries, we can prospectively collect data, including we do this with a pre-specified set of variables that were considered relevant by default. So this is supervised learning. Generally, most data points are available, not many are missing. And how do they perform in the real world, where the top predictors may not be tested. So that's using the prospective registries, using large electronic health records. They offer the digital footprint of healthcare information in massive data sets of clinical data and more opportunities to learn from what we don't always see. Large electronic health record data sets require careful and complex computational considerations due to mixtures of inputs, quantitative, binary, and categorical variables, unstructured data like notes and reports. There are many missing values and outliers, which is reflective of real-world data, and only a small fraction of the large number of variables are relevant predictors. Using prospective registries, this is one study led by Dr. Mazen Noureddin in the US, the prediction of MASLD in the NHANES data set. This is a national health and nutrition examination survey. I'll just say that the main finding was that machine learning methods had similar performance to that of traditional methods, which begs, like logistic regression, which begs the question of, should we always do this? Why? And now new studies showing that it actually may outperform traditional methods. I'm going to come back to that in just a moment and just share a couple of examples. When we talk to our patients, we can use wearable devices. We can use apps. This is one app developed by the Human Edge here in India, where they're looking to provide both real coaching to MASLD patients, but also a whole range of services all done through the apps. The question is, will such apps get prescribed? Can they be reimbursed? And how do we train everyone to use these apps and which apps they should choose? Again, I think this is important for guidelines and for really deep dives in our postgraduate and other trainings, including CME. So some of the challenges and considerations in AI: we need good quality data sets for algorithm development. In terms of data availability, to address the needs of large and diverse data sets for training reliable AI models. A flawed algorithm can cause harm to a large group of patients. Systematic amendment, extensive simulation and validation are required when an AI algorithm is launched in clinical practice. And we have a need for randomized controlled trials comparing AI-based approaches with non-AI-based approaches. This is really where we are now. AI models can offer a digital solution of MASLD identification and risk stratification, which is scalable and possibly accessible to primary care and other non-hepatology areas using already available data. AI as clinical decision support can potentially streamline patient care by removing the need to order and calculate risk predictive scores in primary care, and by improving diagnostic accuracy in imaging when this is automated. And the role of machine learning and AI is most impactful in large data sets where it can choose what is pertinent, unstructured data that the human brain cannot really fully synthesize or see. In other contexts, logistic regression is comparable, and the incremental benefit needs to be balanced with the processing time and computing capability. So in other words, where machine learning is equal to that of logistic regression, we need to decide if it really makes sense to move in that direction yet, depending on the particular setting and the extra costs of developing that ML. And the development data set should ideally be the context of use, which again complicates the rollout of machine learning, otherwise validation before implementation in clinical practice. So I'd like to acknowledge particularly Dr. Alina Allen at the Mayo Clinic for sharing her work with me, and the team at IS Global who helped with the Spanish Digital Health Survey. Thank you.
Next, I invite Dr. Arun Sanyal for his talk on drugs for advanced fibrosis and cirrhosis related to MASH.
Thank you. Good morning. And it's a great pleasure to be back home with old friends, making new friends. And my task today is to talk about what's happening with the treatment of liver fibrosis, particularly with a focus around advanced fibrosis. Here are my conflicts. So the first question we need to ask ourselves is, what is it that leads to mortality in our patients with fatty liver disease? And if you look at fibrosis stage reflects proximity to cirrhosis. Most patients die when they get to cirrhosis, at least the liver-related mortality. And therefore, fibrosis is really a central piece of how we assess disease progression. And our goal of therapeutics has been focused on managing the patient with fibrosis. Now, of those with fibrosis, those who have bridging fibrosis or cirrhosis, this is often referred to as advanced fibrosis, are the population that are closest to developing a clinical outcome, and therefore a population of great interest for all hepatologists, because they are the ones who will benefit the most from an effective therapeutic intervention. We also know, as was shown earlier today, that fibrosis represents, when you look at fibrosis at a point in time, you're taking a snapshot of a very dynamic process, where on the one hand, you're laying down collagen, but on the other hand, you're resolving collagen. So these are data from the simtuzumab trials, and we looked at factors that were linked to developing clinical outcomes. And both the baseline hepatic collagen content and change from baseline and surrogate markers of fibrosis such as ELF also were correlated with developing a clinical outcome. And so this gave us the idea that fibrogenesis is actually a principal driver of that progression, even from cirrhosis to liver outcomes, much more so than fibrolysis. They're not equally weighted. And number two, the idea that a 0.5 decrease in ELF score might be clinically useful as a disease monitoring tool. So when you think now of how to stop this fibrosis progression, we should think about the pathophysiological cascade that drives disease progression, where if you go from left to right, the liver is subjected to metabolic substrate overload in the form of fatty acids, sugars, inflammatory cytokines, which induce cell stress. If it's injuring the cells, leading to an inflammatory response, killing the hepatocytes, which in turn, if it does not resolve, leads to a fibrogenic response and a fibrogenic remodeling of liver architecture that culminates in cirrhosis. The first three elements are generally considered to reflect disease activity, and the fibrosis reflects the disease stage. And so this, of course, also gives us potential therapeutic approaches, where we can either target the disease activity or fibrosis. So let's first think about how we can slow the fibrogenic drain by treating the underlying disease state, which is the cause of the fibrosis. Remember, fibrosis does not happen in a vacuum. The stellate cells do not wake up one morning and say, I think I'm in the mood to make collagen today. There's something that causes the stellate cells to get activated. So if you think about targets that are upstream, the furthest away are the GLP-anchored therapies. GLP does not have a receptor in the liver. All the hepatic effects of GLP are mediated by its effects outside the liver. And these are the phase 2 data where we show that you get almost a 59% resolution of steatohepatitis without worsening of fibrosis. But when you look at fibrosis, unfortunately, we do not have a clear signal of resolution of fibrosis, although there was less progression of fibrosis. So it is possible that with longer follow-up, from less progression of fibrosis, there'll be stabilization of fibrosis, and then eventually when you stop fibrogenesis, your fibrolytic pathways will kick in. It is also possible, if you're too far advanced, that your fibrosis will no longer shift. You've cross-linked collagen that you cannot mobilize. Time will tell. There's a phase 3 study ongoing in pre-cirrhotic NASH, but unfortunately, the study with cirrhosis was completely negative, did not have any biological effect in terms of fibrosis resolution with semaglutide. The next major class of molecules are the PPARs. And the one I want to talk about most is lanifibranor. So as you know, there are different PPARs. You have PPAR alpha, gamma, and delta. Alpha improves fat oxidation, gamma has insulin sensitizing properties, and delta has anti-inflammatory properties. So lanifibranor is a pan-PPAR agonist, and saroglitazar, which all of you are very familiar with, is a alpha-gamma agonist. So in phase 2, lanifibranor actually showed improvement in NASH resolution, improvement in fibrosis, as shown in the middle panel, which led to this new outcome parameter, which is combined both NASH resolution and fibrosis improvement. And this was the basis when this was published in the New England Journal 2 years ago now, and led to the phase 3 trial, which is now we have halfway enrolled. So we think that by the end of the year, we should be fully enrolled, and then maybe a year from then, so sometime in 2025, we should be able to present data with lanifibranor for pre-cirrhotic NASH. This is not currently being studied in cirrhotic NASH, but there are studies in planning for patients who already have compensated cirrhosis. Similarly, with saroglitazar, there is no question there's improvement in dyslipidemia. These are data that we published showing that particularly the small dense LDL particles, which are the most atherogenic part of the LDL family, actually are substantially improved by saroglitazar. And if you look on the right, in this very small pilot study, fairly substantial histological improvement as well. The caveat, of course, is that these are very small numbers. It's a pilot study, and we really need a much more rigorously done and large-scale controlled data set. And the phase 2 trial is currently ongoing, is also about halfway enrolled, and we hope we will be able to show you those data. And I think it is a little regrettable that the phase 3 study data from India has still not been published. Thyroxine beta receptors are the next class of molecules. So thyroxine has two types of receptors, alpha and beta. Beta are relatively liver restricted, and resmetirom is the first thyroxine beta receptor agonist. And what happens in NASH is that you get cellular hypothyroidism within the liver, where you have decreased conversion of T4 into T3 and an increase in reverse T3. And that slows down a lot of metabolic pathways within the liver. And when you give a thyroxine beta receptor agonist, you actually turn on fat oxidation, you improve mitophagy and get rid of the sick mitochondria, which are releasing oxidative signals and oxidative stress, and you generate new mitochondria. So there are a whole bunch of things that it actually does. So thyroxine beta receptors also, by improving lipid metabolism, have a big impact on reducing liver fat and lowering LDL cholesterol and triglycerides. So these are the phase 3 data that were presented at the liver ILC just a few weeks ago, And as you can see, that in a very rigorously done phase 3 study, you're seeing a progressive stepwise and improvement in NASH resolution, with both treatment arms being quite effective. Similarly, it showed benefit for fibrosis and a rather substantial decrease in LDL cholesterol on the background of whatever statin therapy, etc., the patient already was on. Very, very exciting data. This is likely to be the first drug to be approved by the FDA. Now, focusing on drugs with pleiotropic or antifibrotic effects, the first class are the FXR agonists, which have a number of metabolic effects, but also direct antifibrotic effects. And obeticholic acid is sort of the prototype FXR agonist, and there are a number of second-generation FXR agonists. Now, when bile acids, FXRs are the receptors for bile acids. Now, when bile acids come out in the bile and go into the intestine, they are taken back up in the distal ileum through apical bile acid transporters. If you block that, we haven't really seen in multiple studies any real effect on fatty liver disease. So I'm going to leave that aside. But they do activate a receptor within the ileum. If you activate FXRs, you release a molecule called FGF19, which feeds back on the liver and has very similar biological profile. So FXR, obeticholic acid, has been studied in cirrhosis. Unfortunately, the study was completely negative. And in pre-cirrhotic NASH, because of a number of adverse effects like high LDL cholesterol, potential DILI, increased cholecystitis, increased gallstone occurrence, etc., the drug development has currently been stopped. Now, when we talk about FGF, what about the FGF19 that's made at the bottom? So FGF19, as I mentioned, feeds back on the intestine, but there's a different FGF called FGF21, which is made both in the liver and elsewhere, and has pleiotropic effects on adipose tissue centrally and on the liver, and has a multiple metabolic as well as anti-inflammatory and antifibrotic effects. So Alpine 4 is a trial of NASH cirrhosis, and even since I made these slides, the top-line data have just been reported, and the original primary endpoint was histology, but it was changed by the NGM to a change in ELF score by 0.5, and at the highest dose, it did hit that just about 0.51, it hit that mark, and that was significant, and this we hope to see more detailed data at AASLD. Now, the next class of molecule, the other FGF, is the FGF21. Now, FGF21s bind to FGF receptors 1, 2, and 3, whereas FGF19 also binds to 4. So FGF19 has a different profile of receptor activation than FGF21. And the first molecule I want to talk about is efruxifermin, which has very important key attributes in that it has these specific mutations that are shown on the cartoon on the left, and it increases the half-life from less than a few hours to up to 2 or 3 days. And it has high affinity for this receptor called beta-klotho that then mediates its effects. Now, each FGF21 molecule is a little bit different than the other based on its tissue penetration and varying receptor affinity. So this is efruxifermin, which in phase 2 shows very nice 76% NASH resolution and a significant improvement in fibrosis as well. So very, very exciting data, well tolerated with only modest GI side effects. What was interesting is that a subset of patients who had cirrhosis, very small number, albeit only 12, 4 of the 12 had less than stage 4 disease at the follow-up biopsy. So it's very, very interesting, and cirrhosis studies are currently ongoing. Now, similar data was reported with a different FGF21. So these are data that we just published last month in the New England Journal. Rohit was the first author with pegozafermin. And again, small numbers, it's a subset of a phase 2 study, but you can see almost half the patients had less than stage 4 on the second biopsy. So very, very interesting data, but we need larger data sets. Another interesting approach was to use silencing RNA to heat shock protein 47. Early studies in post-hepatitis C SVR patients with cirrhosis looked promising, but the NASH study was just stopped yesterday because of futility. Similarly, people have looked at galectin, which is another antifibrotic molecule, and the initial study a priori was negative, but they found in a subset of people that they developed less varices. So there is now another trial called Navigate that is ongoing with 2 to 4 milligrams of belapectin given every 2 weekly, and to look at proportion of people who develop varices as an endpoint. So when you compare the landscape, it is unfortunately pretty depressing because most of these studies in the cirrhotic population have not really panned out. The FGF21s are the ones that seem to be most promising, but remember, these are data with very small numbers of patients, and we really need large data sets. The future, of course, is going to be combos, but the combo data to date also looks rather modest in my view. But there is an ongoing trial of semaglutide with cilofexor and fircostat, which is an ACC inhibitor with 440 patients. So this is where the field sits, and I do believe that these negative trials have taught us a lot of things about how to approach these patients. And I think there will be an evolution of endpoints looking really at preventing disease progression and the slide into clinical outcomes that will be sort of where the rubber meets the road in the future. So I'll stop over here and take questions. Thank you.
Thank you, Arinja. So all three presentations are open for discussion, comments. Dr. Shiva?
Yeah, I'm Dr. Shiva Prasad from Visakhapatnam. My question is to Dr. Anstey. When we're doing sequential NITs, we assume that, the first level, and we're only going to pick up the indeterminates and then apply the second, like if you're doing a FIB4 and in the indeterminates, you do the fibroscan. But there are a large number of patients who will end up getting both done. And so what happens if there's complete discordance between these two sets? One shows advanced indication of advanced fibrosis, but the fibroscan shows no fibrosis, or the other way around. How do we interpret that situation in clinical practice?
Thank you. I think that's a great question, to be honest. When you actually look at it, firstly, in my practice, I only use one cutoff. So I use the 1.3 for FIB4. Everything above that, I put onto a second test because I think that is the most effective way of doing it. What you'll actually see in a lot of the algorithms is they then introduce a third test. Now, in many settings, that will be the ELF test you might use or something along those lines. In others, it's a liver biopsy. So I think it's about managing that risk stratification in that approach. No test is perfect, and we accept that there will always be some discordant results.
Ajay?
Wonderful session and all the talks. Maybe I'll just ask one question maybe to each one of them. Steve, the first question is about, again, the risk stratification. So most of the guidelines, if you look at, including our INASL guidelines, would follow what we call the two-step approach. You're doing the FIB4, and then you do the fibroscan, and then take a decision. But then we also know the limitations of elastography and all these tests. They may not be accurate for more than 70%, 80%. So if you look at the American, European guidelines, they do suggest that you can go for maybe ELF, MRE, or maybe a biopsy. That we thought was probably not really applicable to our population. So, or maybe a straight-away liver biopsy. So even the liver biopsy we thought was not very, friendly. So we thought that you can keep repeating these tests and then take a decision without going further. That's the first question. To Jeff, I think the AI is a huge and wonderful talk I think you gave. We actually have collected data of 1,600 biopsy-proven patients from Asia. This is a Go Asia group. This is under publication. The question is, what parameters do you use to say, and we actually said to determine the significant fibrosis so that they can be referred. So we used all those parameters, which actually we use in clinical practice at a primary or a secondary care level, and we turn out with that. So maybe your thoughts on that. And last question to Dr. Sanyal is, in clinical practice, when you have a patient with advanced fibrosis, what do we do today? Vitamin E data by Nagachalasani's group, retrospective though, did show us that it reduces decompensation and transplant-free survival. And can we still use OCA as an off-label, because the regenerate did show that it can improve fibrosis?
Okay, I better go first on that one. It's a great question. I think you touch on an important point here, which is what do you do next? Certainly, sequential testing, so in other words, repeating tests after a year or 2 years and so on, is a very reasonable approach when you have an indeterminate result. But at some point, you do need to get to an answer, and that is where a third-line test potentially has value. So I think it's a case of it's not an either-or, it's a combination of those two things. As I say, because the tests have a very high negative predictive value, what you're able to do with a great deal of confidence with non-invasives is identify individuals who don't have advanced disease. Where you get into that grey area where they're borderline, certainly I'd repeat those in 12 months' time. And as you've seen with FIB4, that simple 12-month wait to repeat it actually helps you to risk stratify. And I should say, the data I showed you there was UK-wide primary care data linked to outcomes. So it really does work in the real world.
Thank you, AJ, and it's great to hear that you've done this kind of AI study with the 16 liver biopsy patients. So it's across Asia. So I'll look forward to the publication and discussing it with you, because I wonder, what the breakdown is, both in terms of countries. Asia is a rather large place. So when we break it down, by countries and by population, will that be a training set that's strong enough to actually, run your AI algorithms? I think that's the main consideration.
I'll just stick to the questions that you asked me. So with OCA, given the adverse effect profile of OCA, particularly in the cirrhotic patient, if you will use it, you really have to be very careful in the dosing, because the hepatic exposure changes quite rapidly. And in the setting of any acute intercurrent illness, the hepatic exposure can increase very dramatically and trigger a major DILI event. So my personal bias is I would be very nervous about using it. If I would probably not use it. Vitamin E is relatively safer, and I would be more open to using something like that, except that the database for that, as you know, the quality of the evidence is not at the same level as these prospective trials that I showed you. So the focus really for me is to maintain the metabolic status of the cirrhotic patient, to minimize the use of insulin. I focus a lot on progression of cardiovascular disease and diastolic dysfunction, which becomes rate limiting for many of these patients. And we try to maintain muscle mass and prevent sarcopenia. So for us, those are much more important than some NASH drug without evidence of that any of them really do much at this point in time.
Arun, before I move on, combinations have to be rational. So the best you showed us was semaglutide and lanifibranor. Can we use it in combo?
Well, you can, but we don't have the data to say what that would look like. But it would make sense, because lanifibranor does lead to some weight gain because of the PPAR gamma piece. And so I think there's ongoing conversation to do a combination trial with lanifibranor. So there's two studies, one with lanifibranor and dapagliflozin, and the other one with lanifibranor and semaglutide. But I think whether the two companies can come together and work with each other to do a trial.
No, you can have a trial.
Yeah, so that I think is still an open question.
And second question is, silencing RNAs, small interfering RNAs have been, for decades they have been there. Is it in clinical use anywhere?
Sorry?
Is it in clinical use any disease? Anywhere?
Well, we don't have a lot of data, well, maybe for amyloid. So, yeah, for some genetic diseases, yes. But, the data for HSD17 and for PNPLA3, I mean, they're still very early days. It shows that where we are with those drugs is that you can knock down the gene, whether that is sufficient to change the course of the disease is an open question.
Anil, sorry, keep you waiting.
Thank you, Dr. Arun. Excellent presentation. My question is in two parts. First is the holistic approach to fatty liver disease, and second is what do you do to NASH? Coming on to the first instance, every time you come to INSL, listen to your talk, you look at the end of your slides that there is no drug. Every drug is a failure. Is it that we are missing the woods for the trees, going by that maxim? Because the problem lies in the insulin resistance. Is it that we should redirect our search and research strategies to tackling insulin resistance will take care of everything else, taking an analogy for hepatitis B, because so far as you keep on giving nucleotide analog, you have a culprit like cccDNA which is hiding. Unless you tackle, rest is a futile exercise. So far as NASH is concerned, just look at antifibrotic agent. Is it that we are treading a different path?
Yeah, so let me address that. The first point I want to make is today's talk, I was tasked to talk about advanced fibrosis. So it's not a talk about NASH or fatty liver disease. So the question of holistic doesn't really apply here because we're talking about people with more advanced disease where insulin resistance is part of the story, but it's really not a driver. And in that setting, using insulin sensitizing therapies like GLPs, etc., have not really shown that the semaglutide trial was completely negative. So I think for earlier stage disease, it is holistic. For advanced disease, you have to stop the fibrogenic train, whether you do it with an antifibrotic or whether you use it with something that's more upstream.
And why not you combine the two? I mean, hit in the initial stage and those who have gone to fibrosis, a combo having a different mechanism of action may work.
Well, that's what people are trying to do with all these combos with semaglutide and with the cilofexor and all of those. But, you have to generate the data at the end of the day. And so...
BC, a small question, very quick.
Yeah, question to Professor Sanyal. Any experimental data on drugs enhancing cellular extraction of fat, thereby inhibiting intracellular fibrosis?
Cellular extraction of fat?
Of fat that is enhanced, that becomes extracellular, and therefore intracellular fibrosis is inhibited.
Well, the fibrosis is an extracellular event because it is the laying down of collagen outside the cells. And so, if you look at all the insulin sensitizers, one of the things they do is they move fat into a safer sort of an environment by increasing adipogenesis and moving visceral adipose tissue to peripheral adipose tissue. So there are examples of that already. In terms of, I'm not quite sure what you mean by intracellular fibrosis because fibrosis is an extracellular event.
Before we conclude, I'll just make a comment to Dr. Jeff. It's regarding AI. That is, ultrasound has come in a big way, and we are able to see the images, we are able to see the Doppler images, but we should measure the pressure also, so that HVPG measurement can be done transabdominally. So
there's already a body of literature on use of AI to evaluate portal pressures from ultrasound, from CT, from MRI. They're getting better. They're not precision tools yet, but I think that the field is moving in that general direction.
I think I thank all my co-chairpersons and the panelists over here. Thank you very much. Have a nice day.
We now take a brief break for tea and we start the next session sharp at 11. We have an important announcement to make. There is an hepatology quiz competition for DM students sharp at 5:35 p.m. here in the same hall. All the DM students who have participated in the same is requested to be here on time. 5:35 evening.
Have patients who are put on nucleoside analog therapy, that decreases the HBV DNA, so it eliminates the DANE particles, but the cccDNA contributes to continued replication that can be measured either as this core-related antigen or HBV RNA. So their real value is in helping us to understand the activity of cccDNA. And this just demonstrates the natural history of these biomarkers under the effects of nucleoside analog therapy. So what you can see on the left is at the start of treatment, both HBV DNA in the dark blue, as well as HBV RNA and correlated antigen are all detectable. And over the course of treatment, as expected, you get suppression of HBV DNA, so that becomes undetectable. But you can see a much slower decline in terms of the HBV RNA and the correlated antigen, which tells us that even though we've got suppression of viral replication, we have not suppressed it deeply enough, and we can still measure that activity of the cccDNA through these biomarkers of HBV RNA and correlated antigen. So I'm going to take each of them in turn and highlight the literature that exists around how we can use them potentially in clinical practice. So focusing first on correlated antigen, this measures 3 pre-core products. The E antigen, the P22 correlated protein, and core protein. Now, one of the things to be aware of is that the E antigen and the P22 correlated protein share the first start codon in the pre-core region. So when we get the mutation, the G1895A, which is the typical pre-core mutation, that's going to inhibit both the production of the E antigen and the P22 correlated protein, but will not affect the core. So what this tells you is the core-related antigen is strongly influenced by the E antigen status of the patient, as well as the acquisition of the pre-core and core promoter mutations. Now, in terms of the specifics of measuring hepatitis B core-related antigen, there's only one commercial assay that's available. It has a linear range of quantitation from 3 to 6.8 logs, which is a relatively moderate range. Up to 80% of E antigen positive patients will have values above 6.8 logs, and 42% of patients who are E antigen negative will have levels below the level of quantitation. So what that means is we got a relatively limited range that this assay can operate in terms of the spectrum of patients we see. And not surprising, because they both are reflecting the activity of cccDNA, there's a high correlation between the correlated antigen and HBV DNA in patients who are not on treatment. So what do we know about how correlated antigen can help us in terms of clinical practice or clinical care? So first of all, if you look at it in the different phases of infection, there are significant differences. And this shouldn't surprise you, because remember, correlated antigen includes E antigen. So shown in this figure on the left, which is from the Hepatitis B Research Network, you can see that patients who are E antigen positive, those that are immune tolerant, those with E antigen immune active disease, have high levels of hepatitis B correlated antigen, whereas those that are E antigen negative, and particularly those who are inactive chronic hepatitis B, have the lowest levels of correlated antigen. And shown on the right is a study from Japan, which highlights that seroconversion is an important event. And again, not surprising, with seroconversion, you're losing E antigen, so not surprisingly, the hepatitis B correlated antigens markedly decline. But unfortunately, this is not a very good tool in terms of helping us to sort out the indeterminate patients. So we're often kind of plagued with how to assess a patient who doesn't quite fit into one of the phases of infection. Can correlated antigen help us in assigning a patient to a specific phase? And in this study that was done by the Hepatitis B Research Network, they showed that the correlated antigen didn't help in distinguishing the indeterminate types. And it's probably related to this very limited range over which the assay can measure. But what else has been shown to be associated with correlated antigen? Well, one is that it can be something that gives you a clue as to the ultimate loss of surface antigen. So in this study from Taiwan, where they had over 2,600 patients that were untreated, They had 465 who ultimately cleared surface antigen naturally. And what they showed is that the hepatitis B correlated antigens became undetectable about a decade before the patient lost surface antigen. So it speaks to the importance of turning off or having a reduced CCC DNA activity in order to get surface antigen loss, but also suggests that the hepatitis B correlated antigen might be a biomarker to tell us about future loss of surface antigen. There's also data that suggests the correlated antigen could tell us something about disease progression. And in this particular study, they took E antigen negative patients who were in the gray zone. They had viral levels that were from less than 200 to 20,000, but their ALT levels were under 40. So they had viral levels which were higher than is typical for an inactive chronic hepatitis B, but had normal ALTs. And what they showed in this particular analysis is both at baseline and then following the core antigen over time, that the patients that had the hepatitis B correlated antigen at the highest levels were at risk for developing cirrhosis. So what this again is giving us a clue to is that this telling us about the activity of the CCC DNA, of this ongoing replication in the liver, is helpful in predicting some of the liver-related endpoints, in this case, cirrhosis. And there are several studies that have looked at HCC risk in the same way, and I'm showing you two studies here. One is on the left. It's looking at patients who had chronic hepatitis B, had undetectable HBV DNA levels on nucleoside analog therapy, but who subsequently developed HCC. And they were compared to patients who were on nuke therapy who didn't develop HCC. And when they looked at the various biomarkers to see could they have predicted who got HCC, what you can see is that the only marker in which there's a really marked difference is in hepatitis B correlated antigen, in that the group that had the higher levels of hep B correlated antigen was the group that went on to develop HCC on nucleoside analog therapy. And then shown on the right is a study from Taiwan in which they're also following, this is patients that are not on antiviral therapy, but again, looking at patients who had relatively low levels of virus. And what they showed in this analysis, just go back one there, is that the group of patients that had, again, viral levels that were under, in this case, 20,000, but whose correlated antigen was higher, was the group that had the highest risk for cancer. And in this case, had an odds ratio, which is approximately, a hazard ratio was approximately 10-fold higher than patients who had the lower level of correlated antigen. And then finally, we know that when a patient loses surface antigen, we're calling that functional cure. We now understand that those individuals can still have evidence of CCC DNA activity as measured by correlated antigen and HBV RNA. So shown in this relatively small study where they actually characterized these markers in patients who cleared surface antigen, you can see that about 20% of the patients still had activity as measured by the correlated antigen alone or with HBV DNA. And again, this might be relevant in terms of future risk. Here is a nested case control study that looked at, in individuals who had cleared surface antigen in this group, presence of correlated antigen was associated with future HCC risk. And then finally, the correlated antigen is now being looked at as a potential biomarker as we think about stopping nucleoside analog therapy. This is just one study where they developed this score called the scale B. And you can see that among the variables that go into the score B include the hepatitis B correlated antigen, as well as surface antigen, age, ALT, and use of tenofovir. And with this score, they could identify patients that have a low versus a high risk for clinical relapse after stopping nucleoside analog therapy. And just to show you that this has already been adopted into guidelines, this is the Japanese HBV guidance. And in this guidance, they actually use hepatitis B correlated antigen as one factor to help decide if a patient should be stopped from their nucleoside analog therapy. So you can see in this scoring system that they have, that if you have a patient whose surface antigen level is less than 1.9 logs and their correlated antigen is less than 3 logs, that individual has a 80 to 90% chance that they're going to be successfully discontinued from nuke therapy. So the two working more effectively to predict success with cessation of NA therapy. So to summarize, the core antigen it's not very valuable in terms of its diagnostic potential, but where it really comes into play is in its prognostic potential, both in predicting HCC risk in the indeterminate patients and in those who have cleared surface antigen. It can predict surface antigen loss in a subset of patients, generally those that have a surface antigen over 1,000. And it's clear that in conjunction with other biomarkers such as hepatitis B surface antigen, that also it can identify the best candidates for nucleoside analog withdrawal. Now, what about HBV RNA? So HBV RNA is a heterogeneous mixture that includes pregenomic RNA, spliced RNAs, and xRNAs. They can be naked and they can be encapsid. And what it's being measured in the serum is that composite of HBV RNAs. Now, in terms of the measurement tools for HBV RNA, there is no standardized assay, and different studies use different primers, and those primers may not capture all of these HBV RNA species, and that has relevance in terms of the accuracy of quantifying HBV RNA. There's also no international standard for HBV RNA, although some of the tests are now calibrating it against the WHO HBV DNA to help bring standardization to this measurement. So what do we know about using HBV RNA? Well, first, in terms of just understanding how it changes over the natural history of chronic hepatitis B, very similar to what we saw with the correlated antigen, levels are higher in patients who are e antigen positive. After seroconversion, which is generally associated with decreased levels of replication, you see that the values decline. And the very lowest levels of HBV RNA are seen in individuals who have recovered from their hepatitis B. But again, we find that these are not so helpful in terms of distinguishing. There's a high correlation between HBV DNA and the RNA in untreated patients, but can it be helpful in terms of those indeterminate groups? And here it seems that perhaps it could be helpful in e antigen positive patients where you can see that the indeterminate e antigen positive patient has distinctively lower levels of HBV RNA than immune active and immune tolerant patients. So maybe is a useful tool here. And then the second is on the right, showing indeterminate chronic hepatitis B. You can see that the highest levels are seen in those that have immune active disease, the lowest in those with inactive chronic hepatitis B. But the real place for HBV DNA lies in its predicting relapse after nucleoside withdrawal. And I'm going to show you two studies that really support that. So this is a study that looked at patients who started out e antigen positive, lost their e antigen, and then were consolidated for a year, and then had treatment withdrawn. And what they looked at was whether the HBV RNA helped predict the clinical relapse after nucleoside analog withdrawal. And what you can see on the right is that indeed in the group that was HBV DNA negative at the end of treatment, the HBV RNA helps to further clarify or predict their risk for a clinical relapse. So you can see in the group that is both HBV DNA and HBV RNA negative that the likelihood of having a clinical relapse was only 8%, whereas those that were HBV DNA negative but HBV RNA positive, that risk was 21%. And they showed in this analysis that the clinical relapse associated with being positive versus negative for HBV RNA was about a 4.6-fold higher risk. And this is just one more study kind of highlighting how we can start to use these together. Now we're using HBV RNA and HBV correlated antigen together to help predict clinical relapse after stopping nukes. And you can see that the very lowest rate of having relapse after stopping nukes is if your HBV RNA is negative and your hepatitis B correlated antigen was less than 4 logs. So to summarize the HBV RNA applications, diagnostically, possibly it has some role to play in terms of the indeterminate groups, but I think that really is not the best diagnostic marker. Where it really comes into play is in prognostic markers because it helps to define those that have a deeper remission from the nucleoside analog therapy and can predict those that are going to relapse with nucleoside analog withdrawal. So my final takeaways in terms of novel HBV therapies in the care of chronic hepatitis B. Both the correlated antigen and HBV RNA offer measures of CCC DNA transcriptional activity, but they have limited diagnostic value. Their key role is in prognostic applications. I think they can shed light on the role of surface antigen clearance and subsequent risk of liver-related complications. I think they're going to be most useful in predicting outcomes after nucleoside analog withdrawal, and by extension, they're helpful in potentially how we're going to use our new therapies. But keep in mind that there's key limitations, a need for standardization, improving the dynamic range, and creating tests that are easy to access and use. Thank you.
Thank you, Dr. Nora. Please join in the dais. Dr. Nora, please come. We'll have the question answer at the end of the session. Now, my fellow colleague will.
Thank you. So the next speaker is Professor Ujjal Poddar, and he will be talking about the drugs to treat chronic hepatitis B in children. Professor Poddar.
Thank you, chairpersons. At the onset, I must thank the INASL for giving me this opportunity. Firstly, let's decide who to treat in chronic hepatitis B in children. So far, whatever guidelines we have, be it ASLD, ESL, APASL, even our pediatric society guidelines, they are very restrictive about choosing kids with chronic hepatitis B to treat. The common premises is that hepatitis B is relatively benign in children, and we don't have much to offer to them. So why to treat? But if you see the data, almost 3 to 5% of children with chronic hepatitis B, they do develop cirrhosis before they become adult. Around 3 per 1,000 kids, they do develop HCC before they become adult. But the most alarming figure, if you don't treat a child with chronic hepatitis B now, his lifetime risk of developing HCC is almost 9 to 24%, huge number. You are ignoring hepatitis B in children today, but as an adult, he is carrying the high risk of developing HCC. So we need to think over it. Should we leave aside these kids without treating, or we need to develop some other strategy? Now, this is the standard criteria to decide who to treat in kids, and there is not much of difference like adult. These are all immunoactive patients with chronic hepatitis B, need to have high ALT, taking a cutoff of 40, it should be 60. But what is the basic difference is that you need to have liver biopsy in kids, because liver biopsy showing moderate fibrosis or necroinflammation is important. We don't have much response in kids, and these are the subset who responds, and non-invasive tests are not yet validated in children. Now, if you see what proportion of chronic hepatitis B qualify for treatment, this is our 500 cases experience we presented in a few years back. Just 9% falls into the category of so-called E-positive or E-negative chronic hepatitis. Means they are immunoactive, so you need to consider our treatment. Rest 91%, by standard definition, present definition, they don't qualify. So I am debating whether our standard guideline or defined immune tolerant is appropriate or not. Now, this is the summary of algorithm, what we can follow in children. Basically the same like in adult. You decide on the basis of E-positive, E-negative, DNA level and ALT, and then put them in this 4 category. Are the E-positive chronic hepatitis? In kids, you need to do a liver biopsy to show the significant necroinflammation or fibrosis, and you have treatment option of interferon, entecavir, etc. But if they are E-positive with normal ALT, low DNA, so-called, we used to call it inactive carrier, now we call it chronic hepatitis B infection, you don't do anything. Same is for E-negative disease. If you have a high ALT, high DNA, here you need to do biopsy and decide treatment. These are the drugs approved for use in children with the age given, at what age you can choose what. Only difference is that TDF is approved by European Medicine Agency to be used for 2 years or more. But US FDA is still not given approval. Their approval is for 12 years or more. TAP is recommended for more than 12 years. Let's see the studies. This is the study on entecavir, randomized placebo-controlled trial of entecavir in children, multicentric trial. 48 weeks of entecavir versus placebo, and then it became an open label. Those who are in the placebo not responded will receive entecavir. Age group was 2 to 18 years. They have a quarter of patients between 2 to 6, then another quarter 6 to 12, and rest 15 more than 12 years. Standard inclusion criteria of chronic hepatitis B with immune reactive, ALT value more than 1.5 times upper limit of normal. But to see the variation, their upper limit of normal, they have taken 30, not 50, and the dose is given in 0.015 milligram per kilo per day. This is the algorithm they followed. This is very interesting. First phase is giving randomization between the drug and placebo. After 48 weeks, it becomes open label. Those in the placebo who are still not achieve HBE into seroconversion, they will receive entecavir. And those in the entecavir who become seroconverted, then they will receive a consolidation phase of 48 weeks. So, and then they analyze the data. Entecavir response versus placebo week 48 after 1 year is a seroconversion 24% versus 3.3%. HbA1c loss is not significant. But if you see the week 96 data, this is not a comparison with the placebo. It is everybody received entecavir. One group who received 48 weeks, another 48 weeks consolidation. So there is incremental gain. HbA1c seroconversion improved from 24% to 36%, and HbA1c loss, which was just 2 patients, now become 5.8%. So the predictor of response on entecavir, baseline HBV DNA if it is less than 8 log, and non-D genotype. Important part is that what we commonly believe that if you have a high ALT, more than 2 times upper limit of normal, their chances of response is very good. But in this study, they couldn't find any significant difference between those who are having high, more than 2 times versus less than 2 times. The response was durable, more than 90% cases, and around 2.6% developed resistance. Next is about the tenofovir study, TDF. Randomized placebo-controlled trial, multicentric trial. But this is a 72-week study with placebo and followed by open label. Age, these are the older children, 12 years to 18 years. The standard inclusion criteria of immunoactive disease, and 300 milligram drug was given. There is a 2-arm, drug and placebo 51 and 50. The interesting part of this study is that almost 27% patients, they have normal ALT, and 85% are prior exposed to either lamivudine or interferon. So if you see the response at 72 weeks, their primary endpoint was virological response, means that DNA negativity or less than 400 copies per ml, not the seroconversion with tenofovir. It is very good. 90% kids has the viral suppression versus 0. And there is 74% biochemical remission, but HbA1c loss was almost negligible. Now, substantial virological suppression happened regardless of the baseline ALT. What I am repeatedly hammering that our ALT cutoff needs to be revised, irrespective of the E status or prior exposure to LAM. If you have a child who is exposed to LAM, tenofovir is showing good virological suppression. So regarding the tenofovir in 2 to 12 years age group, this Gilead Science is doing the study. This is there in the clinical trial registry website. They have published their result not as a paper, but in the site, showing good response in 2 to 12 years age group, 25% seroconversion and 10% HbA1c loss. Regarding the TAF trial is ongoing, but data is not yet available. Now coming to the PEG interferon, this is actually landmark study as far as hepatitis B in children is concerned, because after publication of this study, both US FDA and European Medicine Agency has given approval for use of PEG interferon in children with chronic hepatitis B. This was a randomized control open label trial phase 3 study of multiple center. 48 weeks of therapy versus no therapy, age group 3 to 18 years, standard inclusion criteria of immunoactive, but remember the 48% of this subset of patient children who receive PEG, their ALT value was less than 2 times upper limit of normal. Again, our conception that more than 2 times is a good prognostic factor may not be true. And they have assessed the efficacy 24 weeks after stopping the therapy. If you see the 24 weeks after stopping therapy, primary endpoint was the HBe antigen seroconversion, was achieved in 26% in PEG versus 6% in control. And logistic regression analysis showed that baseline low E antigen and DNA levels significantly predict the E seroconversion. Adverse event with PEG is very common. 80% kids, they have some kind of adverse event, but the drug discontinuation was extremely uncommon, just 1%, and drug modification was required just 6% cases. Now, again, interestingly, seroconversion was higher in younger kids. When you are treating a less than 12 years, their seroconversion rate was 30%, E antigen seroconversion versus 20% in more than 12 years. Now, what we have seen the 24 weeks after stopping therapy, what happened to the long-term effect of PEG interferon in E antigen positive patients? This is a study from Kunming, China, 118 children of chronic hepatitis B. They are treated 52 weeks of PEG interferon, but followed up for 104 weeks. And again, in this study, majority of the kids, they have ALT less than 2 times upper limit of normal. Their mother positive, very high DNA. Looks like this is a subset who had so-called immune-tolerant hepatitis B. If you see that results at 52 weeks, 156 weeks means after 104 weeks of stopping therapy, they have received 52 weeks of PEG interferon. E antigen seroconversion was 72% on the long term, and most important finding is that HbA1c loss, functional cure was achieved in 54% of the cases, and this durability was more than 90%. HbA1c loss in baseline ALT less than 2 times upper limit of normal versus more than 2 times normal. If you see those who are less than 2 times, they have a better response, 51% versus 39%. And the predictor of response is, as usual, genotype B, low body weight, and when there is a HbS level was low. Now, clinical predictors of functional cure in children, on the very young children, 1 to 6 years old with chronic hepatitis B. Again, the study from China, published recently. 1 to 6 years age group, 236 children with chronic hepatitis B, they received therapy as per the AASLD guideline. 98% they got the biopsy done. There are 3 groups of children. One received interferon regular monotherapy, 60 children. Another group, sequential therapy. First given the interferon. After 3 months, they assess whether hepatitis B DNA reduction is less than 2 log or more than 2 log. If it is less, they add a LAM, and third group, a combination of lamivudine plus interferon, 103 children. Total duration of therapy, 144 weeks. Now, if you see the results of HbA1c loss, functional cure, interferon monotherapy 51%, sequential almost 50%, but combination therapy is best. If you start LAM and interferon and given for 144 weeks in these younger kids, 71%. What they have shown, the E antigen loss is maximum in 1 to 3 years. If you are treating a very young kid, it is almost 80% compared to just 42% when it is treating 5 to 7 years age group. Highest response was in combo therapy, and the best predictor is young age and when the level of HbA1c is low. How young is young? This is another interesting study from China. Now they have targeted infants, means first 1 year of life, with HbA1c positive chronic hepatitis B with high ALT, high DNA, HbA1c positive, high ELT. Now they have this is a cohort study. The 2 group, one group less than 1 year who are treated with lamivudine alone because interferon is not recommended less than 1 year. And once they become 1 year, they have those who remain HbA1c positive, they added interferon. Another we have a cohort of 11 children whose parents refused to give lamivudine. They said, no, let's qualify to get interferon. So at 1 year, they started interferon and they added lam if they are not showing response. Now less than 1 year age group, the number is small, 18, but see the result. Their loss of HbA1c functional cure 83% versus just 36% if you wait till the child become 1 year and start interferon followed by lamivudine. So duration of therapy is 6 months versus 12 months, and HbA1c loss at 1 year. That means when one group is receiving LAM, another group receiving no treatment, to show that spontaneous seroconversion does not happen. 0%, those who didn't receive any therapy versus 50% who received lamivudine. So to conclude, we have approval for the use of most of the nucleoside analogs in children of more than 2 years, whether it is entecavir, tenofovir, TAP for more than 12 years. But if you want functional cure, means HbA1c loss, the still PEG is the preferred drug. It has a finite duration of therapy, more chance of functional cure, lack of resistance. Now we need to revisit our treatment criteria. So far, we talk about 1.5 times, 2 times upper limit of normal, but I highlighted most of the studies. In children, this sacrosanct figure of 2 times may not be important, and probably there is a window of opportunity age. If you can select the younger kids, their chance of having functional cure is higher. Probably they have not yet exhausted their immune system. And lastly, immune tolerant, probably we need to rethink about the standard definition of normal or minimally elevated ALT. What is normal ALT? Should we take it 30? Should we take it 40? Should we take it 35? We need to have a data to say what is normal in children, and then you apply 1 time, 1.5 or 2 times, because if you go by our old definition, we leave behind huge amount of children untreated and keeping them vulnerable to develop ACC as an adult. Thanks for your patient hearing.
So the next talk would be by Dr. Anil Arora, sir. And the topic is newer drugs and combination therapies for chronic hepatitis B.
Thank you and good morning to everybody. At the outset, I'm extremely grateful to Dr. Ajay, Dr. S.P. Singh, Manoj and the team for giving me this opportunity. The topic which has been allotted to me is new therapies, including combination therapies in hepatitis B. All of us as adults are pretty aware of the fact that we have a safe, effective, long-term oral therapy available for hepatitis B treatment. And fortunately for us, it's not difficult to remember. We have only, fortunately or unfortunately, 2 drugs, entecavir or TAF or tenofovir, as mentioned with the various guidelines. But if you look at what we have achieved with these antiviral drugs, they only suppress the virus. They try to normalize the ALT. They do prevent the progression of the fibrosis. They prevent the decompensation of an established chronic liver disease and prevent the attendant complication. But at the end of the day, we do require a long-term therapy which has its attendant side effects of the cost, adherence, and the toxicity. The rate of HbA1c clearance is practically negligible, and in spite of the fact that you have cleared HbS antigen or cleared HbE antigen, the risk of the HCC does not get totally eliminated, does decrease. We should also remember that when the patient comes to us as a treating hepatologist, he is looking for a cure of the disease. Somebody has diagnosed him to be having chronic hepatitis B. He wants the loss of HBV from his blood. Even if we are not able to get rid of his virus, we can at least try to destigmatize him. In Indian Asian culture, having an HbS AG is itself a stigma, and we may need to destigmatize her. But ultimately, what we end up doing is so-called partial cure. Partial, complete, incomplete, sterilization, these are all juggleries of our own inadequacies of the therapy. Patient has come to us for cure. And ultimately, the cure of hepatitis B is plummeted down to the lowest pedestrian when we only can at the most offer him a functional cure. And finally, the current therapy gives us only a ballooned partial cure of HBV suppression. And reasons for that are very simple, that have a huge viral burden and a weak immune response. I still remember my teaching from days of Dr. S.K. Acharya, who taught us in EB2 ward and gastroenterology way back in 1987, that a high viral load and low immune response will not let the virus go away from the body. That maxim still holds true. And the reasons lie in this life cycle of hepatitis B, which is peculiar to hepatitis C in the sense that virus enters the hepatocytes, attaches to a peculiar receptors, quickly unenvelopes itself, gets into the nucleus, integrates into the form of a cccDNA, and from there it makes a sweet home, producing millions and billions of the copies of hepatitis B, which are then passed back into the circulation to make merry at the misery of our hapless patients. So if we want to get rid of hepatitis B, we have to do three things. We have to inhibit viral replication, we have to plummet the high viral load, and we have to boost the immune response. First and foremost is you have to make all efforts to suppress DNA, try to reduce the viral antigen, which by default is trying to suppress your immunity, and make all efforts to stimulate your immunity. How do you do that? You can either try to enhance the innate immunity or try to invigorate the adaptive immunity. So that is the reason we have these new therapeutic modalities in the form of capsule assembly inhibitors. We need to control the post-transcriptional control of hepatitis B. We have to prevent the entry of the virus into the cell, and we have to use various ways of suppressing the virus hiding within the nucleoside. Starting with the first drug which came into the market for treatment of hepatitis B, in terms of the second generation of the drugs, is a drug which will prevent the entry of the virus into the cell by competing with the anti-CP receptor, which lets the virus enter into the hepatocytes and make a permanent home within the nucleus. So this drug called bulevirtide or mercuridex is more useful when it is used in combination with the nucleoside analogs, and recently has been approved by US FDA for treatment of hepatitis B and D co-infection. In addition, there are a myriad and swathe of other entry inhibitors in the form of farnesylide receptors and cyclosporin derivatives, as well as newer FXR agonists like vonapixor, which have been used for preventing the entry of the virus into the cell. And this is the current status. Most of these are still in the phase 1 and phase 2 trials, so there is nothing much to talk of the clinical data. But we should remember there are major challenges in trying to undo this, that these drugs do need prolonged therapy. There are safety concerns when you are trying to block the entry of the NTPC, because there will be a competitive inhibition of the bile acid entry into the hepatocytes. And whenever you are trying to neutralize the HBsAg in the blood by monoclonal antibodies, there are bound to be reverberation in the form of immune complex related injury. Can we make an attempt to reduce the replication of the virus within the hepatocytes? You can do it either by trying to prevent the conversion of the rcCDNA into cccDNA, or trying to suppress the replication or transcription of the cccDNA into a swathe of mRNAs which are going to produce proteins. So these are the various methodologies which are available in trying to attempt to reduce the cccDNA in the form of either trying to decrease the assembly of the formation of the cccDNA, trying to do acetylation and deacetylation of the mini chromatin, which is a component of the cccDNA, or you can even make an attempt to silence the DNA, cccDNA, without trying to remove it by these different methodologies which are available. In addition, another attempt is being made to take care of even the integrated DNA in the form of CRISPR technology, Zens and the TALENs. These are the agents by which you can go and try to mess around with the integrated DNAs in an effort to get rid of the DNA which has got integrated into the host genome. What is the current status of these agents which are trying to get rid of the DNA? And these again are, most of these are into the preclinical trials, but if you summarize the status, that whenever you're trying to mess up with the genomes of the human being, there is a chance of genomic instability leading to the host DNA cleavage. They are likely to be the off-target side effects, and because of the heterogeneity and the diversity of the pre-existing immunity of the HBV, you are likely to have problems. And this is what has possibly prevented the development of the gene editing techniques in trying to get rid of the integrated genome from the hepatitis B virus. Can we make an attempt to prevent the translation of the proteins which have started from the HBV cccDNA? There are two ways of doing it. You can use small RNAs, small interfering RNAs. You can use antisense oligonucleotides, or you can use ribonucleic acid enzymes. There have been various trials and various combinations, and these are the various drugs in the form of siRNAs and ASOs which are trying to look at the way the virus gets suppressed in terms of inhibition of the siRNA. But still, we do not know how to optimally use these agents in the armamentarium of HBV therapy. And we need to have a better understanding of the precise mechanisms of how these do acts. Another drawback of this strategy of siRNA inhibition in HBV replication is they are likely to have a plateauing effect after 16 to 20 weeks. That means irrespective of what you do, there are other mechanisms which will be bypassed, and hence the HBV replication will not get suppressed after some time. The next step in prevention of HBV replication is it possible that the virus once has formed, then you try to disassemble the assembly or try to stop the formation of a capsid assembly so that the virus does not get formed. So there are two ways of looking at it. There are two classes of capsule assembly modulators, also called CAM1 and CAM2. If you use CAM1, you are likely to have aberrant assembly formation, and if you use CAM2, you are likely to have empty capsids. And these are the various agents which are in the use in different stages of the clinical and preclinical development. And the drug like Verbicure is a first generation capsid inhibitor which has been evaluated in combination with nucleoside analogs. It is known and shown to have profound viral suppression. But if you look at the current summary of what is available, these are the various trials and tribulation which are occurring in treatment of hepatitis B. But we have to better understand the mechanistic ways to clarify if the new generation of the caps, that is capsule modulator, assembly modulators, have any direct effect on cccDNA, and this will be an added addition to the potentially useful agent in hepatitis B. Can we prevent the exit of the hepatitis B once it has had enough of its shape and form within the hepatocyte? These are the assembly release inhibitors. Why are we so obsessed with hepatitis B surface antigen? Because this is so important, because it forms the surface of the viral genome. This is an antigen which is important for the spread of the infection. This is an antigen which is important for the entry of the virus into the cell. This is the antigen which is a component of the small subviral particle. This is something which possibly tries to suppress, attenuate, and plummet the immunity of the immune system. And there are new class of drugs called STOPs, that is S-antigen traffic inhibiting oligonucleotide polymers. If you stop the release of the HBs antigen into the circulation, there may be some rejuvenation of the immunity. So these secretion inhibiting agents are possibly new class of small molecules, but we still lack large studies to confirm their role in the present armamentarium of hepatitis B therapy. The second component, as I mentioned, was a poor immunological response. Can we enhance that? We can enhance the innate immune system by trying to use the basic innate molecules, which are TLR7, 8, 9 agonist as well as the RIG agonist. And also we try to reinvigorate the other therapeutic responses which are specific to hepatitis B in the form of therapeutic vaccines. If you want to modulate the immune response, you have TLR7, TLR8, TLR9. There are different phases of the development. You have RIG and the PD1 and PD2 and PDL1 inhibitors, which try to stimulate the immune response in an effort to take care of hepatitis B, which is lying incipient in the hepatocytes. As of TLR, TLR7 and 8, these are non-specific stimulators of the immunity, which have their own flip side, that they will try to have inflammation in other non-specific organ sites, and it is difficult to deliver these agents into the circulation without affecting the off-site targets. Can we use checkpoint inhibitors like trying to give PD1 inhibitor or PDL1 inhibitors? These are still, we are far away from using it in the clinical practice, because understanding which patients are more likely to respond to checkpoint inhibitors will also depend on the baseline level of the PD-L1 and PD-1 in the different set of the individuals. And we should also remember that even in HCs today, there is no relation between PD-1 expression and the response to anti-PD-1 agents. Can we use therapeutic vaccines in an effort to get rid of the hepatitis B? The concept is that if you use a multitude of antigens, you will have a better response to antiviral therapy and will maybe able to get rid of the hepatitis B virus. But there are a lot of caveats in trying to develop these vaccines, and these important ones are, we do not know what is the best immunogenic composition. Should we use a polymerase S or the core antigen? Should we be using a B or a sealed antigen, which is a adjuvant? Which vaccine regimen which should shoot, and what should be the mode of the transmission? In fact, there are more unanswered questions in therapeutic vaccination for hepatitis B than the answered question we have. And hence we have this new immunotherapies to restore immunity, in which monoclonal antibody will do three things. It will prevent the entry of the virus into the cell. At the same time, it will try to jack up the immunity so that the virus is cleared. Can the combinations be useful? In fact, these are the various agents which can be combined in different ways to get rid of hepatitis B virus, but we do not know which cycles to combine, in which sequence should be combined, and what should be the duration of the therapy. So this is the landscape of what we are going to see in future in the next 5 years. To sum up, ladies and gentlemen, hepatitis B life cycle is complex, and as of now, currently we are dependent only on non-nucleoside analogs for treatment of the patient. And at the most we are getting is a partial or a functional cure, which is not enough because most of these drugs do not tackle the cccDNA, which should be the target. Entry inhibitors are approved for chronic hepatitis D, but not for hepatitis B. They are attractive options, but still they will not be able to get rid of cccDNA. There are concerns about genomic instability, and hence we are not able to reach the heights which are expected. Can we try to suppress the post-transplant transcriptional control of by using siRNA or ASO? Still they will not be able to eliminate cccDNA. CAMs or the capsid assembly modulators are at the moment the best drug of the available therapy for suppression of the HBV DNA and RNA. Stops and the nucleic acid polymers, the exit inhibitors are the promising new agents of the drugs. The suppression and of the other agents and trying to stimulate the immunity is another concept which is coming into the being. And finally, we may end up using a combo therapy, learning the good lesson from hepatitis C. With that, I'll end up my talk.
Thank you, Dr. Anil. Please join. Now we have the last speaker of this session, Dr. Paulo Resu. He is going to talk on the outcome and after the hepatitis C treatment with the DA. Dr. Paulo Resu.
Thank you very much, Chairman, dear colleagues. It's a great honor for me to be here in the double role as hepatologist and as INASL representative. As you know, our society is trying to get closer, and I hope this is the first step for long-term collaboration. The title of my presentation has been just said. I will talk about the treatment of HCV with EA and the outcomes of these patients. This is my outline. Very quickly, I will speak about the revolution of this therapy, the hepatic disease outcomes, the extrahepatic disease outcome, the patient-centered outcomes that is nowadays is very important, and how we can follow up these patients. We faced a great change in the treatment of these patients since the late 90s when the SVR was no more than 110%, and we are treating patients, and most of these patients can achieve the SVR. On the left side of this slide, you can see the timeline of the new treatment, but although we know at this time where these treatments are available, we use pan-genotypic treatment for all our patients. In some way, sometimes we don't even need anymore to do genotyping or fibroscan, because most of our patients can respond well in 8 to 12 weeks, rarely in 16 weeks. And what about the results? The results are very good, as we already mentioned. It seems that the fibrosis stage and the presence of HCC could be a risk factor for non-response to the first treatment. But we know that after we can retreat these patients with other regimens, having in the second case almost 100% of response. What about the disease outcome? Clearly, what we look about the disease outcome in patients with advanced liver disease, because we want to know what's happened to the natural history of cirrhosis in these patients. And this is a paper recently published by Pietro Lampertico group, where they checked for liver-related outcomes and events and non-liver-related events. As we can see from the slide, the liver-related events are those that are more influenced by the stage of liver disease, because they analyze patients with child A, patients with child B and C, and patients who had a prior hepatocellular carcinoma, while the stage of the liver disease did not influence the non-liver-related outcome. And again, regarding mortality, the stage of the cirrhosis did influence the mortality to liver-related and the non-liver-related mortality. But the first step is portal hypertension in these patients. So the first demonstration was by the group of Vienna and Barcelona, where they showed that there is an improvement in HVPG after the treatment with this regimen of pharmacy. And by the States, the group of Jordan-Feld showed that in decompensated patients, the response to this treatment is less, and also the survival in the child B and C is not different when you have response to the treatment and no response to the treatment, while you have the difference, important difference in the child A group. But even in those that have an SVR, there is no difference in the liver transplant survival, liver transplant free survival, if they respond or they don't respond, even in the child A group. What about hepatocellular carcinoma? We heard a lot of stories about the hepatocellular carcinoma, but I think this paper published in 2019 by the group of Palermo, they compared patients treated with EA and not EA, and they could see that there was an improved survival in these patients developing HCC compared to those that did not receive any DAA. So if we want to summarize what's happening to this patient, if we treat this patient clearly in the early phase, when they have a chronic hepatitis, we can halt the progression to cirrhosis. And the benefit of a CR is always less if we then treat the patient later on. But at some stage of cirrhosis, we might get also regression of fibrosis or cirrhosis, as we can say. And even if we treat the patients when they have a more damaged liver, we can still improve the survival of these patients. But as I mentioned, what is the mechanism to improve this? This is a really nice review written by Don Rock and Scott Friedman a couple of years ago, when if you remove the injury, and we saw before also in the HBV context, we can have some ACM degradation and hepatocellular hepatic stellate cells reversion and deactivation. So this will help us because we will have some specialized pro-resolving mediators. Maybe we won't get a restoration of the normal architecture, but we can really get some regression of fibrosis. And recently, this paper published by the Marcus Kornberg group, there is this new idea of reverse inflammaging. A very interesting paper. They make some, they took some tissue from patients that were treated with DAA, a patient with cirrhosis, patient with no cirrhosis, patient who had some hepatocellular carcinoma, and thanks to the tissue, they analyzed the PBMC, and they did the genome-wide DNA methylation analysis, and they could predict the biological age via epigenetic clock. So what they found that those that received the treatment, they have the age deceleration. That seems there was a better methylation in the cells in the PBMC that they analyzed. But this improvement did not found in the cirrhotic patient with ACC. So of course this is just a first step, but I think this might be very interesting in larger numbers of patients. And as we know, the health system asks also for cost effectiveness. And already in 2016, in these US treatment patients, they found the case averted regarding liver transplantation, decompensated cirrhosis, HCC, and Day-2 liver complications. So, of course, these treatments are also cost effective. What about transplantation? We saw a huge change in transplantation because the numbers of patients transplanted for decompensated HCV is dropped down and increasing the number for other diseases in both United States and Europe data. And of course, in patients that were treated being in the waiting list, there was the delisting. So patients that were in the list could get out of the list. Even then, there is some particular ideas on this, but which were the variables related to the listing, the MELD delta, and the delta albumin of this patient. So we also have some non-invasive tests that can help us to predict which will be the patient that will be delisted after the transplant. What about extrahepatic disease? As we all know, the HCV is a systemic disease, is not only an organ disease. So, of course, the most common complications are due to lymphoproliferative disorders, but the hepatitis C will affect different organs. And we know from this really nice meta-analysis by Patrice Kakoub that the impact of SVR on extrahepatic mortality is very important. I haven't reported all the single variables that they have checked, but we know that we get better, less cardiovascular disease, less diabetes, less insulin resistance, and all the possible manifestation of extrahepatic due to HCV infection. What about patient-centered outcome? This is another issue very important that we are looking a lot during the last years. And of course, again, in the cirrhotic population, as you can see, there is a quite good improvement in activity score, in the emotional score, in the systemic score, and in the worry score of this patient. And this improvement, as is shown in the figures, it gets in the first part, when the patient arrived, reached the SVR, and then remained stable after that. Of course, in the darker lines, we see the decompensated patients, and of course, this will be less important than in the non-decompensated patients. What about follow-up? This is a big issue. Actually, as INASL, we are preparing a position paper. So in the future, you will see the new suggestion by INASL. At the moment, of course, usually we discharge patients with F0, F2 if they do not have any comorbidities. We keep surveillance on HCC every 6 months in patients with advanced liver disease, and we do the surveillance for portal hypertension in a group of patients that already have viruses before treated with DAA, or they have some platelet less than 150 and elastography higher than 20. There is the risk of reinfection in the risk groups. Of course, we ask them to modify their risk behavior, and we repeat HV RNA in those patients that can be reinfected, for example, PWIT patients. But we heard this morning about non-invasive tests. Also here, we, led by the group of Vienna, we found some non-invasive tests that could help us, and then this became part of the Baveno 7. So if we take patients with a stiffness less than 12 and platelet higher than 150, we are almost sure that this patient will not develop any decompensation even after 3 years after the treatment. While if we take patients with a stiffness higher than 25, there will be almost 10% of possibility that they will develop a complication within 3 years after transplantation. Of course, there is the gray zone, as we saw also in the hepatitis B. And always the same collaborative study where we collaborated as well show that we can have also risk group for development of HCC. So high risk group always using some non-invasive test, high risk group that can arrive at 30% of possibility to develop the hepatocellular carcinoma. And we did in double assessment after 12 and after 48 weeks after the treatment. But this is a paper that is in press in clinical gastroenterology. Is again an international paper that shows that there are regional differences in the presentation prognosis of patients with post-SVR regarding hepatocellular carcinoma. And this the most important risk factors at the multivariate is the presence or not of surveillance. So those patients that get surveil, they will get probably hepatocellular carcinoma more than those that are survived after the SVR. And this is my last slide. It's very interesting as well, published by Jack Chatwell by Harvard University. So they, thanks to some statistical model, Markov model, they updated the HCC incident threshold for surveillance in virological cura, because so far the guidelines are based on very old data. So the guidelines suggest to have the surveillance in those patients that have 1.5 per 100 person per year, while the new data suggests the surveillance should be done when we expect 0.7 per 100 person per year. So this is something that we should think, and maybe the new guidelines will suggest to follow these new ideas. So in summary, current DHA-based regimens are highly effective and safe. Early treatment halt the progression to cirrhosis and allow for a decrease in healthcare costs. The eradication can prevent the complication of liver cirrhosis and extrahepatic manifestation, regression of fibrosis, reverse of inflammaging as we saw. I'm sure there are also other mechanisms that help in this, for sure, for example, some immunological aspect as well. We have seen that the non-invasive tests are available to protect the onset of complication. The ideal follow-up for all the range of these patients with advanced liver disease and cirrhosis is still debated. I would like to thank, in your language, I hope I will say the right way, Bahudam Yahad, I hope this. And I hope to see all of you in Milan at the INASL in June 2024. Thank you very much for your attention.
Thank you, Dr. Bishu. Please join. Now this session is open for question and answer. I invite any questions and comments. Yeah.
Question to Dr. Podar, Professor Podar, please. We have seen that the interferons, we have seen in adult population using interferon is very, very toxic drug. Some of the patients, measured, and significant number of patients don't tolerate it. Forget about completing 48 weeks. How is the tolerance in children in those studies that you have quoted? Number one. Number two is, do you think that treat them very early is the way to go?
Yeah.
With nukes?
Yes, regarding interferon in children, we do use it. Fortunately, the side effect profile, though similar, but not serious in children. I showed those data. Discontinuation for therapy is less than 1%. Modification requires, mainly for neutropenia and sometimes a flare of hepatitis, but discontinuation is not required. Most of the patients manage to continue for 48 or 56 weeks of therapy. Early treatment, I showed, yes, early treatment is the only way to go to achieve functional cure in chronic hepatitis B in children.
My question is to Noora. Is there any correlation of HBCRG with integration with human genome? Correlation of HBCRG with integration of hepatitis B with human genome?
It should be their responsibility.
Yeah, I'm not aware of data. Okay. So you're asking a very different question. You're looking at surface antigen levels and actually looking to see kind of if the surface antigen is from integrated sources versus intrahepatic sources and the sites. And I'm not aware of them actually looking at that correlation with correlated antigen.
Thank you.
My first question is to Dr. Terol. I'm considering that E antigen is one of the components of CR antigen. How would you think the performance of this test would behave in patients who are anti-E positive also? Do you think that the performance would come down, not just in who are E antigen negative, but those who have achieved successful seroconversion and who are now anti-E positive? Do you think the test would perform equally in that subgroup?
I'm trying to recall if, so the question is really for Hep B correlated antigen, which includes E antigen, would there be a difference in the performance of that test in the presence of antibody?
Right.
Right. And the answer is, I think, no, although I have to be honest that in the studies that have been done, they've not identified if they had antibody or not. But you're kind of highlighting, I think, or hinting at the fact that there could be complexes, right, of E antigen antibody that are potentially being captured. So I'm not sure it's been looked at in a way that would allow me to say definitively it makes no difference. But most of the patients, I think, have antibody that they're doing this assays in. So
We don't know.
I think they've not done that comparison.
My second question is to Anil. First, excellent presentation, excellent slides. If you look at NAPs, nucleic acid polymers, they are the one subgroup of of drugs which have given the best results as far as sustained off-treatment DNA absence is concerned. But all the data is from the company. There's nothing published. And the same data was available 5 years ago when I had given a talk on a similar this thing. Why is it that nothing has happened in 5 years in NAPs when supposedly the results are the best in that subgroup, in that drug group?
Yeah. See, the problem is this is whatever has been published, it goes with the premise that whatever replenishment of CCC DNA is happening because of the recycling. So that nobody is sure. Unfortunately, Dr. Nora would try to justify what I'm saying. We do not know the source of the DNA, whether it is coming from the CCC DNA or integrated DNA. If we presume then giving NAPs is going to plummet the levels of the DNA in the blood, then we presume that it is all related to the CCC DNA which gets replenished. But if the major component of the DNA is coming from the integrated DNA, then it will not be helpful. Unfortunately, there is no way to distinguish between the two. And hence, you have to indirectly rely on things like HBV RNA and the HBV correlated antigen, which is a direct reflection of the transcription of the CCC DNA. That may be one of the reasons.
Ujjwal, actually, I'm intrigued at some of the results which you presented. And one of the major results that you can clear functional loss if you start interferon at the age of 1 month, right, in those patients who have HBsAg positivity. And HBsAg loss in infant, if you treat with interferon alpha, is about 55–56%. But on the other hand, there are hundreds of studies which shows that they are immunotolerant, and as they grow up, they have spontaneous clearance. Therefore, if you see adult patient as a cross-sectional who had been infected in childhood, irrespective of whether they are vertical or a horizontal transmission, you will find 75% of them do not have liver disease, but is so-called chronic hepatitis B virus E negative infection without disease. So how do you know that they are spontaneously not clearing and interferon is helping? Because there is no control group in those studies where they have followed up equally, see the spontaneous clearance rate. Mind you, the follow-up is at best 2 years. Right, it's not 10 years or 12 years. So that's a big surprise that whether on those basis, on those studies, whether you can recommend treatment of children with interferon alpha. Because functional cure, if it is 85%, nothing like it.
Yeah.
But you have achieved it. It's like hepatitis C virus infection at clearing at 85%.
So
that's a big.
Yeah, that is the numbers are mind-boggling. But that's our age group. What they said is less than 1 year with ALT elevation. That means they are indeed immunoreactive phase more than 2 times. then they have treated and got this figure.
Sir, sir, sir.
That is a problem. You see, many of these patients who clears the virus and reaches the adult group, nobody has followed them over 20 years to see what is the ALT flare. ALT flare is your immune-mediated actions. So there might be silent ALT flare, some degree of fibrosis, which get reversed once the replication is stopped. So the natural course of hepatitis B virus, right, is actually interesting, right? A group of boys will clear it, whereas another group will not clear, and there will be abortive event. What we call as HBe positive or HBe negative chronic hepatitis whom you treat, right? So, or later on. So there is a big problem there.
Dr. Mish-
Before you recommend that interferon can be given.
Dr.
I
Michel.
was to ask a question, I will not ask the question. Three of you are there in the chair. I was the first to come over here. Everybody has to seek your permission to speak. You're not there sitting idle over there. So that's your job to do.
Good afternoon. I have a question for Professor Russo. So, what should be the ideal surveillance protocol for the high-risk population like HIV, IVDU, and MSM once they have attained SVR? Because they will be at the risk of reinfection as well as progression of disease, which would be faster in them.
Thank you for your a very interesting question. Of course, they have to be retested for HIV RNA because they are at risk, as you were saying, at least once a year. And every time, maybe you can see higher liver function test. And regarding the disease, as you see, I mean, when they do not have when they have early disease, without comorbidities, they can discharge. Otherwise, if they have important comorbidities as other virus, as HIV patients, I think they need to keep in follow-up, at least every 6 months.
Every 6 months.
Dr. Singh.
Yeah. Question to Dr. Paulo. This is regarding the patients who have received the DAA and there is a SVR. If there is no fibrosis, in them we usually don't do the surveillance for the HCC. But there were large number of abstracts in the ASLD when I reviewed. And in that, there was a higher prevalence of the HCC in the long-term follow-up in these patients. So what do you say regarding this group which is not having fibrosis? And do we need to do the surveillance, long-term surveillance for the HCC in them?
I mean, in the non-fibrotic patients,
Yeah.
If they don't have lots of comorbidities, we are not supposed to do any surveillance in this patient. I mean, in my institute, I prefer to see them maybe every 2-3 years. I tell them I shouldn't see you anymore, but I'm happy to see if you are happy to come to the hospital. But I should discharge from the hospital. But they are very happy to come every while. But now that we have more and more patients, so our patient clinics are full of these patients, it would be very difficult to keep, also to see them every 2-3 years.
Thank you.
Last question.
Okay, I think again, very nice session overall, and I must compliment all these speakers for this. I have a small question for Dr. Russo. The story about HCC and DAs has been rested. We know that they're not at high risk. But then we know that these patients who are cirrhotics, even if they achieve SVR, they still get HCC because of the cirrhosis. And one reason people have looked into their studies to say that these patients, even if they have some reduction in fibrosis, there's some increase in hepatic steatosis in them. And that steatosis is probably because of the metabolic dysfunction these patients can develop, not related to the virus. And that can actually put them at a higher risk of HCC. Your thoughts on that?
I totally agree. There is a publication last year from Luca Valenti where they evaluated the patient with steatosis in the group of patients treated for HIV. So that's another risk factor that we should take in consideration when we think about the surveillance. But I think even if we have a better stiffness after the treatment, we can use as a cutoff those that I showed to stratificate those that we should keep on surveillance or not.
Subsequent to that questions to you,
very
that's
short,
one
sir.
question. Is there a randomized data, that after SVR, in non-cirrhotic but advanced fibrosis, HCV screening, not only increased detection, increased survival? I don't think there is any randomized data. Second problem, if you put every patient into surveillance, there is also a side effect of surveillance. False detection, unnecessary biopsy, unnecessary risk, and also the human psyche. So I don't think that has been very clear with the available data. And third thing is ultrasound and alpha-fetoprotein or PIVCA or AFP3 still now inadequate biomarkers, which will miss 40%. Now, if you miss 40% of HCC, and the sensitivity is 63% if you combine ultrasound and alpha-fetoprotein. So those are problems I think must be remembered when you are suggesting surveillance. So therefore, those who have SVR, no fibrosis, absolutely functional liver status, other no risk factor, I think surveillance should not be recommended.
Okay. Thank you very much, because we don't have time. I thank all the speakers, learned speakers, and my co-chairperson, and we had a very beautiful interaction with the audience. Thank you very much. So I end this session.
Thank you so much to everybody. Now we move forward with the session 4, hepatic fibrosis, and the chairperson for the same are Dr. Manisha Devedi, Motilal Nehru, Allahabad, Dr. K.T. Shenoy, Sri Gokulam Medical College and Lord's Hospital, Tiruvananthapuram, Dr. G.N. Ramesh, Aster Med City Hospital, Kochi, Manoj Kumar Sharma, Institute of Liver and Biliary Sciences, Delhi.
The next session is on non-invasive tests for hepatic fibrosis, diagnostic performance and limitations. It is to be delivered by Dr. Meena Bansal.
Great, thank you very much. Thank you to the INASL Organizing and Singing Committee for this great invitation. I'm going to be speaking on non-invasive tests for hepatic fibrosis, or NITs. These are my disclosures. So I'm going to first provide a very brief conceptual framework of NITs, emphasizing the importance of fibrosis, population-based screening in high-risk groups, the rule-out approach, identifying at-risk NASH or MASH, because this is the target population for both clinical trials and any FDA-approved treatment labels. How do we monitor response to treatment given the heterogeneity of disease, the different mechanisms of action of different drugs? We need to understand who's a responder and non-responder, progression to cirrhosis, predicting clinical outcomes. And I really want to emphasize at the end this idea of fibrosis progression, really having more of a longitudinal view in an individual patient as opposed to a cross-sectional view. And Quentin kind of alluded to this as well. So we've known for a while that fibrosis is the single most important determinant of liver-related outcomes. Once you hit stage 2 to 3 fibrosis, your risk of liver mortality is 10 to 17-fold higher. And NITs can broadly be broken down into blood-based markers like indirect, which may reflect hepatocyte injury or function, or direct, which actually reflect extracellular matrix metabolism. There's also imaging modalities, either ultrasound or MRI, liver stiffness assessments. So direct biomarkers capitalize on the idea that fibrosis is a very dynamic process. Arun mentioned this as well. You have two concomitant things happening. On the one hand, you have fibrogenesis, but at the same time, you have fibrinolysis. And which of those pathways is winning will determine whether you're going to have fibrosis progression, fibrosis regression, or stability. So in my mind, I think about the activated stellate cell pumping out single fibrils of types 1 and 3 collagen under the influence of profibrogenic cytokines such as TGF-beta 1. The N-terminal peptide is then cleaved and can be measured by ProC3 or P3NP. Those fibrils then join forces with different glycoproteins to form a triple helical structure. They are extensively cross-linked by lysyl oxidase, and then you have macrophages coming in and releasing matrix metalloproteinases to degrade that collagen. C3M is an MMP9-mediated degradation product of type 3 collagen. So these are released into the blood and can form the basis of direct biomarkers such as ELF, which is made up of P3MP hyaluronic acid or TIMP1. Now, Quentin went through this, so I won't go over it again, but for screening large-scale populations, we really have the rule-out approach where we want to make sure we don't miss people with advanced liver disease. The only thing I'll add here is that some have proposed a difference age cutoffs, so for age over 65 using a FIB4 greater than 2.0 or age less than 35 using a FIB4 cutoff of 1.0, since age is inherently part of the equation. And we went over this as well. So let's think about, we want to identify those who are at risk NASH or MASH, and that's defined as having a NAFLD activity score of greater than or equal to 4 and at least stage 2 fibrosis, because this is the patient population that's going to be in clinical trials and will be on the label for hopefully soon to come FDA-approved therapies. And Quentin talked about the issue of the indeterminate or gray zone when you use FIB4 alone, suggesting that we need to do either sequential or combination NITs. So what are some of the combination NITs that have been looked at to identify at-risk NASH? Newsom and colleagues did a derivation cohort in 7 centers in England and then validated across 7 international cohorts. The areas under the curve varied from 0.74 to 0.95. The positive predictive value was 0.83 for a FAST greater than 0.67. Negative predictive value ranged from 0.73 to 1 for a FAST of less than 0.35, which is the rule out zone. And as Quentin suggested, performance always is dependent on prevalence of disease in the community, and this performed poorly in low prevalence settings. Still a wide gray zone, 16 to 44%. And when this was applied to the NASH CRN cohort, the area under the curve was 0.81, negative predictive value 0.9, positive predictive value of 0.69. And very interestingly, it performed better in non-whites versus whites and better in those with a normal BMI versus those that are obese. Now, the MASS score is a very similar score that utilizes steatosis being measured by MRI-PDFF or liver stiffness by MRI, and AST is a marker of inflammation. And in a derivation cohort in California and then a validation cohort in Texas, MAST compared to NAFLD fibrosis score or FIB4 resulted in fewer indeterminate scores and a higher overall area under the curve. Compared to FAST, MAST exhibited a higher area under the curve and overall better discrimination. Now, the MEFib index was mentioned earlier. This is a binary test, so you're either positive or negative. MEFib positivity is defined as an MRE greater than or equal to 3.3 and a FIB4 greater than or equal to 1.6. When this was looked at a prospective cohort in both San Diego and Japan, it demonstrated a 97% positive predictive value for stage 2 fibrosis in the San Diego cohort and 91% in the Japanese cohort. Now, there's not that many studies comparing these head-to-head, so in this one study, MEFib was superior to MAST or FAST for the detection of significant fibrosis as well as the detection of at-risk NASH. Now, Arun mentioned ruling in advanced fibrosis or cirrhosis. So this was a retrospective study looking at 7 cohorts across North America, Europe, and Asia, and externally validated in the NASH CRN and the French cohort. They constructed 2 scores, Agile 3 and 4, which include liver stiffness by elastography, platelets, AST, ALT, diabetes, sex, and age in the case of Agile 3. And the key was that it was narrowing down the indeterminate zone. When this was applied to an Italian cohort, the area under the curve for liver stiffness and Agile 3 Plus was comparable for advanced fibrosis, but again, the gray zone now was 8% compared to 13% for stiffness and 25% for FIB4. Now, what about predicting response to treatment? I had to remove my OCA slides. So hopefully resmetirom, the thyroid hormone beta agonist, will be an FDA-approved therapy soon. So how do we know if a patient is a responder to this treatment as early as possible? And can you apply response in the context of clinical trials to real-world experience? In their phase 2 study, they looked at 12-week MRI PDFF and had week 36 biopsies. And what they found were those who had at least a 30% PDFF reduction at week 12 had higher rates of NASH resolution on that week 36 liver biopsy compared to non-responders. Now, in this study, those that were in the placebo arm were offered a crossover to open-label resmetirom. And what you see here is those in orange were on resmetirom throughout the entire course. And you can see this steady decline in PDFF and PRO-C3, which is a marker of fibrogenesis. When you look at the blue line, you can see a pretty flat pattern when they're on placebo, but then as soon as they turn on to study drug, you see this decline in both PDFF and PRO-C3. Similar results were seen with FibroScan. And when you look at the ratio of PRO-C3 to C3M, you see this decrease that is suggesting less net fibrosis formation. Now, what about progression to cirrhosis? So these are data from the negative simtuzumab and serlonsertib studies, and what they demonstrated was that baseline liver stiffness of greater than 16.6 was associated with a 4-fold higher risk of progression to cirrhosis. In addition, an ELF score greater than 9.76 at baseline, as well as a greater change in ELF, was associated with an increased risk of progression to cirrhosis. Now, this is probably the most important point. For the first time, Arun showed that cirrhosis regression is associated with improved clinical outcomes in patients with NASH. So if we have a treatment and we see that fibrosis decreases, but the patient still dies of a variceal bleed, we really haven't achieved much. So this was the first time that we can really say that improvement in fibrosis will correlate improvement in outcomes. Now, what about predicting clinical outcomes from the get-go? So the top study is from the Mayo Clinic, where they showed that baseline MRE of 8 kilopascals was associated with 20% chance of decompensation at 1 year compared to 9% at 5 kilopascals. In the lower study, MRE with a cutoff of 6.48 was associated with decompensation and mortality. And for each increase by 1 kilopascal, the odds ratio of decompensation increases by 3.28. In a systematic review and meta-analysis of individual participants in 6 international cohorts with NAFLD who underwent MRE, you can see again this baseline MRE was associated with the risk of developing liver-related events, and importantly, a negative MEFib was associated with a less than 1% chance of having a liver-related outcome at 3 years. Similarly, the MAS score can predict major adverse liver outcomes. A MAS score between 0.25 and 1 predicted a 22-fold increased risk of adverse outcomes, and a slightly lower threshold of 0.165 to 0.42 was associated with an increased risk of 7.75. Again, from the simtuzumab studies, the ELF score at baseline of greater than 11.27 was associated with a liver-related event. And at baseline, liver stiffness of greater than 30.7 predicted hepatic decompensation. And this is something that Quinton showed this as well, but I think that the point is really deserves some further discussion. The key is really looking at the trajectory for an individual patient. So if you're monitoring them over time and you're seeing that they are progressing more rapidly, their FIB4 is increasing more rapidly versus staying the same, you're really identifying that person's individual risk. I always say to my patients, I don't know what the slope of your line is, and we need to understand that. So having these serial assessments, I think, is better than having a single point in time. Where were you yesterday and where are you going tomorrow? And this was similarly shown with liver elastography, where increases in liver stiffness was independently associated with poor clinical outcomes in NAFLD. So, when we talk about screening high-risk populations, FIB4 is clearly a great first line of defense. It's cheap, it's easy to calculate, and it's readily available. We have a problem with the gray zone, and so either sequential or I showed you some examples of combination testing to try to decrease that gray zone. Identification of at-risk NASH will be our task now if we have FDA-approved therapies. Fast, MAST, MeFib, depending on the population that you're testing, Agile 3, all work well. I will caveat that, and Quentin made this point as well. All of these populations where these have been tested have been hepatology patients, right? They're in clinical trials. They've already identified themselves as high risk, so the prevalence of disease is higher. How they will perform in the general population, I think, needs further study. In terms of response to resmetirom, a 30% reduction in MRI-PDFF at week 12 could predict those that will respond. Pro-C3 to C3M ratio is great, not necessarily commercially available yet. Decreases in VCTE. I didn't show it here because it's going to come out with the 52-week biopsy study, but sex hormone binding globulin reflects target engagement for resmetirom, and so those who have an increase in SHPG had predicted a response. Progression to cirrhosis, baseline VCTE of 16.6 or higher, ELF greater than 9.75. Predicting major adverse liver events, ELF greater than 11.27, VCTE greater than 30.7. I didn't go into corrected T1, but that's certainly very good as well. MAS greater than 0.25, a positive MeFib index. And longitudinal changes over time are more important than a single cross-sectional view. You really want to understand the slope of the line for your individual patient. Thank you.
Thank you, Dr. Bansal. Now the talk is open for discussion or comments. But before the floor people take over this, I can request my co-chairs, if they have a question, they can set the ball rolling.
Can you spell out the duration between two fibroscans to show a significant difference? Your
Sure.
slide mentioned about 1 year, but is it the minimum time or is it the permissible time?
Well, I think that we all understand the issues with reproducibility with FibroScan. So, there's certainly a lot of inter-observer variability, with the operator, there can be a lot of variability. But when you're talking about following a patient longitudinally, we do it annually. If I'm very concerned about a patient, someone who's more in the F3 range, I might do it every 6 months.
The baseline value falls at, say, about 9 kilopascals.
Yeah.
Your interval will remain the same compared to a person with 15 kilopascals.
No, the person with 9 kilopascals is definitely different than the patient with 15 kilopascals.
Thank you, Professor Bansal. So one important issue about using specific cutoffs always remains a spectrum bias. So spectrum bias, because the specific cutoff in a population will depend on what is the prevalence.
The prevalence in the population,
so how
yes.
do you tackle these?
Certainly these cutoffs were developed in that particular population in which it's studied. So certainly, as I said, there is going to be a selection bias because most of these have been studied in those who are high risk to begin with. So the prevalence is going to be higher, the performance of the test is going to be better. So some of these may not be applicable in real-world application to patients. That remains to be studied and seen.
Okay, questions from the floor, yes?
I was interested in whether we have any markers of insulin resistance which are incorporated into these NITs, like abdominal girths or triglyceride to HDL ratio, and why are not there any tests based on these markers?
Well, diabetes is in many of them, right? So diabetes is in the Agile score, the presence or absence of diabetes, which would suggest
that is after the occurrence of diabetes. Before the occurrence of diabetes,
yeah.
The other markers of insulin resistance, we have the triglyceride HDL ratio, we have the waist circumference. So why these markers are not getting included in this NITs. These are
Yeah.
very easy to know, and we can see the patient has insulin resistance. He walks into the room.
Sure, sure. I think this was discussed a little bit this morning. So these are NITs for fibrosis, right? So they're actually trying to assess the amount of fibrosis in the liver. Certainly what you're describing are risk factors for people who are likely to have more advanced fibrosis, and that defines your screening population. But these NITs are really looking at fibrosis.
Dr. Ajay?
Very nice talk, Dr. Meena. I think just two comments I would say rather than questions. I can't see Dr. Arka, my colleague. So our group actually had published this our own data on FAST score. As you said, its NPV and PPV would depend upon the prevalence of disease. So in our cohort where we looked at the FAST score and validated, so the prevalence of NASH, histological proven NASH, was close to 28%.
How much? 38?
28.
28.
So when we applied the original Newsome data to our set of patients, the NPV and PPV was really not good. So we actually recalculated these cutoffs for our population, and we came out that the rule-in cutoff and rule-out cutoff for our population has to be different. So it was, if I remember, 0.78 and 0.55 rather than 0.67 and 0.35. So what I'm saying is, as
Yes.
you rightly said, it depends on the prevalence of a disease in that population. The cutoffs will depend on that. That's number one. The second, we are presenting in this meeting data on Agile 3 and Agile 4 scores, and again, Indian cohort. We have a consortium in India called Indian Consortium on NAFED, and we have a data of close to 8,000 patients. So in that, when we looked at the biopsy-proven NASH were only 381. When we applied Agile 3, we found, yes, it is good, and it actually also reduces the gray zone. But when we applied Agile, 4, I think we found that, yes, it is really not helping, and Agile was as good as LSM or even FIB4, and it was even not reducing the gray zone. So I don't know, maybe again it depends on maybe the population prevalence or something. So these two posters from ICON we were presenting in this meeting here.
Thank you.
Dr. Sanjay?
Thank you, Dr. Bansal. Your talk was limited to fibrosis. And if you would wish to extend your views on what is the status of non-invasive imaging for steatosis, whether that is going to help us in the future, or how could we use this in clinical practice?
I think that steatosis is more, do you have it or not? Because in some people, a small amount of steatosis causes a lot of fibrosis. So the dose-dependent effect of steatosis is less clear. We know time and time again, the only thing that matters to predict clinical outcomes is fibrosis, which is why the emphasis has been more on fibrosis. To identify those that have steatosis, certainly MRI PDFF can get down to 5%. But that's not readily available. Ultrasound maybe 20%, and FibroScan maybe down to 11%. So I think all you want to know is it there or not? And I think that we probably have good enough modalities for that. And if you have fibrosis, irrespective of the steatosis, you have a concerning liver disease that needs to be dealt with.
Thank you.
Your views on the level of microRNAs to predict fibrosis, number one. Number two, the role of liquid biopsy in predicting fibrosis.
Sure, there's a lot of other novel, NIS4 is one that has microRNA, YKL40, so there's certainly a lot more proprietary biomarkers that are out there. I think it remains to be seen if they perform significantly better to justify the cost. And I think that's been the issue. FIB4 is just for large-scale screening. It's a good first line of defense. And then we might need to get into these more nuanced ones. And I think for monitoring response to treatment, these could be very important. That's where we lack the most, actually, because we're going to have different therapies. Payers are not going to pay for them endlessly. They're going to say, is your patient responding to this therapy? How quickly can you tell me? Because when a response rate for resmetirom at 52 weeks is 24%, there's 75% who are not at that moment. Maybe with more time, you would have more responders. But the key is, what biomarkers do we have that quickly say this mechanism of action is addressing the driver of NASH in this patient, and therefore this is the right therapeutic that should be continued for a certain period of time, and then an add-on therapy or a change of therapy.
Okay, I think there are no more questions. We still have 1.5 minutes left. Just a short question for the benefit of the residents. With so much of development happening in this front, what do you think today the role of a liver biopsy would be?
If you don't know what you're dealing with. So I think really in clinical practice, the only time to do a liver biopsy is if you're not sure of the diagnosis and you need to rule out autoimmune disease, Wilson's disease, some other thing that could mimic or look like NAFLD. And if you have a lot of discrepancies in terms of your NITs, that's another option, is to clarify the amount of fibrosis there.
Thank you very much with this message. I think, thank you very much for that very comprehensive presentation, and thanks to the organizers for this opportunity.
Thank you.
Thank you so much to everybody on stage, and thank you so much to the speaker as well. Now we move on with the session 5, Ascites and Acute Kidney Injury, and the chairperson for the same are Dr. Vivek A. Saraswat, Mahatma Gandhi Medical College and Hospital, Jaipur, Dr. Virendra Singh, PGIMAR, Chandigarh, Dr. Anup Saraya, AIMS, New Delhi, Dr. Gaurav Pandey, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, Dr. C.R. Khatwa, MKCG, Barampur.
Thank you very much. And we have the session on AKI and the ascites. And the first speaker is Dr. Paolo Angeli. He doesn't require any introduction for this audience. And his topic is the biomarkers, its role in cirrhosis and AKI. Dr. Paolo, please.
Dear Chair, dear colleagues, first of all, let me thank the organizer for this kind invitation. I'm very happy to be here again and to find a lot of friends. What I need for the next time is to have an Indian passport to avoid the request of visa every time. Well, these are the renal biomarkers I will speak about: cystatin C, neutrophil gelatinase-associated lipocalin, IL-18, kidney injury molecular 1, liver fatty acid binding protein, and tissue inhibitor metalloprotease 2. As you can see, with only one exception, KIM1, all have different origins in the human body, not only in the kidney. Only one, cystatin C, is an index of renal function. All the other are indexes of renal injury. All them have a time to expression quite short, and all them, with only one exception, are indexes with some strong limitation in their applicability. These are the renal biomarkers, and these are the questions I will try to address in my talk. Are they useful in predicting AKI? Are they useful in making the differential diagnosis among the different phenotypes of AKI? Are they useful in predicting the response to terlipressin plus albumin in patients with HRS-AKI? Are they useful in predicting recovery or progression of AKI regardless the phenotype? And finally, are they useful in predicting the need of RRT in patients with AKI? Let me move from the first question. Well, we can see that cystatin C is better than NGAL in predicting renal dysfunction in patients with decompensated cirrhosis. Is better than creatinine and NGAL in predicting the development of HRS-AKI in this patient. And is better again than creatinine and NGAL in predicting the development of acute on chronic liver failure. Cystatin C is also capable to predict the development of recurrent AKI because of the probability to develop another episode of AKI is dependent upon prior AKI, serum bilirubin, and serum cystatin C. What we learn from omics in this setting? Well, we learned that in patients with sepsis or with acute on chronic liver failure, that there is an altered degradation of tryptophan through the kynurenine pathway. The most important key in this pathway is the last one, the conversion of quinolinic acid into NAD, nicotinamide adenine dinucleotide, that is a powerful antioxidant. This key step is catalyzed by quinolinic acid phosphoribosyl transferases, which activity is downregulated in patients with sepsis and in patients with ACLF. So it is not surprising that the increased urinary level of quinolinic acid can be found in patients with sepsis and can be found in patients with acute on chronic liver failure. And it has been observed that the urinary level of quinolinic acid, sorry for the slide, can predict the development of AKI in patients with decompensated cirrhosis. Let me go to the second question, probably the most important one. Are biomarkers capable to make the differential diagnosis in between HRS-AKI and ATN-AKI easier? Because, you know, we have 4 different phenotypes in patients with cirrhosis, but let me say that in most of the cases, pre-renal failure is solved by plasma volume expansion, and post-renal AKI is rare. So the real problem is to differentiate in between ATN-AKI and HRS-AKI. And what we have is our old definition of hepatorenal syndrome, according to which we are speaking about a functional renal failure. What does it mean? It means without parenchymal damage. And so we are going on making the diagnosis of HRS-AKI based on our old criteria. So no response to plasma volume expansion, no shock, no previous or current treatment with nephrotoxic drug, no evidence of parenchymal damage on the basis of significant proteinuria, significant hematuria, or abnormal ultrasonography of the kidney. But we all know that if we apply a platform of biomarkers, particular of biomarker of tubular damage, abnormal values are present not only in patients with ATN-AKI, but also in patients with HRS-AKI, comparing to patients with pre-renal AKI and to patients without AKI. The higher number of these biomarkers with abnormal values, the lower probability you have to make a final diagnosis of HRS-AKI. Why does this occur? Because nobody in this room thinks anymore that HRS-AKI is related only to renal hypoperfusion. There are at least 3 more powerful drivers that are microvascular dysfunction, direct tubular damage, and overall inflammation and oxidative stress. So we should change our view, our vision, our definition on HRS-AKI. HRS-AKI is probably predominantly functional in nature, but frequently it is associated to some degree of parenchymal damage, putting HRS-AKI in the middle between functional AKI and structural AKI, in the middle between pre-renal AKI and ATN AKI. But let me go back to the question, are these new biomarkers useful to facilitate the differential diagnosis between HRS-AKI and ATN-AKI? The answer is yes. You can see that urinary IL-18 and overall urinary NGAL have enough sensitivity and specificity to make this work more easier. This is particularly true for urinary NGAL because there is not much overlap between the values in patients with HRS-AKI and in patients with ATN-AKI. But if you don't have urinary NGAL, you can use urea clearance that has enough sensitivity and enough specificity to differentiate between ATN-AKI and non-ATN-AKI. And if you don't have urea clearance, you can use a fractional excretion of sodium higher than 0.567, which is even better than urea clearance in differentiating between ATN-AKI and non-ATN-AKI. But let me go to the third question. Are the biomarkers useful to predict the response to treatment in patients with HRS-AKI? I'm speaking about terlipressin plus albumin. The answer is yes, to some extent, because if the patient has a urinary NGAL higher than 220 nanogram per ml, the probability to be a responder to the treatment is below 35%. And in our hands, urinary NGAL was the only strong predictors of non-response to the treatment. Well, let me go on to the next question. Are these biomarkers useful to predict recovery or progression of AKI regardless its phenotypes? The answer is yes. Again, you can see that urinary NGAL and urinary albumin are much higher in patients without renal recovery than in patients with renal recovery in this large series of patients with AKI. And you know, it's not surprising to see that if the urinary NGAL is very, very high, more than 500 nanogram per ml, there is a high probability of progression of AKI. So if we look to the multivariate analysis, again, we can observe that the stronger independent predictor of no resolution of AKI is to have a urinary NGAL higher than 500 nanogram per ml. What about the other predictors? Let me focus on the presence of cast and renal tubular epithelial cell in the urinary sediment. As you can see, it was found not significant, but if you don't have NGAL, if you remove NGAL from the analysis, then it will become significant. So you can use it to define the probability that AKI will solve or not at 7 days. What about the SOFA score? In my mind, a nice SOFA score means ACLF, acute on chronic liver failure. So it is not surprising to see that in patients with ACLF, the progression of AKI is quite frequent, up to 60% of patients. What we learn from omics in this particular setting, let me say nothing. I mentioned it before, or the metabolites of tryptophan, and you can see there are no difference according to the fact that this patient will recover or not recover from AKI. I spoke about progression of AKI. What does it mean? On the histopathological ground, it means evolution toward cholemic nephrosis, or more frequently, acute tubular necrosis. On the ground of definition, progression of AKI means progression to acute kidney disease or chronic kidney disease. And you know, we have some strong predictor of progression to CKD in patients with AKI. Again, a very high urinary level of NGAL or the no resolution of AKI at 7 days. The progression towards AKD or CKD will require sometimes the need of RRT. So the last question, are the biomarkers I mentioned useful to predict the need of RRT in this patient? The answer is yes. You can see, again, the presence of septic shock, ISOPA score, urinary NGAL, the presence of CAST or renal tubular epithelial cell in the urinary sediment can predict the need of RRT. What we learn from omics in this particular setting, I mentioned the olinic acid before. Let me say that the level of olinic acid in serum is capable to predict the need of RRT in this patient. So let me summarize what I said. AKI is a frequent severe complication in patients with decompensated cirrhosis. The differential diagnosis between HRS-AKI and ATN-AKI is complex because HRS-AKI is frequently associated with some degree of parenchymal damage. But the new biomarkers, particularly urinary NGAL, can facilitate the differential diagnosis in between HRS-AKI and ATN-AKI. And the new biomarkers, particularly urinary NGAL, are promising tools in phenotyping AKI, but also in predicting its evolution in patients with cirrhosis. And thank you very much for your attention.
Thank you, Dr. Paulo. Please take your seat on the dais. And now I invite Dr. Rakhi Maiwal. She is Professor of Hepatology at Institute of Liver and Biliary Sciences, New Delhi. She doesn't need any introduction. She is already a rising star from this part of the globe. Over to Rakhi.
Thank you, sir. And I would like to thank Professor Duseja, Professor Singh, Dr. Manoj for inviting me and also giving me an opportunity to talk about refractory ascites, newer concepts in the management. So this is going to be the outline of my talk. So starting with the definition very briefly, we know refractory ascites is something which cannot be mobilized or the early recurrence of which cannot be prevented after therapeutic paracentesis by medical treatment. And by medical treatment means maximal dosages of diuretics, that is the diuretic resistant, or where you get side effects of the diuretic therapy or the diuretic intolerant, which is the larger group and the set of patients that we see in a clinical practice. The pathogenetic basis, we know the driver and the key factor is the portal hypertension. They share stress on these splanchnic vessels, production of local vasodilators, splanchnic vasodilatation, decrease in the effective arterial blood volume, and activation of the various vasoconstrictor systems. And this results in sodium and water accumulation and vasoconstriction in the renal vascular bed. And along with this, we know that recently, the role of damage-associated molecular patterns and pathogen-associated molecular patterns and gut dysbiosis cannot be forgotten because this drives the systemic inflammation, which is seen as a key driver in progression and rapidity of ascites worsening in these patients. So what is the medical management? Obviously, the first step is to identify the etiology of the liver disease and treat it accordingly. And over here, I just would like to mention about non-alcoholic fatty liver disease, which we are seeing very often. It is important to see for other organ involvement as a contributing factor in the ascites development in these patients. Now, coming to the very important aspect when you start managing these patients is to look at what is the salt and what is the diuretic resistance of the kidneys to these patients. So how do they handle salt? So if your patient is compliant with salt of 2 grams and you're checking the daily urinary sodium excretion, and the patient is excreting 88 millimoles in 24 hours, but still accumulating ascites, here you can optimize the diuretic therapy. However, if your patient is not excreting any sodium, these are the set of patients which are diuretic resistant. This can be harmful, and here on, straight away, we have to consider the second line options. When your patient is compliant with salt and is excreting more sodium but still reaccumulating, this is the set of patient which is non-adherent to salt, and a salt compliance has to be ensured. And why we're discussing about the effect of diuretics, and this is a very old paper, but just to show you here after 24 hours of giving torsemide or furosemide, how there is circulatory dysfunction pre and post. There was a decrease in the mean arterial pressure, increase in the plasma renin activity and plasma aldosterone levels. So diuretics have to be very carefully monitored and dosed in patients with refractory ascites. So what is the solution in the medical management? So we know the data from the ANSWER study clearly benefits of albumin given in long-term administration to this set of patients, but this was a less sick set of patients, that is patients with uncomplicated ascites. But in refractory ascites as well, this is not a randomized controlled trial, but a retrospective cohort study, again showing the benefits of long-term albumin administration given at a dose of 40 grams per week, which was reducing all the complications and the hospitalization, and also improving survival in these patients of refractory ascites. And this is some new data from our center, a randomized controlled trial. We looked at the combination of giving a long-term high-dose albumin therapy to patients with refractory ascites, combined with standard medical treatment and a vasoconstrictor, that is midodrine, which was given in one group versus the other group just received high-dose albumin therapy versus standard medical treatment. So 55 versus 57 patients were randomized, and this work was done by a fellow resident, Dr. Preeti. She presented this work in the INASL meeting this year, and the mean dose of midodrine was 22 in the 24 hours. And as was seen, as we hypothesized, there was a synergistic effect because albumin can correct the systemic hypovolemia. The dose of the albumin that we gave in this trial was similar to the ANSWER study, that is 80 grams for 2 weeks, followed by 40 grams. And the end point was to look at 6 months, what was the transplant-free and TIPS-free survival. So we got a benefit over here. And obviously, there was improvement in the systemic hemodynamics, and we found that the development of acute kidney disease and chronic kidney disease, which is very often seen in these patients and develops, was drastically reduced, and so was the number of hospitalizations. Now, coming to the role of TIPS, TIPS is a very important modality, and this is a recent meta-analysis which looked at 12 control studies enrolling around 4,000 patients, because we know portal hypertension is a driver and the TIPS can correct. So in this study, the indication of TIPS were patients who had refractory ascites, a preemptive TIPS, and for the prevention of rebleeding, and they found clear benefits of using TIPS to prevent the second or recurrent liver decompensation, that is worsening of ascites, variceal bleeding, hepatic encephalopathy, jaundice, renal dysfunction, and spontaneous bacterial peritonitis. And also there was a survival benefit. But what are the challenges that we face while we do TIPS and we consider our patients with refractory ascites is an appropriate patient selection, the timing, just stratifying the risk of liver failure and hepatic encephalopathy development post-TIPS, and the risk of cardiac decompensation. So we need to understand again, don't use TIPS when everything has failed. So you need to find an appropriate window for TIPS in patients with ascites, and this is particularly true for patients with refractory ascites. And this is some new data again, looking at, this was a retrospective series wherein TIPS was done for refractory ascites and subsequently monitored these patients for the control of ascites post-TIPS. And they found that 74% of patients had control versus 26% who did not have control of ascites. And the independent factors which were associated with not control of ascites even after a TIPS was the cumulative frequency of therapeutic parasynthesis. So higher was the cumulative frequency, or the later was the TIPS done in the course of refractory ascites, and patients who had already developed renal dysfunction. These were the two key factors, and persistence of ascites was also associated with worse survival. Now, how do we stratify the risk of post-TIPS liver failure or liver decompensation? So we are aware of the different scores, the Child-Pugh, MELD, and MELD sodium, but this is a new score which was produced from a German multicentric retrospective cohort of patients, almost 2,000 patients, 80%, and validation set comprised of 20%, and they developed this Freiburg index of post-TIPS survival, which comprised of 4 factors: age, bilirubin, albumin, and serum creatinine. And they showed that this score was able to just identify the patients who would go on to post-TIPS decompensation. However, when they also assessed this score for patients who had a preemptive TIPS, it did not perform quite well there. So this is the Kaplan-Meier graphs of the training set and the validation set. So a high score, this can be calculated using an online calculator, above 0.92, was supposedly the patients were having a median survival of 5 months and just 3 months in the training and the validation cohort respectively, while patients who had low scores were surviving for more than 48 months. The other problem, and what we see here, is sarcopenia is very common in these patients. And this is a retrospective study from our center, 210 patients, all of them who underwent TIPS, 71% for refractory ascites. And all these patients, we assessed the sarcopenia using the skeletal muscle index in the CT scans that were performed 3 months within the TIPS procedure was done. And almost half of these patients were sarcopenic based on the CT skeletal muscle index. And we found that the patients who developed hepatic encephalopathy after TIPS were the ones who had sarcopenia based on this SMI index and higher serum ammonia. And these are the patients who also developed recurrent episodes of hepatic encephalopathy, which was about 8 times higher. And on multivariable analysis, we found that, again, higher age is an important factor, lower serum albumin, and sarcopenia correlated with increased risk of hepatic encephalopathy. So nutrition and frailty has to be carefully assessed. A good amount of protein and exercise protocol, which should include both aerobic and resistance, should be prescribed as a routine protocol for these patients. The role of branch-chain amino acids looks exciting, but still not enough data to suggest its routine recommendation to this. Now, coming to the risk of post-cardiac decompensation, and this is another interesting paper, 100 patients who underwent TIPS for different indications. The mean MELD over here was 11, and the cardiac decompensation post-TIPS at 1 year was seen in 20% of these patients, and they proposed an algorithm, which is the 2-lows algorithm. Based on this algorithm, they suggest that in the first place, we can start off by doing a NT-proBNP or BNP. If your BNP level is less than 40 and NT-proBNP is less than 125, these patients also usually have a normal echocardiography, and these can have very low risk or extremely no risk of cardiac decompensation. However, if your biomarkers are elevated, then you need to do a transthoracic echocardiography, and there, if your E by A ratio, E by E prime, and the left atrial diameter is enlarged, this is the group of patients who is very high risk, and actually TIPS should be contraindicated because of risk of cardiac decompensation. The other important strategy which can be done to prevent and improve survival and decrease the number of episodes of hepatic encephalopathy is to go forward with a smaller diameter stent. And this particular retrospective series looked at these factors, and they showed that an 8mm stent, even though the portal pressure reduction was less, actually was leading to a survival benefit. And this is how, and there are now multiple case reports also and case series suggesting even much smaller dilatation of the same 10mm stent, which is underdilated to 6mm, and just reduction of the portal pressure gradient could be helpful rather than reducing the portal pressures very extensively in these patients. Alpha pump is a newer technology. It's not available in India, but again, a very Important strategies, especially if your patient is unsuitable for TIPS, who's previously failed TIPS, or patients who have portal vein thrombosis or associated cardiac dysfunction. This can be subcutaneously implanted and battery-powered device, and it moves the ascites automatically into the peritoneal cavity to the urinary bladder and facilitates removal. Now, this is the meta-analysis, only one randomized controlled trial, 9 studies again, showing that almost 62%, so 2/3 of the patients did not require any LVP after placement of this alpha pump. There was reduction in the number of LVPs, but at the cost of more frequent renal dysfunction, because these patients are not put on albumin. There is automatic drainage of the ascitic fluid, so kidney injury was seen in almost 1/3 of the patients. And again, infections of the urinary tract and spontaneous bacterioperitonitis was seen. Now, this is a very elegant study by Professor Solar, looking at 10 patients of refractory ascites who underwent alpha pump, and she followed them up carefully from day 7 and looked at different time points up to 6 months, and looked at the GFR using the gold standard method, looked at all the circulatory parameters, the cardiac output, the plasma renin activity, norepinephrine, and inflammatory markers. This is just to show that alpha pump caused reduction in the GFR and also worsened the circulatory dysfunction. So this has to be seen whether it can be combined with long-term albumin to improve the outcomes. Now, liver transplant obviously is the best option and the solution, and should be considered even in patients with low MEL scores, and many of these patients would have gone into a chronic kidney disease, which is HRS non-AKI. So if it is stage 3B or more, they should be considered for a simultaneous liver kidney transplant. Palliation is another very important aspect of managing these patients, because many a times we see elderly population, patients with comorbid diseases who do not have any option of a definitive management. So these are the patients, and this was a randomized clinical trial looking at the palliative long-term abdominal drains versus large volume paracentesis in a 12-week feasibility study, and they showed that by the self-reported questionnaires, the quality of life improvement was much better with the placement of these drains, but its role lies in the palliative setting, because we can see here almost 55% of the cohort of patients died within a span of 4 weeks of screening into this study. And this is another large systematic review, again looking at the same role of palliation of these indwelling catheters, and they showed that this was well accepted by patients, and the median survival can be seen here was very low in this set of patients. But its benefits lies in reduction to the burden on the healthcare and the economics of the patient. So I would like to summarize by saying that timely liver transplant improves outcomes in refractory ascites. This is complicated. Assess for diuretic resistance, go for an early TIPS, large volume paracentesis, albumin infusions with or without vasoconstrictors. Vaptan, some data I did not discuss, but yes, in a carefully selected patients. Nutrition, frailty, and palliation form an integral part of the management of these patients. Thank you.
Thank you, Dr. Rakhi, for excellent presentation. Please take your seat. Now, house is open for discussion, and I'll invite my co-chair to.
Thank you very much. My first question is Professor Paolo. In the era of urinary biomarkers, in many publications we have seen the fractional excretion of urea is used to differentiate between pre-renal and renal AKI. But in the definition of AKI, we are using serum creatinine, and we are ignoring the importance of serum urea. My question is, in the era of biomarkers, are we underplaying the importance of serum urea? And my second question is Professor Rakhi, that in the pathophysiology of ascites, portal hypertension has crucial role. But in many studies, it has been seen that the use of non-selective beta blockers negatively affects the survival of the patients. But in many centers, TIPS and liver transplantations are not available. So, is there any new guidelines how to use non-selective beta blockers to control portal hypertension in these patients?
Thank you very much for your question. That is dealing with the use of serum urea in the diagnosis of AKI. Because we all know that serum creatinine has strong limitation in the definition of GFR. Yeah, it may be, but study on this are still lacking. We have never compared the change in serum urea with the change in serum creatinine for the definition of AKI. We can do it, may be interesting to do, I think.
Yeah, the beta blocker story is interesting. And again, the data for refractory ascites is debatable, but I would say that most of these patients have circulatory dysfunction. They are getting repeated paracentesis, they have these deranged cardiac, they have cirrhotic cardiomyopathy. So in a very carefully select, and then you cannot not optimize the right dose of beta blockers. So we should not rely on beta blockers for managing. Yes, if your patient has no criteria where he could worsen, obviously you can try, but we have to be careful of using beta blockers.
Dr. Paulo, this is the Angel study and the other biomarkers have been done especially in the earlier definition of the AKI. Is there any the study in which they have looked at the new definition of AKI and the role of Angel?
Well, what is lacking, I think, is a study monitoring the level of NGAL during the late phase of AKI, because it is important to know if an AKI which doesn't solve within 7 days will move fast to ATN AKI or not. Also to define the criteria for simultaneous liver kidney transplantation. But this study is still lacking. We have only one study proving that there is no increase on the level of urinary NGAL in patients who move from AKI to CKD, but not related to the progression of AKI from stage 1 to stage 3 and then after that.
Yeah, thank you. Raki,
my question,
this is just 1 minute. One clarification that in the refractory ascites, in our APASL guidelines, which has just come today only, in that we have revised the definition of refractory ascites as per the new AKI definition. So we should try to, because once we follow the old definition of the AKI, it is too late. So yeah. So the creatinine level we should follow as per the new AKI. And then regarding the dose of the midodrine, which you said in your study of albumin and the midodrine, it is quite a high dose, 22.5. Our patients don't tolerate, and this was a mean dose. So means how much was the maximum dose? It will be very difficult to.
It comes to around 7.5 mg thrice a day.
Thrice a day. This is a regular dose.
This was the dose with albumin that was the mean dose.
Okay. So, a major problem in these patients with the refractory ascites is either they are not salt compliant, or they are on beta blockers, or there is a SBP. SBP is a major problem in these patients. So, the moment you come across the refractory ascites, do a diagnostic tab. If there is a SBP, you treat it, and then after that you can increase the diuretics. If not, then you look for the other factors and then treat refractory ascites. Yes. Gaurav, you want to say anything?
Basically, ascites for me is a disease in progression. Refractory ascites is no bolt from the blue. It's basically the hemodynamic deterioration that keeps on happening. The GFR reduces because of splanchnic and systemic vasodilatation, and we need to correct this with albumin and vasoconstrictors. The amount of albumin and vasoconstrictors depend upon the hemodynamic deficit. The hemodynamic deficit would vary from patient to patient. The albumin and RARI, renal artery resistive index, SVR, all these things can be measured. Once you know the hemodynamic deficit of the person, then to correct them to achieve a particular level is more of a response-guided therapy than a particular fixed dose combination. Yeah, now we'll take questions from the floor.
Yeah. Is it my turn? Yeah. To Professor Paulo, please. What is the role of microalbuminuria in detecting various stages of HRS or HRS AKI. Urinary microalbuminuria, because NGAL is not available here in many centers.
Yeah, you can use it, but it is better to use urea clearance, I think, and also fractional excretion of sodium to make the differential diagnosis in between ATN AKI and non-ATN AKI.
So
Much better than urinary albuminuria.
The paper that Paulo sir had shown, which we published, we have assessed for albumin also in the urine. That was not coming as a factor in the univariate or multivariate. Univariate it was significant, but multivariate it was not.
Yes, please.
Yeah, the question to Professor Maiwal, that is, can we use, because the Barcelona group has published small case series, that is SGLT2 inhibitors for refractory ascites, and especially if we combine them with midodrine, as sir was telling us, the hemodynamics can be taken care of, and less chances of encephalopathy, and also urinary sodium excretion goes high. So what are your thoughts? Also, Professor Singh, Virender is there also. SGLT2 inhibitors with midodrine.
Yeah, this is very interesting, but the only problem with the SGLT2 is currently the safety has not been established for child C and particularly refractory ascites group of patients. But I think so Professor Singh has some data. He's done in recurrent ascites. The SGLT2 inhibitor has been...
This is a paper which has been accepted just yesterday for the oral presentation in ASLD, and this is the role of the safety and efficacy of the SGLT2 in patients with the recurrent ascites. It was useful, but only problem was the infection. The UTI was a problem with these patients. So we'll present this data in the coming ASLD.
The problem with SGLT2 is that until you get the renal blood flow right, these drugs that act on kidney do not act that well. So renal blood flow has to be monitored with vasoconstriction and albumin. Splanchnic vasodilation, systemic vasodilation are there. You have to vasoconstrict to get the renal blood flow correct with albumin. Once the renal blood flow is correct, only then the diuretics will act and SGLT2 will act.
Yeah. My question is to Professor Paulo. Sir, cystatin C has been in the vogue for 2 decades, and most of these urinary markers are in the vogue for almost 1 decade. So when would they move from bench to bedside? Because there is a yawning gap. None of us uses in the clinical practice, because when the patient comes to you for treatment in hepatology wards, you're not looking only at the ascites. You're looking the patient holistically. You're looking after infection, bleeding, renal failure, replacing albumin. So where is the time and point of looking for prediction of AKI? In any case, you are correcting pre-renal factors, you are looking after the post-renal factors, you are giving albumin, and the patient who is destined to go into AKI will go irrespective of what you do. So where do you have this algorithm for looking these parameters, and can something else be different in terms of our management to look for these parameters when they'll come into clinical arena?
Great question, thank you. Cystatin is not in clinical use for a very simple reason. It is too expensive. The change in the scenario will be the introduction of a point of care to measure urinary NGAL. This will be available in a short time. And I think and I hope that it can be applied everywhere because it will be cost effective. And so it can be introduced in any algorithm for the evaluation of the risk to develop AKI, the diagnosis of different phenotype of AKI, and the prognostic prediction on AKI.
Yeah, there are a few other markers that might be used, like SVR and RARI, renal artery resistive index. Actually, to detect early kidney injury, RARI may outperform urinary NGAL. A couple of studies do suggest that. But anyway, this is a matter for discussion later. The row behind person has been standing for long. Please, may I have your question?
My question is to Dr. Rakhi ma'am. Our Indian cirrhotic patients do not reach up to the dose cutoff that is defined for refractory ascites. So, is it the needed to be revised definition of refractory ascites? Because Current definition defines mostly diuretic intolerable ascites rather than diuretic resistant ascites. And I would also like to know the experience of Dr. Paolo sir. Do Western cirrhotics tolerate this much doses in their clinical practice?
Well, great point again. You should consider that diuretics is a symptomatic treatment that paradoxically can further worsen the pathophysiology of the scenario. So I totally agree with you that in very few patients we use the maximal doses of diuretics suggested for the definition of refractory ascites. And in clinical practice, I prefer to use the terms recurrent ascites and to move the indication to TIPS from patient with refractory ascites to patient with recurrent ascites, because the outcome will be much, much better. And for me, recurrent ascites is a patient with responsive ascites who will not respond to the long treatment with albumin. This is my definition of recurrent ascites.
Yeah, please. Sir?
Yeah, okay, in line with that, perhaps a comment from Raki and you, Paolo, on the definition of resistant or refractory ascites with these high dosages of diuretics. Is it still adequate to go for these high dosages in order to define a refractory ascites? Could you comment on that?
Yeah, whatever, that's what I think. So all these definitions need clear-cut revision, especially in the area of ascites and AKI, the way the progress is there and the field is evolving. What you're saying, we're learning that diuretics are rather harmful. And we're going back to those papers, and we're learning in our experience that we're never elevating the dosages of diuretics, rather giving other therapies which are there, and we should reduce the risk of renal dysfunction in these patients, and the hemodynamic dysfunction which is seen is very important. So yes, we should sit and revise the definition, the dose of diuretics, and what is the appropriate dose cutoff, and these should be taken in large centers-based cohort studies. Yes.
Thank
Last
you.
question by Dr. Sunil.
My question
please.
is for Dr. Aki. So you said that there is a specific indication for using Vaptans in patients with refractory ascites. What is this indication, and do you think that low dose Vaptan with long-term albumin can help in patients with refractory ascites?
So I just put it in the conclusion because I felt we are using Vaptans as a last resort, especially in the patients who have hyponatremia and refractory ascites, and sodium becomes an important factor when you're trying to use Vaptans. But it has, whatever data is there, you have to use a very small dose, and we have tolvaptan. And a small dose of tolvaptan added to the low-dose diuretics, we can see that there is diuresis, and we can see the improvement in sodium and fluid, the water excretion by the kidneys.
Tolvaptan should not be used so freely, although you can try a low dose, but try it when the MAP is high. If the MAP is low, don't try it. This is going to lead to the AKI. So if you are combining the midodrine, I'm not saying patients with the SBP in which the MAP is low. Non-SBP patients, you can try with the midodrine after 2 or 3 days. You can add a little dose of the tolvaptan, maybe 1 tablet only, and then you can see there is a very fast decrease in the ascites, and the urinary output goes very high. It is like a tap is opened in these patients.
That's why very close monitoring and asking the patients to drink ample amount of water, not using in renal dysfunction also is very important. And tolvaptan has a black box warning, so should not be used in patients.
So with that, the time is already up. Thank you very much, Dr. Paolo, Dr. Raki, our co-chairpersons, and the audience. Thank you all.
Hello, check. Thank you so much, everyone. We may now proceed for the lunch. The arrangement is downstairs in the Crystal Hall and the basement. And for the faculty, the lunch is at faculty. Requesting all of you to kindly be seated so that we can start the session number 6, which is a debate on acute on chronic liver failure. The chairpersons of the same are Professor Dr. Rajiv Jalan, University College London, UK, Dr. Punita Tandon, University of Alberta, Canada, Dr. Manav Wadhwan, BLK Super Speciality Hospital, Delhi, Dr. Bijay Mishra, Utkal Institute of Medical Sciences and Hospital, Bhubaneswar.
Welcome everybody to the session. Can we please have Dr. Sanjeev Sehgal, who needs no introduction, from the Max Super Specialty Hospital in New Delhi. And he will be presenting for the motion. Patients with acute on chronic liver failure should receive priority with liver transplantation. Thank you, everybody.
Thank you very much. Good afternoon, everybody. I'm going to be speaking on a very interesting topic. ACLF should receive priority on a liver transplant wait list. And this indeed is a thing which we are experiencing day in, day out. And I think earlier talks today have actually even consolidated my view further that yes, acute and chronic liver failure should be given priority on a liver transplant wait list. This is an extreme situation. High prevalence, high short-term mortality, high morbidity and mortality increases with grades. And we know that there's a low chance and priority of being listed for DDLT. And spontaneous improvement is actually not much, especially if you have higher grades. And very low chance of survival in higher grades of ACLF if you don't have a transplant. This is a very well-recognized diagram which says that as your grades increase, your chances of survival actually go down. The more the organ failure, the more is the mortality. And we know that the window of opportunity is very small, and we really have a very short time, 3 to 7 days perhaps, to act. If we can't, then probably we might lose this patient. So let me first take you to the standards of priority listing in the West and see what we are doing in our own setup. And where does ACLF stand? Now, in the USA, for example, is the sickest first approach, which is based on a MELD. And that's the way patients are put on the wait list. And there are criteria for super urgent and urgent listing. Indian system is basically on a waiting time based system. So waiting time is a common thing for prioritization in most centers. Some have started MELD based priority, especially in Gujarat. But what is the issue with our policy? Urgency of liver transplantation is not always determined by the waiting time. A paradoxical situation where sick, decompensated patients die before they accrue enough waiting time. And low MELD patients who could remain stable for a sufficient period of time may actually get listed and may get an organ. So that's pretty a paradox. So we do have a super urgent priority as per our guidelines, primary non-function of the graft, or a living donor who develops life-threatening liver failure post-surgery, early hepatitis thrombosis needing a retransplant, and yes, fulminant hepatic failure who meets criteria. If there is no super urgent patient, the liver will go to the recipient of the requiring a simultaneous multi-organ transplant. And if there is no that suitable candidate for that, then allocation will be done to the patient who has been waiting on the list for a longer time. So it's all a waiting period based system. So what are the issues in priority listing for ACLF? Waiting time is clearly not applicable due to high short-term mortality. MELD-based allocation system does not exist in our system, and it, in any case, does not reflect the dynamics in ACLF. We don't have any MELD exception system in our own criteria. Long waiting due to diseased donors, and especially the fact that many of them may be alcoholics, they are further put down on the wait list. But let me compare ACLF3, which is the toughest to deal with something like an acute liver failure. Now, ACLF3 has almost similar or higher mortality than ALF. And please note that acute liver failure, we know, is traditionally given a super urgent priority all over. Then why we don't give priority to ACLF? What is the problem with ACLF? Especially if we know the fact that if you do a transplant for ACLF, even ACLF2, even up to 3, you can actually have a meaningful outcome and patients can actually survive very well. Now, I was a part of this national liver allocation policy, which we actually devised and developed over several months. And our dear colleague, Muthu Reddy, was really instrumental in doing this. So we had a team. So what we actually defined here, I just put this paragraph for your notice. Patients with ACLF who need early liver transplant should be considered for standard DDLT listing with additional priority points based on the number of failing organs or for living donor liver transplantation. And please note that the additional points which have been proposed are if you have single organ failure, 2 points, two organ failure, 4 points, and more than 2 organs, 6 points. So although this is not being practiced, but the proposed National Liver Allocation Policy, the NLAP, what we call as consensus, clearly says that ACLF patients should be given priority on a waiting list. Also, please note that what are the treatment options for ACLF? Okay, we know that still the medical measures, what we do are purely supportive. We have an excellent talk by Professor Jalan today, and he has really given an insight into what lies in future. And I'm sure we'll have excellent opportunities to treat this patient with much more robust modalities medically. But right now, there's no specific drug which is there. So as of now, there is no clear cure for this group of patients, and the only thing which can really help them at the end of the day is a transplant done at the right time. I'll also highlight this, actually this is a snapshot of a study. Why I want to present this? I want to show you that if you have any grade of ACLF, either through the INASL criteria or through the PASL criteria, R criteria, irrespective of the grade you use, the 28-day, 90 days, 1 year and 3 year, the survival in all these grades is actually much better. And there are, it's almost, is something which we can look forward to very strongly. I mean, like, for example, in 90 days, you see 88, 87, 76, 93. So, I mean, this is an ACLF3, if you see the ACL1, and the ARC is also pretty good. So therefore, if you're doing a transplant for ACLF patient, you're doing pretty much good for that patient. Now, what is the issue of waitlist? Issue of waitlist is that waitlist is something which is really detrimental for patients of ACLF. And waiting list priority can account for almost 25% mortality in ACLF grade 2 and 3. 1 year post-transplant survival of patients with ACLF was in excess of 80%, independently of the grade. But please note this, factors independently which were associated with post-transplant mortality included higher lactate, need of renal replacement therapy, and multi-drug organism infections while on wait list. So letting these patients wait for long is detrimental, and that again makes the point that yes, they should be given a wait list priority. Also, if I'm comparing ACLF3, which is really the hot topic these days, what do? We don't know. ACLF3 versus, for example, status 1A of UNOS. What do we see? Look at this study very carefully. Nearly 3,000 plus patients in status 1A and 5,000 plus patients on ACLF grade 3, when they were compared, what was found that patients with ACLF3 at the time of listing have a greater 14-day mortality than those listed as status 1A, independent of MELD sodium scores. So therefore, these patients definitely need something to be done. We cannot let them die on the wait list. This beautiful study, Markov model, in fact, I'm glad Professor Jalan is there on the chair. He has been instrumental in this Markov model for ACLF, where it was seen that 3 things, donor organ, quality, organ failure recovery, and early transplantation, when they were compared, it was clearly seen that doing a transplant for ACLF3 is much better than not doing transplant. And please note that the impact of a marginal graft on post-transplant mortality was much less consequential than the mortality from delaying transplantation. So therefore, even the sickest of the patients, if you have an opportunity, you should go ahead with a transplant. So that was the message. So if you have a ACLF2 or ACLF3 patients who are there in your ICU, you need to give them a priority, otherwise they're going to die without a transplant. MELD allocation has a huge limitation, in particular in ACLF. A, it is not being followed in India, so it's really not good for us. B, that MELD does not reflect ACLF severity, which we know very well. And I'll just show this slide. This again, a great work done by late Dr. Sundaram and Professor Jalan sitting here, that ACLF3 actually have a mortality dynamics which is independent of the MELD system. So even if your MELD is low, if your grades of ACLF are high, then irrespective of the grade, your chance of dying would be much higher if you have high grade of ACLF, but this will not be reflected by the MELD score. So liver transplantation increases odds of survival for these patients, particularly if it is performed within 30 days of placement on the wait list. So that again is a thing which says that yes, waiting is detrimental for these patients. So in ACLF, we need to do a balancing act. It's a jugglery, feasibility versus futility. If you're too late, you're futile. Morning, we had an SIG and Professor Rajendra Reddy was there, and we knew that we discussed that in ACLF 3 patients, waiting too long is going to be futile, and we don't want to do that. So also we know that there's no standard exception for ACLF today to compensate for these disadvantages which are there to ACLF, and to better highlight the excessive mortality of this syndrome in patients on the wait list. LDLT, my dear friends, is not the answer because it is ill-equipped to actually deal with ACLF. We think that it's your patient, your donor. No, it's not so. In a sicker patient, so very sick ACLF3, it's not really easy to say that, okay, you got an organ from a near relative and go ahead with transplant, especially if your patient is, your recipient is very sick. So we need something beyond LDLT, and that will be a priority on the waitlist of DDLT. So my view, my friends, would be that balancing between the dynamics of ACLF and allocation of organs has not been found in actual clinical practice. So what we need, a timely evaluation and admission to the liver transplant waiting list and prioritization of patients with ACLF within that narrow window of opportunity. It's a very narrow window of opportunity which will improve the outcome and reduce the futility of these patients, and careful selection of patients and timely liver transplant will save precious lives. So finally, I will conclude with my statement that ACLF patients should receive priority on the liver transplant wait list. Thank you very much.
Thank you, Sanjeev. It's now my great pleasure to invite Dr. Kapoor, who is a long-standing friend of mine, to speak against the motion. And I'm really looking forward to this talk.
Thanks, Rajiv. Sanjeev, I'm really glad that you've had a change of heart. So you're talking of now deceased donor transplant and saying that there are some demerits to living donor. So this is the entity that we are talking about. A rather confused entity means different things to different people. Cirrhosis, present, not present. Past acute decompensation, present, not present. Infection as precipitant, present, not present. Liver failure, must, not really must. And what are the organ supports that you are talking of? So we can have a full debate on this too. And this is how this entity came into being. Seminal work, for the reason that the study was finished in less than 1 year. And Rajiv and other colleagues showed that about a quarter of patients admitted decompensated cirrhotics have ACLF at the time of presentation, and another 11% or so they develop while they are in the hospital. But mind you, people who had a past acute decompensation, they were similar in the two groups, and hence there might be some merit in saying that decompensation is not such a bad thing. But also we must remember that those who had decompensated in the past, they fared better than those who'd never had a decompensation. So Dr. Sanjeev conveniently did not mention about the precipitants. So the course of a patient with acute on chronic liver failure is also going to be dependent on the precipitants. It's been shown very elegantly from an All India Institute study that if you've got viruses like hepatitis E, A, these are the patients who do potentially very well. And then you see a host of other things over here. For example, decompensation after surgery, GI bleeding, which is almost always associated with a good prognosis, especially if it is variceal, not so much non-variceal. And then a number of other things which can be addressed and arrested before your patient progresses to a higher grade of acute and chronic liver failure. And this, of course, was a landmark study because for the first time it was shown that you could drop off the list or you could be dead even at a high MELD score if you did not have any inflamed milieu. So for me, acute and chronic liver failure is only an inflamed milieu. You can define it in a number of ways as to what an inflamed milieu means to you. Whereas if you see the left part of the bar diagram, then even someone who's got a MELD score of more than 35, his dropout rate is only 20%. So indeed, one would be led into believing, and let me tell you, I'll make a sweeping statement here. Nowadays, it's become fashionable to say that, sir, we transplanted someone with ACLF. I hardly ever see a junior colleague calling up to seek advice on somebody who was transplanted for decompensated cirrhotics. So they will always say that we transplanted someone with ACLF. But it took us some time to realize that it is not the ACLF at the time of presentation, but what happens to this patient while he's in the ITU. And this is probably even a better study than the initial canonic study. Of course, the same group, in which it was shown that in ACLF1, you could have 3/4 of the patients improving. In ACLF2, with good liver intensive care, about half of the patients improve. Of course, in ACLF3, only about 1 out of 5 would improve in any meaningful manner. But that does not mean that you lose sight of good ICU care. What happened in acute liver failure? When Sehgal very comfortably said that acute liver failure status 1A patients, they do much worse than the patients with ACLF3. Do they do that because of liver sickness? Nah, that's not because of liver sickness. It's because of something else. And this became actionable because if you see at the time of diagnosis, at least in ACLF3A, you have 3 organs knocked out. But look at the blue bars. So at the time of diagnosis, 68%, but with good intensive care, about only a third of the patients in the same original cohort, they continue to have those many numbers of organ failures. So that means you cannot downplay the importance of good intensive care for this cohort of patients. So this, dear friends, is what happens to a cohort of patients who've been defined by the canonic way. You will have resolution and improvement in about half. There would be a steady or a fluctuating course in another 30%, and about 1 out of 5 would be worse. So you cannot just use one brush to paint all the 3 grades and say that I would want to prioritize these patients for liver transplantation. Now, coming to the most important aspect of this discussion, it is the change of grade of an ACLF patient that is going to decide the further fate of this patient. So this particular study, again from the UNAS database, you can see that those patients who were listed as 3 and transplanted as 3, they did the worst. But just imagine those who were listed as 3, but you were able to bring down their grades to 0 to 2, they did extremely well. And this is something that we should never lose sight of. Of course, I am again at the expense of repeating myself, saying that only about 1 out of 5 would be able to improve or show some meaningful improvement, but that's not a small figure, at least for the earlier grades of ACLF. And this is what you were trying to say. So in those patients who are transplanted less than 7 days and more than 7 days, mind you, this cohort is only ACLF3. There is no difference. So that means that clearly there are ACLF3 whom you are able to downgrade to 0 to 2, and they would do much, much better. This is from the same cohort. Only in those who are more than 60 years of age, there was a statistically significant difference whether you were transplanting less than 7 and more than 7. And by the way, I thought that Sehgal would take away some of my time by telling you now what is an early transplant. So when the canonic definition was given, early transplant used to be 28 days. Now it has been pegged down to 7 days. So I think we are really crazy. So this is what, again, this study showed. So the meaningful organs that you need to correct are the respiratory failure, the circulatory failure, and the brain failure. At least according to the Western world, the kidney failure doesn't count for much, though I would argue that it's not true for our setting. So what are the significant factors? Age, DRI. He comfortably told you that if an organ is a marginal one, it's been shown across a number of studies that if you have got a high DRI organ, then your patient is going to do much worse. And of course, ACLF3. But those which have not been proven to be significant is the time to liver transplant. So that's the key for this audience. MELD score and ERA. So we are not improving, at least between 2004 to 2019. There was no difference in the 2 eras, the 2012 being the middle point. Even individual centers. So the problem with the registry data is that different people would be managing these patients differently. This is from the University of Hamburg experience. Again, a small study, but what it is telling you is, look at the right side Kaplan-Meier curve. So those ACLF improvers who have shown improvement with liver intensive care, they actually behave as well as the no ACLF, which is at 90 days. So what about the ELITA study? Look at this. So this is the study. So it's a question of glass half full or glass half empty. So he told you about the 3 factors, but look at the 1-year waitlist survival intention to transplant. So this is those patients who have been evaluated and listed. Look at ACLF3, 53% of them would be still alive. Even if you had 4 organ failures, 40% of them will be still alive. But what are we doing wrong? Look at the time that they take to get a transplant. So ACLF3 is getting transplanted in 5 days. So clearly there is going to be a crunch on organs. So I don't think we can lose sight of the fact that these are probably transplants which have been done sooner than they should probably have been done. So this is a TAM score. This again tells you that 3 days, 7 days might not be very relevant. This is again a study from France which showed that if you have got these 4 factors, you are on a mechanical ventilator, your PaO2 to FiO2 is less than 200, lactate is more than 4, you are more than 53 years of age, and you do not have a high leukocyte count, you do much worse. But if you are able to correct the TAM score, you do much, much better. So this is what we must realize. You cannot lose sight of good intensive care for this cohort of patients because there is no standard therapy. talk of regenerative medicine, talk of plasma exchanges of this world, there is no consecutive therapy that you can offer confidently to this cohort of patients. So am I saying that these patients should not be transplanted? Not at all. But you should not have a knee-jerk reaction. And you should always make an attempt to downgrade the stage of the ACLF that the patient presents to you with. Fortunately, sane days, in those days in Rajiv's original cohort, 61 patients with ACLF received liver transplant vis-a-vis other 55 who were on the wait list, they received. So I was very happy. And this is what that particular Kaplan-Meier curves told you, that if you have got ACLF3, do you really do well? But what is Rajiv telling us now? So he's telling us that probably pre-ACLF is even worse than ACLF 1 and 2. So I don't know where we are going to draw a line. So we probably are again going back to the minimal listing days, paving way for a preemptive evaluation and listing. So what are we missing? So this is something that the scientific community which has come from overseas also needs to look. Are there any good explant studies from ACLF? We have been transplanting them for more than a decade. Answer is no. Do you have any protocols for immunosuppression in this cohort of patients? The answer is no. Do you have any long-term follow-up on these patients? What happens to those patients whom you are transplanting with AKI and who are on renal support? The answer is no. And I could go on and on. So there is a never-ending list of to-do things, even for the very learned colleague as the chair. So please remember that we are not gods. So just because somebody has been referred to me for a transplant does not mean that I have to do a transplant. I cannot lose my wisdom. So there are two things that you must know, whether you want to escalate care or you wanted to call it a day and you say that this is futile. And herein you would need the standard ICU considerations and the liver specific considerations, and all of them might not be tangible. For me, there can be someone who's weighing 140 kilos, who's 35 kgs, can barely walk a few steps, is not jaundiced, and creatinine is 1.7. This patient is far sicker than someone who's got a bilirubin of 15, creatinine of 1.8. So there is no comparison. ACLF means different things to different people. And this is what is the final nail in the coffin. And this is what Rajiv's most latest gift to us is, that this is not the end of the story. Transplant is not end of the story. Post-transplant length of stay, ICU length of stay, number of days in the hospital, discharge to a hospice or rehab, and then readmission rates. So this is the so-called latest gift from Rajiv. Of course, he's telling you what is there available for when you follow up these patients. And you see that star mark there, infections. So Sehgal said MDROs. Do you have any clinical guidelines which tell you that how you are going to handle somebody who's got an MDRO bacteremia? You think you will be able to transplant that patient in 7 days? Even the infectious disease guys don't know how long you have to wait. So listing and prognostication, my dear friends, of 6 cirrhotic patients means different things to different people, and it's not just a game of numbers. And mind you, for in the interest of time, now Rajiv and colleagues have moved to a different level altogether. So they are now talking of modeling and not just mere numbers. Distributive justice when you're talking of deceased donor organs, and ethical considerations when you're talking of living donor. How good is it that you will go and tell the donor that the recipient has passed away even when the donor is still in the hospital? Fast track workup of the patient who's encephalopathic, who was drinking while coming into the hospital. How do you do it? It's impossible. And do you know what used to be the toast of the town for transplanting acute severe alcoholic hepatitis patients? That they develop aerodigestive cancers on follow-up. Did you ever hear this term in recent times? I haven't. Have you ever seen a publication about the new malignancies in the cohort that we are transplanting, I would say, rather frivolously and so quickly? I haven't. So we should be gracious enough to accept futility of liver transplant and futility of care. And mind you, we do not know the long-term follow-up on these patients. I rest my case.
Wow, this is fantastic, Dharmesh. Please come have a sit down. So what we have is now a opportunity for 2 minutes for each of the speakers to do a short rebuttal. 2 minutes. Sanjeev, over to you.
I think everybody understands that ACLF is a very serious issue and we have to do something for them. Although Dharmesh has given a lot of arguments, he has not been able to tell even one line why they should not be given priority. So there is no conclusion from what you talk, I understand, number one. Number two, talking that ACLF3 can be downgraded and we wait for that to make him 1 and 2, I think that's too childish. In our practice,
We are seeing patients who are sick every day and out, and we are absolutely, our days and nights are really involved with the sicker patients. I'm here to see patients with the hope that I can downgrade and not do anything. I mean, it improves very well. But I think nobody in the house here sitting will say that I'll wait for a HCL3 to improve and, make him 1 and 2, maybe that 20% out of, 100 patients who improve and not do anything. So having said that, we have to devise something which can help the patient. So what we don't have right now, we don't have a good policy. We know that we don't have good drugs. They will probably come in 3-4 years' time. Dr. Rajiv is working very hard. I think sure we'll get something. Till that time we have something. We cannot just sit idle and put an argument. We have to do something. And for that, I think that LDLT is not the answer. We have to give the priority. NLEP also, which we did the liver allocation meeting, we actually discussed this part. Till we have better medications in our hand, better armamentarium, bridging therapies, we must do something. And at least by putting them on a priority list, we're doing a justice to this patient and not anything which we should not be doing.
Well, thank you, Sanjeev. Now, Dharmesh, you have the last word.
So I think he was not listening carefully. That is all I can say. So just because somebody is sick does not mean that I have to do something. Our job is as much to educate patients and their next of kin as to treat them. And that's a very, very vital job. So I really do not buy this philosophy that we have to do something. What is the meaning of that? It means nothing. So how can you lose sight? So you tell me one thing, which is the medical treatment of acute liver failure? It's a comprehensive care in the liver intensive unit. And that's probably where we have to go. I concede that this is a different game, but you cannot say that status 1A is sicker than ACLF3. Status 1A is sicker than ACLF3 because he's reported to the hospital. The status 1A is less sick than ACLF3 because he's got an acute insult. He did not have a diseased liver to start off with. And his time to presentation to a higher center is much shorter than someone who's already languished across centers, been treated most of the times, indiscriminately and irrationally, and he lands with you. So I think, and there are so many other interventions. For example, in a select cohort of patients, do a TIPS. So how can we ever deride the importance of liver intensive care? I do not believe that there is going to be a magic wand to treat this sick group of patients. I do not believe that at all. I have always said, even though I work in transplant for the last 2 decades, that liver transplantation is a disease that you give to cure a disease. That is something that we should never lose sight of. So it is not, so everybody who works in transplant will say doing well. What is the meaning of doing well? It means different things to different people. Probably I am very incompetent because none of my patients do well.
Thank you, Dharmesh. So questions, we've got a couple of minutes for questions to these 2 very eminent speakers.
I wonder if the audience has noticed the importance that Dharmesh did not sit next to Sanjeev. So the problem is, no, the gloves are off. So the problem is that if you transplant ACLF like this, what Sanjeev says, we'll only be transplanting ACLF3A. We'll not have anything because as such DDLT is not so common in this country. LDLT is a different ball game altogether. So that's my problem. Where do you get the livers from?
See, it is not a transplanting ACLF3. Please understand. Question is very specific, which we are not actually hitting. It is, are you going to give them priority or not? Right? A, you let them die, there's nothing, there's not a donor. Issues, we are talking priority. It doesn't mean that we are transplanting these guys. So there's a difference between transplanting a patient who's very sick versus giving you priority. My only submission is very clear. That's what our even national liver allocation policy, the team also felt the same thing. That if you organ failure, please give them points. Let them not die in the ICU. If you can have a patient who's meaningfully surviving, why not? And I totally disagree with Dharmesh. Patients are coming in our OPD day in, day out, sick. I mean, Dr. Subhash is there. They are absolutely coming in a very good state, living a meaningful life. And that's what I want to do. I mean, I don't see a reason why I should not do a sicker patient who's, I'm not randomly transplanting everybody. That's not the point. But I should give a priority so that's what I mean. And maybe our national policy is not wrong, so I can't say that.
So, Dr. Agarwal.
Yeah, maybe Rajiv should answer this. To stop the bullfight between the 2 stalwarts, I think they are talking of the same thing. See, irrespective of the vagaries of the definition and the discrepancies in the precipitating factor, fact remains that you have to do your best in the intensive care. But there is a limit to which the liver will improve, beyond which you have to transplant. I think they are talking of the same thing. Rather than denigrating that you have not done enough in the ITU or you will never transplantation. I think there is a limit to which you can do. If the patient liver fail, forget about the definition. If you have a liver, you have to transplant.
So here there is an issue with the definition. So the earlier definition of an early transplant for this cohort of patients was 28 days. It's been pegged down to 7 days. That's what I have a problem with. I don't think that in a sick cohort of patients you can do a very good thorough evaluation of the patient in 7 days. Acute liver failure is a completely different ball game. Here you are contending with various comorbidities. Here you are contending with various psychosocial and behavioral issues. And of course, Sanjeev can say that, he wants to prioritize, but he works in a living donor program. So where is the question of priority for him? So priority question comes when you have to draw from a common pool, which is the deceased donor programs. What are the Asan Medical Center, which everybody would concede is the mecca for living donor transplants? Their 1 year results of acute and chronic liver failure, severe grade, which means ACLF 2 and 3 is only 72% graft and patient survival. So it's not as if to say that doing the hemigrafts or the living donor. Of course, living donor is a very, very valid option in a carefully selected patient. But all of us know, including Dr. Subhash, who's just come to the podium, how difficult it is to go and tell the donor that your recipient is no more, while the donor is still in the hospital.
Two quick points. One is, how do you improve the TAM score when age is such an important factor of it? Number two, where are these good ICUs? Because Delhi doesn't seem to have good ICUs. We only get patients from who have escaped their ICUs for a chance at life. Maybe it exists in Hyderabad, and we'd like to send the ITU people there for training.
Bedometer is the buzzword. Bedometer.
Thank you, Subhash. Last point, and then we'll have a debate. And then we'll have a show of hands.
Okay. This is actually more of a comment, because we did a natural experiment in Edmonton. Dr. Punita will remember. There was a time when ACLFs in 2007, it wasn't a definition at that time, were being listed as status 4s. And we analyzed our data. We found that they were being listed on a super urgent waiting list. And the results were probably around 55 to 60%. They didn't do well at all.
Well, thank you. Should we do a show of hands? So so let's have a show of hands for people thinking that we need to give priority to patients with ACLF for liver transplantation. That's for the motion. That is a question.
You see, ACLF as such is a confused issue. The definition is confused. ACLF organ failures determines mortality, not necessarily. ACLF etiology varied. Some improved, some doesn't. There is a large group of cryptogenic ACLF. How does they behave with other etiological agents? Not clear. Right?
All right,
you
guys.
are taking a mixed bag and trying to ask clear questions, right, with so many variables. That is not possible to get. I don't think
people have a view, Subrat. People have a view. So I think it's probably 70-30 in favor of Sanjeev.
I'm always happy if people leave the auditorium ignorant.
Let's do against. So people think there should be no priority for liver transplantation for severe ACLF patients. So yeah, thank you very much, guys.
So that was quite a session. Anyways, let's move ahead with the next one, INASL, EASL Synopsium on hepatocellular carcinoma. Chairperson for the same are Professor Dr. Anil C. Anand, Kalinga Institute of Medical Sciences, Bhubaneswar, Dr. Abhijit Chaudhary, Indian Institute of Liver and Digestive Sciences, Kolkata, Dr. Ajay Jain, Koithram Hospital and Research Center, Indore, Dr. Assis Kumar, Sri Gangaram Hospital, New Delhi.
The session is on hepatocellular carcinoma, and the first talk is by Dr. Thomas Berg, who's going to talk to us about screening and surveillance in HCC, current concepts.
Yeah, dear colleagues, dear chairman, dear organizers, thank you so much for invitation to this wonderful meeting. I really feel honored, and it's a pleasure to give a talk on surveillance in HCC and what the current concepts are. You know that hepatocellular carcinoma is on the rise and has high mortality. And as with so many other cancers, early detection improves survival. You know, the median survival, if you have an early HCC, is around 5 years. If it's in an advanced stage, it's around 1 year. I think although we are missing well, robust, controlled trials, I think the evidence is quite clear that HCC surveillance is associated with improved early detection, improved curative treatment, and overall survival in patients with cirrhosis. And the harm of surveillance is perhaps not very high. And I do not want to focus on this topic, but more on the concepts of surveillance. And one of the surveillance concepts, of course, is you have to do surveillance in order to see the benefit. And this was clearly highlighted by the different ranges of surveillance in different countries. And you know, in Japan, they perhaps have the highest rate of surveillance in patients being at risk, and they see the highest overall survival in these patients as compared to European patients, where the surveillance rate is around 30 to 15%, and the lowest here from a study in Hong Kong. And according to a recent meta-analysis from all patients being diagnosed with a hepatocellular carcinoma and looking how many of them had a surveillance before diagnosis, it's clear that it's less than 50% overall, and it's even worse when it comes to the population between being perhaps at the highest demand, the non-alcoholic fatty liver disease, where only 1/3 had a surveillance before diagnosis of hepatocellular carcinoma. So the question is how to improve surveillance rate and what are the potential intervention. And I think there are two dimensions on that. The one is promoting education, especially in the primary care providers, perhaps also the patients, that they are their own advocates, and improving also adherence of patients being already diagnosed as being at risk. And this is very much in line with the EASL Lancet Commission telling us that the dissociation between primary and secondary care is perhaps a major cause of delay in diagnosis. And with this commission, we are really aiming for something in primary care like the FIP4 score that easily helps the primary care physician to find patients at increased risk and then have a referral to a hepatologist. On the other hand, on the patient perspective, if you look here, and these are data on the US from a randomized trial showing if you have outreach programs or patient navigation in addition, you also could improve the adherence to the surveillance strategy in patients being at risk, although as you can see here in the data from the US, the overall adherence and surveillance rate was quite low. And I think it's interesting also to realize that we can use perhaps more the help of allied health professionals or kind of a nurse-led hepatocellular carcinoma surveillance, as shown here in a study from Australia, that could also improve adherence to the surveillance strategy on a patient level. Let's move forward to HCC surveillance. For whom? What are the current guidelines? And here, all international guidelines agree that patients with cirrhosis, child A and B, and those with child C being on the waiting list or being a transplant candidate should be surveyed. There are more inconsistency, or I would like to say uncertainties among guidelines what to do with surveillance in a population being non-cirrhotic. And the largest population we have studied so far are patients with hepatitis B, and you see here the inconsistency among the guidelines, the EASL guidelines going for a certain risk stratification, and I will talk about these risk scores in a minute, or ASLD, a puzzle more in line with where you come from, the age, the family history, or whether you should use all HBV carriers you have to include in a surveillance strategy. So I think we need a better definition of high-risk groups. And here, are potential interventions to increase it by refinement of our screening strategies with new predictive biomarkers. Artificial intelligence may play a role to come to a concept of defining patients with low, intermediate, or high risk, and then, and I think it's important, also to adapt the surveillance program. Well, for the hepatitis B situation, you know also whether patients are in treatment, not in treatment, with or without cirrhosis. There are so many scores, but I think most of you don't use them in clinical practice. And these scores, where they mainly incorporate, you see age, sex, other markers like platelets and so on, they are perhaps also helpful in other chronic liver disease, as studied here for the AMAP score, also involving patients with hepatitis C and a smaller proportion of patients with non-viral hepatitis. And again, these are the typical markers like sex, age, albumin, bilirubin, platelet. And I think the important point here, whether you use this or another test, is that by these risk stratification, you will find a big group, nearly 50%, 45% being at very low risk, really can dismissed from surveillance. So you can concentrate really on the patient at risk, and you are not overwhelmed by patients with very low risk. A special concern are surveillance in patients with metabolic associated steatotic liver disease. So what evidence is needed? And I've shown you the proportion of patients here with HCC being diagnosed without cirrhosis according to the liver disease etiology. And you see that, of course, we have hepatitis B. Sorry, this is B, this is C, and this is alcohol-related. Can you see alcohol-related C? This is B, and this is a group of non-alcoholic fatty liver disease. So it's increasing, and the highest risk for a patient without cirrhosis, the underlying etiology could be non-alcoholic fatty liver disease. And indeed, identifying these patients with a pre-cirrhotic NAFLD who have a high enough HCC risk to justify HCC screening is a major clinical challenge. And I think all guidelines so far do not recommend surveillance in these patients because it's unclear. But we know the risk factors, and this is one of these very nice reviews article, telling you what are the demographics of these patients, or the risk factors with comorbidities. Of course, diabetes plays a major role, environmental factors, the stage of fibrosis, medications. You are aware that insulin increases the risk of HCC. Of course, certain lab parameters. I want to also focus on genetic polymorphism. And according to these parameters, you're perhaps able to again classify patients in a very low or a very high risk group. And I really want to mention the genetic polygenic risk factors. So the same genetic factors that are associated with fibrosis disease progression, you know, the PNPLS3, TM6SF2, MBOT, and so on, are also associated with the risk of carcinoma. And in this study, the authors conclude, well, if you have cirrhosis, you will go for surveillance anyway. But if not, the polygenic risk score can tell you whether you're at high risk and perhaps you need surveillance, whereas if the score is favorable, you can follow the patient. And these genetic risk scores do not only work in fatty liver disease, also here in alcohol and Hep C. It has shown that by the number of mutations of variants, you can really stratify the patients according to their individual risk. Now coming how to screen at risk population. What the current guidelines recommend? Well, they all recommend ultrasonography every 6 months. Again, some inconsistency whether you should use AFP. And here in your region, you clearly, and I think it's wise, you clearly recommend to do AFP in addition. So, but what is the performance of the current surveillance strategies for early HCC detection? What is the evidence? And I think the evidence is clear that ultrasound is not optimal, we know that, and since the sensitivity for early detection, this means here within Milan, is perhaps only 0.5. And it becomes even worse if a patient is obese, non-alcoholic fatty liver disease, and so on. And what is the role of AFP? I think here clearly the vision has changed. The addition of AFP significantly increased the sensitivity of the detection of early HCC. You see here from 45 to 63, and it's especially the dynamic of the AFP over time. And if you look at a very nice study looking at the effectiveness in terms of the number needed to screen to prevent one death from liver cancer, you can see here, according to this study, AFP alone has the same number needed to screen to prevent a death as compared to ultrasound. If you compare it, you're a bit better. So we need new circulating biomarkers for early detection of HCC. So where are research and practice heading? So there's a long-term interest in biomarkers for early liver cancer detection. It started with AFP, but you see there are so many out there, but we are still only using AFP, I think, in clinical routine, at least most of us. This is also highlighted in a recent summary, and I don't want to go in detail into this. Well, there are DNA panels, methylation markers are quite interesting, but I would like to focus on the Gallat score. That is perhaps the one being most studied, including 3 biomarkers like AFP L3, AFP and DCP. This is PIVKA2, gender and age. And it has been shown that it's better than the single marker to have this combined marker profile plus age and sex in order to find patients with early HCC. And now Roche is interested, so this test will become available commercially, and they have shown if you skip AFP L3 and you just go for a GAT score, you have a similar area under the curve of early detection of HCC. So we come to the concept of the ACC precision screening, both in those with and without cirrhosis, and even in the patient without cirrhosis, with further risk stratification, you will have patients being at lower, moderate, or high risk. And I think the important point here is that we then have to adapt also the surveillance strategy. In patients without cirrhosis, most of them are not at risk, but the important point is how to find those being at high risk with these risk models that fulfill criteria and a high level of risk that it's justified to enter them into screening. So I would like to conclude with how to improve the performance of our HCC surveillance, and I think here imaging techniques matter. I have told you that ultrasound is suboptimal for small lesions. CT is okay, but the best is MRI. Of course, also the more expensive one. And the Japanese already adapted to this program, and they defined patient as super high risk. And here they had a more intense surveillance with ultrasound every 3 to 4 months, in addition to a CT or MRI scan. And there's a lot of interest, especially with the hepatobiliary liver-specific contrast agent, also to define early lesion, early HCC, not showing the typical wash-in, wash-out phase with a late hepatobiliary phase. When you have a hypointense lesion, you can define a HCC or perhaps dysplastic nodules. And perhaps this is underused, the information we could get from imaging techniques to define dysplastic nodules or the regenerative nodules in the liver. But the evidence from the literature is very good. If you look at all these papers, they all show the natural history of an undefined liver nodule in a patient with cirrhosis, that the malignant transformation rate of these nodules is 30% in 3 years and up to 50% in 5 years. So we have good evidence here to further define a very high-risk group by these C or MRI scan-based imaging. And as part of a larger project within Germany, we now classify patients according to baseline risk factors. And here a patient being 60 years old, male, has diabetes, advanced fibrosis, and we put them on a screening, an index MRI. And if you see this nodularity of the liver, then we follow him with a yearly MRI. And you see what happened here again, and you now see here some hypervascularity and 2 years later, an early hypervascularization lesion developed, no washout, but was resected and was an hepatocellular carcinoma. And of course, radionomics and all the evaluation of artificial intelligence, and you see there's a huge increase in artificial intelligence, use of machine learning and all these things in early identification of the at-risk population, and it will be perhaps a major game changer in this field. So my conclusions are any surveillance is better than no surveillance, but HCC surveillance is underused in clinical practice, and there are several multi-level interventions that are needed to increase surveillance utilization. The current ultrasound-based surveillance only works in specialized centers, not in primary care in my view. AFP should be implemented in the HCC surveillance strategy, and especially the constant increase should trigger additional imaging techniques for which EUB MRI has the highest sensitivity. And the biomarker-based surveillance has advantage that it could be broadly implemented also in primary care. And we need a refined definition of the at-risk population without cirrhosis. And this can be done by readily available HCC risk scores and helps to limit the screening efforts to those at highest need. Polygenic risk factors, I think, have potential and should be further evaluated. And for certain high-risk groups, I think we have to adapt our screening and have to intensify it, and I've shown you the data here. And artificial intelligence has a potential to revolutionize HCC care and surveillance. Thank you very much.
Thank you, Professor Berg. Can I request you to join us here? The next talk will be on staging of HCC, what is new in INASL guidelines. And the talk will be delivered by none other than Professor S.K. Acharya. This audience needs no introduction to Professor Acharya, who is the most popular teacher in this country of hepatology. He is also the driver of INASL guidelines on HCC, of which 3 editions have come. The 3rd edition is going to be released tomorrow during the meeting in the morning. And he's going to talk what changes we have made in the staging of HCC in these guidelines.
Thank you, AC. And you give a background as if I'm going to provide a new staging or new modifications which will revolutionize HCC management. Nothing like that. Essentially, all of you are aware that there are various staging systems of liver cancer, particularly in cirrhotic, and you know the criteria also. You also know that out of most criteria, there are a few criteria which it not only defines the tumor burden, the tumor spread, the underlying functional status of the liver, the performance status of the patient, depending upon the prognosis and treatment allocations. That is also well known to all of you. However, what has happened in HCC during last 25 or 30 years, the treatment has advanced. And when transplant came in, and resection was going on previously, and ablation came in, particularly from Italy in somewhere in 1980s, people could knock off HCC completely, particularly smaller burden, good liver, good performance status, good liver functions, and they could cure it, and they could have long-term survival. So we divided treatment of HCC into curative, right, and palliative treatment. However, over this period of time, many of these patients who are undergoing palliative treatment, now because of advent of multiple therapies and increase in armamentarium and therapies in HCC, are indeed can be cured or downstaging and bringing to the curative treatment. That is a major modification. And third, those advanced HCC which cannot be downstage, which cannot be cured, for them, various systemic therapies has evolved, and there is a huge multiplication of various types of systemic therapy, and they are also going on, and you will see them more. So depending upon the staging system, HCC, which allocate treatment must change. And that's what INASL did, keeping all the literature and information in view. And now in India, a lot of these treatments are available very widely. So this I just told that you know very well.
that HCC itself is a multi-step, right, genetic alteration in the cirrhotic liver, and cirrhosis itself is heterogeneous. And depending upon cirrhotic functions, cirrhotic sequelae, they can die despite treatment of liver cancer. Liver cancer is also, the tumor burden is varies. The intrahepatic vascular invasion varies. Their spread can vary. So these are actually homogenized by staging system, and they are essentially, as I have mentioned, for prognostications, and based on prognosis, treatment allocations, and based on previous experience, their possible response, and also now those who are unable to get curative treatment to stage them to fit into curative treatment to improve survival. And also, since biology is known now, tumor biology, and we know the factors for recurrence, that has to be kept in mind when you are treating this patient, particularly patients who are undergoing transplant, because the post-transplant recurrent of HCC is a huge problem. And Dharmesh told, transplant is not a cure, it's a swap for another disease. And recurrence in such a patient tumor is a headache. Now, we know the classical Barcelona clinic liver cancer staging, which you have modified. You all know their stage 0, A, B, C, D, depending upon the tumor burden, right, tumor invasion and underlying liver function and patient's performance status. This is very old, and Barcelona clinic liver cancer staging has undergone 5 modifications, and latest in 2022, which I'll briefly discuss. This is depending upon the number of nodule, I need not repeat it. And this is an old BCLC, and I have given, depending upon the stage, what are the different type of therapy, which is also very well known to people. And you just heard from Dr. Berg that effort to diagnose HCC early, to give them curative treatment while going on, and where we have no very good biomarker. And at best, ultrasound and alpha-fetoprotein had a 63% sensitivity. And that adherence is very poor. One thing Dr. Berg, I think I requested, I will request that factor should come in. You may have a low sensitivity and specificity of a diagnostic surveillance, but adherence is a very important thing, which will increase the detection rate and actual in a cohort sensitivity rates. And adherence is the biggest problem in screening HCC. And you have seen, I'll just summarize the advancement in treatment. And first thing, that liver function test conventionally was to be classified according to child Turcotte-Puig score, right? Less than 6 is included for all therapy. Now it has been seen, they have been subdivided based on albumin and bilirubin score, which is ALBI score. And very interestingly, it has been seen, ALBI can be 3 grades. I will discuss about it. Those who have ALBI 1, those who have good liver function in child, say, and ALBI 1 can tolerate and survive aggressive treatment like systemic chemotherapy and multimodality therapy. That's why the ALBI score is very important to decide on the treatment. And their functional status should be 0. So the treatment eligibility is this. This is a big problem in our country. Now, if you see early SCC, which is BCLC 0 and S, small tumor burden, good liver function, good performance stresses, no vascular invasions. Now we know various ablative technique. Now we know that microwave has scored over radiofrequency ablation. I have no time to discuss the advantage and disadvantage of RFA over microwave. And now ablations of larger tumor is being gold. Even you have a single SCC, you can subject them to intra-arterial radiotherapy. And there are excellent study for success. Liver resection, we know conventional criteria of liver resection that they should not have portal hypertension, their MELD score should be 9, and there are less than 3 segment resections. And Subhas obviously operates more. He says any number of tumor, and I will resect them, right? And during surgery, obviously the functional liver reserve, functional liver value, portal vein embolization, and liver partition to increase the reserve of the non-resected liver other further modification which has come in, increasing the surgical approach and surgical technique. Now, many patients who do not fit into our early SCC criteria for transplant or ablation or liver resection can be downstage by using various treatments. And intermediate HCC in previous BCLC were not at all suggested to undergo any transplant. So these people can be transplanted. Now, if you see the recent BCLC classification, the intermediate BCLC-B, that is tumor more than 3 or single tumor larger than 5, right? They were called BCLC-B, but without vascular invasion, good liver function, good performance status. Now they divided this B into 3 groups because of experience. First one was more tumor burden, but transplant surgeons like Subhas told no problem. In fact, they follow University UCSF criteria, which says more tumor, say up to 4.5 centimeter instead of 3 centimeter, or single tumor more than 6 centimeter, or total tumor burden up to 8 centimeter, do as well as Milan's, which is less than 3 or 3 number tumor. So that was BCLCB. You can upfront transplant them. The second group is the increased tumor burden who has a clear arterial feeder. There you can do a TAS, transarterial chemoembolization. There you can give chemotherapy. The others you cannot. That is a very important thing. And there is a diffuse variety of tumor which doesn't respond to TAS. So they divide into 3, V1, V2, V3. And they suggested those, that is B3, should undergo systemic chemotherapy. They didn't suggest at all to downstage them or multimodality treatment or radiotherapy, which we had included because they work. There are reports. And also, in such patient, the reports are there that intraarterial radiotherapy is better than intraarterial chemotherapy. And therefore, the INASL guideline, if possible, TARE has suggested TARE to be better than TACE. And sometimes you can combine. There are 2 lobes involved. One is a smaller tumor, one is a larger tumor with a clear vessels. You can do a TARE and ablation in the other tumor, therefore knocking up the whole tumor. And even in this stage, if you downstage them and fit into the UCSF or Milan's criteria, you can transplant. Or if you have smaller and fit into the resectable criteria, because organ is not available, you can resect. These are the modifications we have introduced. And in advanced HCC, that is, there is a vascular invasion. Vascular invasion can be inside. We know the vascular invasion, Japanese, is classified as BP1, BP2, BP3, and BP4. BP1 was the beyond second order of the portal vein, second order of portal vein, right? The first order of the portal vein, and the main portal vein, BP1, BP2, BP3, BP4. Now, the Southeast East Asian countries have been very aggressive in resection. They resect tumor even with intravascular vascular involvement. So VP1, VP2, VP3 can be resected along with the tumor even with a mild portal hypertension, and their result, 5-year survival, is about 70 to 75%. So that was a consideration INASL considered, keeping in view of our problem of DDLT, because 95% are LDLT, which are select population. Out of 100 people who are eligible for transplant, 10 can only afford or donate organ, 90 cannot. So therefore, resection is an important thing for us, and we thought if it is resectable, by using multimodality and downstaging, we should resect, or upfront they are resectable, we should resect straight away. And BCLC never suggested any bad liver, that is child C. With any tumor, they suggested supportive care. But now we know if they follow the transplant criteria, that is less tumor burden, child C, they can be transplanted and cured. Those are the modifications we have included essentially in our modification. And by now, irrespective of this transplant advancement or treatment advancement, the biological aggressiveness of the tumor has become a major determinant for post-therapeutic recurrence. And therefore, when you are doing surgery and transplant, to cure them with a curative intent, they become very important. And a alpha fetoprotein more than 1,000, they don't transplant. They will be downstage to below 100 to transplant to prevent the recurrence. A PET positivity indicates biologically aggressive tumor because slowly growing tumor will not take up FDG. Second, after downstaging, they wait for some period of time because during waiting period, if it recurs, it is aggressive tumor. So all those criteria has been identified. Even some people do histology to see whether well differentiated or poorly differentiated cancer. Poorly differentiated cancer has a more chance of recurrence. And those factor has been added into this staging system when you are allocate treatment, keeping this biological aggressiveness and using downstaging as an important factor. So what I say, the intermediate stage can be down stages to early stage for curative intent, and that's it essentially, even certain advanced stage. This is the new BCLC criteria. I need not go into the details. I told you that these are the modification. One is ALBI, and if you see all the early stages, including intermediate stages, their performance status is 0. They are all walking. They have good liver function. So most of the treatment is directed towards them. If they slip, even the performance status, they suggest systemic treatment, right? Not further treatment. These are the modifications we have added. And they had suggested, if possible, downstaging, because downstaging endpoints are not clear till now. So you can do the transplant. And you can use TARE when the tumor size is large, because TACE doesn't respond. And they also define various treatment migration policies while on treatment to go to the next step of treatment. So these are the essential things which I discussed, the changes in new BCLC score. One is ALV score to subdivide the liver functions. Second is categorizing BCLCB into 3 groups, B1, B2, B3. And third thing, they define treatment stage migration or untreated progression. That means if despite one treatment, the disease is progressing or not responding, go to the next step. And downstaging is an option, and there are various forms of systemic therapy for advanced cancer. And as I was telling about ALBI, multiple studies have shown that ALBI is a discriminant score you can calculate on your app, and depending upon the scores, the results are different. So keeping this ALBI score in mind, when you are treating patients with TARE, TAS, radiofrequency ablation, microwave ablation, multimodality treatment, remember ALBI 2 and 3, right, may not do that well. They may progress. And in them, a curative intent, the transplant should be always open. That we have discussed in INASL, because this is very important. So, however, these are the weaknesses that I just discussed in BCLCB. They didn't discuss about resectability, which is necessary for us, in which we can downstage. And multimodality can be used, they didn't discuss. And intrahepatic vascular invasions can be resected. And TARE is more effective than TACE. And also, they didn't mention that transplant should HCC in child C patient with limited tumor burden should be done. Those are things which we have included. And third thing we included, that instead of CTP-A, we have extended intermediate stage to CTP-B8 and also up to performance status 2, because these patients are excluded in Western country, but we cannot afford, and there are now evidences based on which we recommend these patients do much better than not to offer them these treatments. And these are the 3 major things we have done. So this is what I discussed. And if you see, we divided, these are the major things. We divided them into 4 groups: good liver, good functional status, small tumor burden, intermediate liver, intermediate tumor burden, and good functional status. Intermediate liver, functional status is intermediate, and tumor burden is also intermediate, and bad liver and bad functional state. These are 4 broad groups we divided. And depending upon these 4 broad groups, we have offered, if you see, downstaging more often in all these patients using TARE or intraarterial radiotherapy, and more often transarterial radiotherapy because they are more effective. These are the treatment modification we have brought in. Even in advanced stage, if you have an intravascular invasion inside the liver, we can use radiotherapy. And we have included resection, which has not been included in this other guidelines. So these are essential modifications we have brought in, and we have grouped them into 4 different groups. And that's what I told, BP1, BP2, BP3 can be resected. And here we have also suggested you can resect one lobe and ablate another lobe, particularly in the intermediate group. And if there is indication to transplant, he is fit for transplant, but if donor is not available, you can undergo resections. Thank you, ladies and gentlemen. These are the basic modifications we have included.
Thank you, Dr. Acharya, for that elaborate discussion on staging. I request you to take a chair on the stage. Next, I would like to invite Dr. Sridhar BC, who is Associate Professor of Radiology at PGI Chandigarh, to deliver a talk on loco-regional treatment in HCC, how to choose. So, Dr. Sridhar.
Thank you, Chairpersons, and very good afternoon to all. At the outset, I would like to say that what the Acharya sir has discussed, this is what generally we follow with the help of a hepatology department, because most of the cases that we in our scenario say is intermediate stage or an advanced stage. So if we actually go by BCLC stage, almost 70-80% of the patient will not get any kind of LRTs. So in the next 15 minutes, I'll just go on with the case-based discussion, and we'll try to tell what kind of ablative modalities or intra-arterial therapies we choose based on the lesion and size. So we all know surgery is the best treatment, but then unfortunately more than 80% of the patients are not fit for the surgery. So we have to offer them some kind of a therapy. So we have 2 kinds of therapies: ablatives, which are with a curative intent, and then an intra-arterial therapies. Those can be with both curative intent as well as a palliative intent. In the ablative, there are so many therapies, but most commonly used and studied with the available literature is thermal based, that is RFA, microwave, and cryo, non-thermal IRE. In the arterial therapies, we have a bland embolization, chemoembolization, deptase, and a radioembolization. So this is the BCLC stage that you all are aware of it. Unfortunately, it limits our role as an IR only to early 3 stages. So coming to the case-based scenario, this is the first case. Here we can see there is a well-defined lesion, less than 3 centimeter with the parenchyma all around. So it's a straightforward lesion for an ablation. What kind of an ablation? Here, fortunately, we don't have any big vessels surrounding the tumor, so we go with the RFA. Which with the 2 decision-making factors here with the RFA is that RFA is cheap, almost 60,000 as compared to microwave, it would be 1 lakh. The second thing is that there are no limitations. In RFA, it is because of an alternating currents, there is a water movement, coagulation, necrosis happens. So there is a limitation with this one. Whenever we use an alternating current, because the tissue just adjacent to the RFA probe gets heated first, it gets desiccated, it gets charred, and it creates an impedance. So if you're using a RFA for a more than 3 centimeter size, as the current goes peripherally, the effect becomes unpredictable, and hence there is always a limitation that we may have a recurrence. The other thing is that if you have a bigger vessel, like any artery that is artery or a vein which is more than 4 mm just adjacent to the lesion, it tend to cause a heat sink effect. Again, it becomes an unpredictable zone. So fortunately in this patient, we didn't have those 2 limiting factors, and hence we went ahead with an RFA. Here we can see this is our RFA probe placed at the center. This is how often the ablation looks. This is one of the limitation when we consider ablation, because lot of gases actually blur the margin of ablation zone. So sometimes it becomes very difficult to appreciate the area of ablation. However, this is what at the 3 months, there is complete ablation, no recurrence. At 6 months, patient is doing well. This is another same lesion, size is less than 3 centimeter. Only thing is that you see a vessel just proximal to it. So there is always a risk of heat sink effect if we go with an RFA. This is how it looks on an ultrasound. So here we can see a branch of hepatic vein almost coursing all along it, increasing the risk of heat sink effect, and hence we choose a microwave. The phenomena is that microwave, here we don't use an alternate currents, we use electromagnetic waves to create a movement within the water molecules. Again, these movements causes a frictional heat, again a coagulation necrosis. At the end, ablation happens the same way. Only difference is that since we use a microwaves, there is no impedance, so we can do a larger ablation with a high tumor necrosis. And the second thing is that the heat achieved is very in a shorter duration. For a 3 centimeter lesion, if I have to do an RFA, I would have to do it for a 12 minutes time, ablation time. Whereas with the microwave, we can do it within 3 minutes. So we can do it at a shorter duration. So there is a less procedural pain, more patient comfort, even the operator comfort, anesthetic comforts, all things are matters. Only disadvantage with the microwave is that it is costlier, almost 50 to 60,000 more than what RFA comes with. This is how we have placed our microwave probe, and then ablation we have done. Again, this is a limitation with microwave because of a lot of gases are produced. So sometimes it is difficult to appreciate the clear-cut ablative margins, but this is what it looks at 1 month and 3 months. So complete response with no recurrence. So as I said, these are the limitations that I have already discussed. And this is the meta-analysis of RFA versus microwave. I think as far as overall survival or a disease-free survival is concerned, both of them are equal. So the only advantage microwave provides us is that for our lesions more than 3 centimeter, we have a predictable ablative zone. And if there is a large vessel, definitely microwave is better than RFA. Coming to my third case, again a same lesion, early stage, less than 3 centimeter, but if you look at the location, it is subcapsular, partially exophytic, and then GB is very close to it. As well as in the coronal section, we can see hepatic flexure is very close to it. Normally, we can get away with routine ablations, but then we have to use a hydrodissection, pneumodissection, or a balloon, different kind of techniques to separate these organs. But fortunately, at PGI, we have a cryoablation at our armamentorium, so we went ahead with the cryoablation. Cryoablation because of two factors. One is that you can see a clear-cut ablative margins with both ultrasound and CT, so we are sure that none of the surrounding structures are affected because of our ablation. And the second important thing is that it doesn't cause pain. So for cryoablation, we don't take anesthetic support, we do it under a local anesthesia. So any comorbidities where anesthesia is a contraindication, we can always go ahead with the cryoablation. So here we can see the lesion. This is the GB, so it will be very difficult to create a hydrodissection between the GB and the mass lesion. And here is the bowl loops. So we have placed our probes here. Since the lesion is slightly larger, we use the two probes with a sushi technique. And on a CT, we can see that the clear-cut zone of ablation. So we are sure that none of the surrounding structures are affected. This is how it looks at the 3 months follow-up with a complete response. So moving on to the next case, again a same lesion, less than 3 centimeter, but the location is near the hyla. Here you can see in the arterial phase, branches of middle hepatic artery and right hepatic artery are encircling this tumor. And here you can also see dilated biliary radicals, which is clearly appreciated in coronal reformated images. This is the tumor, this is the dilated radicals, this is the portal vein, it is sitting on the portal vein, and these are the hepatic arteries. So this is a central location tumor with all the vital structures all around. So what would I choose? Definitely all these things are against a RFA or a microwave. Cryoablation, yes, we can do it, but then you saw that there are two branches of hepatic artery circling, and the probe of a cryoablation is somewhere around 14 gauge or a 13 gauge as compared to IRE probe, which is 18 gauge. So there will always be a risk of injury to the artery, and hence we went ahead with the IRE. You all know how the IRE works out. It basically creates an irreversible pores. So once the irreversible pores are created, cells gets damaged and they are taken up by apoptosis, so there is no significant inflammation. And since we use ultra short pulses, there is no significant heat or a thermal based effect on this one. Why bile ducts or vessels are saved? Because they are primarily made of collagens or proteinaceous structures. So the alternate currents that tend to create a irreversible pores are less likely to affect these proteinaceous structures, and hence even though they are within the vicinity of an ablation zone, they are less affected. So here we can see the only disadvantage here is that we need a general anesthesia because these alternating currents has to be given in a synchronized phase in an ECG gated machine in a refractive phase of a ECG cycle that is somewhere between S2 to T segments. And second thing is that since we give a multiple ultra short pulses, they tend to excite the neuromuscular junctions, causes a muscle contraction, hyperkalemia. So for all these things, it's important that we take up a GA. So here we can see that we have placed our probes. here something what we used was this, since this lesion was smaller, we used the no touch technique. We have placed all 3 of our probes around the lesion, and then we have done an ablation. And this is how it looks immediately after the ablation. So all the vessels within the vicinity, even the portal vein branches, are unaffected, and patient did well. So just a overview of what we practice at PGI is that we divide the liver into 4 zones. Near the hilum is considered as a zone 1, where the significant vascular structures or vital structures are around. Here in this lesion, if we find any lesion smaller, we go for an IRE if it is doable. Otherwise, we consider TACE. Then those lesions in the periphery are considered as zone 4. In the zone 4, we can use all kind of modalities. If the lesion is more than 50% exophytic, then we probably choose a transarterial embolization because of risk of rupture and tumor seeding. If it is less than 50% exophytic, we can use all kind of ablative modalities. If it is near to the GBA or colon, we use a cryoablation. Again, this is another limiting factor for all the ablative modalities, especially for RFA and microwave in our setting, is the cost. So coming to the next case, this is a multifocal lesion, BCLCB. You have 2 lesions. One is in segment 4A, the other one is in segment 5. It is completely exophytic. We can see this is in the falciform ligament, and it also measures around 4.5 centimeters. So it's a straightforward case, BCLCB. We went ahead with the TACE. Here we can see that we have selectively went into both the arteries that are supplying the tumor. We have given a lipidol TACE, and this is how a lipidol uptake looks after that. This is a type 1 lipidol uptake without any recurrence. But if the lesion is more than 5 centimeter or more than 6 centimeter, though the practice is that if the tumor burden is less than 50%, we can still go ahead with the TACE. But there is a recent precision study that says that TACE versus DEP-TACE, always if the lesion size is more than 6, it's better to go for a DEP-TACE. That's what we practice here. So this is the lesion which is almost about 8 centimeter in size, and there are multiple arteries that is supplying this tumor. So we went ahead with the DEP-TACE. One of the limitation with the DEP-TACE is that these leads are not radio opaque, similar to as lipidol. So even if I have injected, you may not see those things. So in this scenario, we immediately take up an angio-CT to look where our drug has been deposited. Here it looks brighter because we have used the contrast to load these drugs, and hence we can see where its deposition has happened. And this is what a follow-up, 3-month follow-up dynamic MRI looks like. There is a minimal residual loop, but compared to what the size was, there is a good response in this lesion. So as I said, there were 2 studies which showed that DEP-TACE is better than TACE for the 2 reasons. One is that the DC bits are nothing but an embolic material. So when we load them, they deposit within the tumor. So there is a very minimal systemic absorption of doxorubicin, and then systemic side effects are less. And it gives us a good necrosis. And for a lesion more than 5 centimeter, definitely TACE has significant adverse effects as compared to DEP-TACE. So this is my next case. Here we can see this is a large lesion, which is almost 13 centimeter lesion, entire right lobe. And on top of it, you can see that portal vein is thrombosed. It is not a tumor thrombosis, it's a chronic thrombosis because of cirrhosis, and we only see a atretic segment. So this is actually a BCLCC. If you actually go by the BCLC staging, this patient has to be given only a systemic therapy. But we, as in our practice, we always have a discussion with the clinical counterpart. Since patient's general condition was good, CTP was good, we went ahead with the TARE. So in TARE, what we did was, since there were 3 arteries that were supplying the tumor, and the volume of the 3 arteries, tumor volume was different, we choose different doses for all 3 arteries, and we give 3 different doses of Y90, and this is what the PET uptake looks after the procedure. And this is how 10 months follow-up, this patient is walking around, is perfectly doing fine with a M-RECIST criteria. This is considered as a non-viable tumor in M-RECIST criteria. This is again another similar lesion, but here we can see that this is the tumor thrombus going up to VP3, almost VP2 definitely. So here we can see the lesion size was around again 8 to 10 centimeter. Here again, this patient was offered TARE, though if you go by BCLC, he will not fit into, but because provided is all other clinical scenario, we offered him a TARE. And this is how we do a volumetry for all 3 different vessels. And this is what the response what we have achieved at the end of 5 months. So this patient, there is some amount of minimal residual. Definitely we will consider this patient for a TACE in the next session. But what we can also notice that the portal vein has significantly opened up as compared to the previous. So definitely the recent INASL recommendation that Sarah has discussed is a welcome step. because there are a lot of patients who fall into these categories where we can offer them a treatment. Probably we can make them fit for the transplant in the further sessions. These are the recent trials that have compared Y90 with the DC beads, because many times it happens cost is the limiting factor, because DC bead would cost somewhere around 1 to 1.5 lakhs, whereas Y90 would cost around 8 lakhs in our setting. So this is something which tells that if patient is affordable, always go for Y90, because the median survival rate is good, the complication rate, the tumor progression rate, all these three things are better with the Y90. And again, this is another personal dosimetry trial, because earlier what we used to do is we used to give less than 120 grays. So this is one trial that came up in 2021 where they said that you should always aim more than 200 grays to have a good response. That's what it's trying to say, that with the more than 200 grays, the response is very good. So this is just a screen grab of what Sarah has discussed. So we as an IR, it's a welcome step that they have divided intermediate stage into all three substages, stage B1, B2, and B3, and even an advanced stage, stage C1 and C2. So as an IR, we can always play a role in these scenarios as well. Even in VP1, VP2, and VP3, we can offer a treatment. So just to conclude, RF and microwave are comparable only if the lesion is more than 3 centimeter and a large vessel nearby it. Consider microwave. Otherwise, RFA will equally do good, except that patient will have a kind of a pain or some kind of limitations. IRE is prepared for the hilar lesions, cryoablation for the lesions near to GB and bowel loops. With respect to arterial therapies, it all depends upon the size. 3 to 6 centimeter, definitely conventional TACE. More than 6, it depends upon the affordability, either a conventional TACE or a depth TACE. Even a VP1 lesion we are doing, if the lesion is less than 5 centimeter, but VP1 means a segmental portal vein involvement, then we still offer them TACE or a depth TACE. But VP2 and VP3, most often then we offer them a tear, and they do very well. Thank you.
Thank you, Dr. Sridhar, for this excellent description of all the local regional therapy. I would like you to take a chair here. Now, it's my proud privilege to introduce the next speaker, who needs no introduction in this audience, Dr. S.K. Sareen, who has been my mentor. He is the director and chancellor of Institute of Liver and Biliary Sciences, New Delhi. So he'll be presenting on systemic therapy for HCC by a video lecture. Can you start the lecture?
Greetings from ILBS. I'm grateful to the organizers for allowing me to give this brief presentation. I have no conflict of interest, except that we have very bright faculty and brighter residents across the country. Today, the commonest cause of liver cancer in India is diabetes. 35% of HCCs are diabetic. The development of liver cancer can go through normal to cirrhosis to dysplasia to HCC, or it can also go, remember, directly because of inflammation in a non-cirrhotic HCC, and 50% of fatty liver HCCs are non-cirrhotic. With this background, let's come to the systemic therapies. Systemic therapies are given in patients with BCLC, advanced stage C, where there is portal invasion or extrahepatic metastatic spread with preserved liver functions and performance status is good, or intermediate stage B, which has diffuse infiltrative extensive bilobar involvement. And our aim is that we have more than 2 years of survival, and the first line drugs are immunotherapies, if not feasible, to sorafenib or lenvatinib, and the second line drugs are TKIs or other combination. I will mainly discuss on the immune checkpoint inhibitors. Here is a case, large, big tumor, which is also involving the portal vein, as you can see very much here as a tumor. So two approaches, TKIs or immunotherapy. The Nobel Prize in 2018 was given to Dr. Honzo, PD-1 inhibitor innovators, or Allison, CTLA-4 inhibitors. When there is a tumor, the cancer antigens, they go and the antigen is presented to dendritic cells, antigen presenting cells, it goes to the lymph node, and here there is priming which occurs. And at this stage, the priming may be inadequate, and therefore these inadequate priming is due to CTLA4 or PD1. Now here there is trafficking to the tumor infiltrating lymphocytes come, and then these lymphocytes, they recognize the tumor antigen, and here the major role of PD1 will come, and they will kill the cell. So two spaces, lymph node and recognition, and T cell functions. Let's look at this. So now from the lymph node, there is a tumor antigen which has to be prepared, and the T cell has to be activated, which has two signals, the MHC and T cell receptor, which they join, and a co-stimulatory signal, the second signal, which is B7 from the tumor antigen and CD28 on the T cell. If these two signals work together, T cell gets activated and will kill the tumor cells. Now, there is also from this, there is an inhibitory signal because body has to balance. So besides this signal, the co-stimulatory, which is B7 of the antigen presenting cell, is now to join, but there are two inhibitory molecules, PD1, programmed as receptor 1, or CTLA4. Now, the CTLA4 has a 10 times stronger activity to B7 than CD28. So always the inhibitory molecules are higher, and this will keep the T cell inactivated. Our checkpoint inhibitors are antibodies that selectively block the checkpoint receptors PD1 or CTLA4 so that the antigen presenting cell can activate the T cell. I hope this is the basis and you understand this. So what are our therapies today? PD1 or L1, the inhibitors include nivolumab, pembrolizumab, durvalumab, atezolizumab, or CTLA4 inhibitors, tremelimumab or ipilimumab. So immunotherapies can be mono or combo. So here you have first drug and proof of principle of immunotherapy was giving nivolumab PD1 inhibitors. Compared to sorafenib, when nivolumab was given, there was overall survival advantage. Here it shows that patients who got a recurrence on sorafenib with high AFP after immunotherapy and they remained disease-free up to 5 years or 1 year. Then came the new generation atezolizumab and bevacizumab combination in unresectable HCC. Now, as I said earlier, atezolizumab is a PD-L1. So now what it will do, the T cell receptor and MHC binding, but it is blocked by PD-L1. And the PD-L1 is inhibited by atezolizumab so that the tumor cell and the T cells can active and the tumor cell can be killed. On the other hand, you have another drug called bevacizumab. Bevacizumab works by reducing angiogenesis, which is part of tumor growth. VEGF also causes the growth and the immune inhibition. It inhibits the T cells, antigen presenting cells, increases Tregs, MDSCs, the myeloid derived suppressor cells, and the tumor associated macrophages. All these make a bad microenvironment. Bevacizumab, the inhibitor, also improves the microenvironment by increasing the T cell responsiveness. So combination of atezolizumab and bevacizumab is scientifically very strong. Now I'm giving you a summary which is published only yesterday on JAMA Oncology. I will give you all the trials till date in their perspectives. The first trial of TKIs, sorafenib versus placebo, gave an advantage of about 3 months or so. This is progression-free survival, and this is the overall survival, and this is objective response rate. Then lenvatinib was compared to sorafenib. There was a distinct advantage of almost, let's say, a year or so of this. But when you look at this, the actual survival may be just about 2 months or so in overall survival. Then you look at the trial which used atezolizumab, which is anti-PD-L1 and combination of EGF, and this gave a huge survival benefit, 27 months compared to 11 months or so. And this substantial benefit made atezolizumab and beva as the first line therapy, especially when compared to sorafenib. Then you have newer drugs, sintilimumab, which is anti-PD-1 and VEGF combination, and this also gave an advantage. And then the Himalaya trial. The Himalaya trial included another drug, tremelimumab, and which is an anti-CTLA4. These were PD-1. This is CTLA4 inhibitor, which is another inhibitory molecule, suppress it, and durvalumab. So these combinations of drugs made the combinations gave better advantage overall as compared to sorafenib. So when you give the drug combinations, CTLA4 inhibitor and PD1 inhibitors, the increase in the duration of survival was markedly increased. Then you have anti-VEGF plus TKI combinations, camrelizumab, which is another very emerging therapy, 25 months versus 5 months survival benefit. The second line therapies included regorafenib, and compared to placebo, this is the only one where it gave a overall objective response rate of 11 months, and it was better. However, when you look at cabozantinib and other drugs, they also gave survival advantage. But these are all now second line therapies. So clearly, immunotherapy is the first line therapy today. Are there any predictors of response to atezolizumab and bevacizumab? If there is a pre-existing good immunity, means the patient has high CD274, T effector cells are more, and the intratumoral CD8 density is high. So liver biopsy is helpful in these. There are low Tregs and more of effector T cells, low expression of oncofetal antigens like a low AFP or GPC3, high expression of VEGF receptors. There is also myeloid inflammation signatures. Anti-VEGF synergizes, that is, bevacizumab synergizes with anti-PD-L1 and it suppresses the angiogenesis, Tregs, and myeloid proliferation. Are there contraindications to this combination? Yes. If a patient has unstable angina or myocardial infarction, avoid it. Transient ischemic attacks, pulmonary embolism, bleeding events, high risk varices. So this is to show you that PD-L1 expression in the intratumoral inflammatory cells and neoplastic cells, it shows aggressive behavior of the tumor, but also shows that these patients will respond well. Here in the malignant hepatocytes, and then afterwards there is a clearance. Now, this diagram is important for us to know which are the good cells. T cells, effector CD8 T cells, neutrophils, and therefore a high neutrophil ratio is very good for us, and the dendritic cells, which present the things. What are the bad cells for us? T regulatory, which inhibit. The myeloid-derived suppressor cells, these are, so in tumor, Tregs are increased, MDSCs are increased, and we therefore need to suppress them. The anti-CTLA4 is good. For T cell, here anti-PD-1 and PD-L1, they are very good. So this is in lymphocytes, lymph nodes, and this is at the periphery. And anti-VEGF drugs and TKIs, they will actually neutralize the MDSCs. We also have to look into mutations like beta-catenin mutations, which make a hot tumor into a cold tumor, non-responsive. And tumor-associated macrophages, TKIs inhibit them. So a combination ideally of TKI and systemic therapies will be very useful. Here PD-1 in immune cells in the tumor is seen very. Now I will give you the guidelines. So this is just published a day ago, yesterday. It tells you inoperable HCCs and management and all different associations guidelines. So what is the patient profile? Advanced HCC, BCLCC, portal vein invasion, extrahepatic spread, or intermediate HCC with multinodular disease which cannot go on locoregional therapy with a good ECOG 0 to 1. First question you ask, is my patient candidate for immunotherapy? No. Why no? His autoimmune disorder, high AST, ALT, and maybe there is evidence of autoimmunity, or the patient is a liver transplant. Don't do immunotherapy or any other therapy. If the patient is a candidate for immunotherapy, then you say whether there is a high risk of variceal bleed. Then you might actually not give bevacizumab. You will give a combination of tremelimumab and durvalumab. If he is not a high risk or the patient has been banded, bevacizumab and atezolizumab will be the first line combination. And for this group, only lenvatinib and sorafenib. Now, on the combination, if the patient has progressive disease, you can go and start, and this is important new, tremelimab and durvalumab can be given to progressive disease patients. Moreover, they can also be combined with lenvatinib or sorafenib. Now, if there is progressive disease and there is no possibility, you can give regorafenib as the first choice or cabozantinib. However, if these patients come on this category, you can always give nivolumab or other biologicals. I will briefly go on to a patient of metastatic or large inoperable HCC, also has portal vein thrombosis. So he has a VP4 main trunk or main branch or second order branch or third order branch. For these patients and others, you have to have a different therapy. Why? Such patients of HCC with portal vein thrombosis generally have deranged liver function, and there is a fear of ischemia and rapid spread. They have a high portal pressure because of portal vein block, so they can bleed more and poor control of bleed, and they may have ascites. So this group of patient needs extra care. Our aim is to reduce tumor burden, open PVT, and preserve liver functions. So the approach in such patients, if it is child A or B, and then you see that there is a main branch, total first order branch is blocked, straight away go to systemic therapy. And you can use high dose vitamin K. There is data that it decreases PIVKA very rapidly. If it is in the second order or third order branches, then of course you can use all other kinds of therapies. The real world data on immune checkpoint inhibitors in HCC with microvascular tumor thrombosis. Patients who have PVT, in them immunotherapy has been found to be effective, and patients even with IVC thrombus or portal vein thrombus, you can achieve objective response rate of about 50%. So I think immunotherapy is fairly good in patients with PVT. Here you can see a patient where portal vein thrombosis was there, which got response. Now, there is a special group of post-transplant patients. Now, I'll carefully like you to understand, if there is a slow tumor growth, biologically, AFP is normal, PIVKA is not very high, hold on, give oral TKIs, don't give immune checkpoint. However, if there is a rapid tumor growth in such a patient, and if it is old enough, 4 or 5 years, chance of rejections are low. You may try under careful thinking. That patient will die not of rejection but of tumor. You can try, especially bevacizumab. ICIs can have many side effects. They can start mainly from pneumonitis, which is one, and all other kinds of immune stimulant activities. How do you differentiate a patient who has got immune checkpoint inhibitor related autoimmune or classical autoimmune? You will have high ANA in the biopsy, in the blood, and in biopsy plasma cell infiltration. While in the autoimmune in the ICPI induced AIH, you will have histiocyte and ductal or endothelial injury. So a liver biopsy is very helpful in this. You will not see plasma cells in this. How common it is? You will have a grade 3 or more ICIs in about some of the trials as high as 70 to 80% or so. So be aware of this. What are our guidelines for treatment? If the patient has grade 3, which means there is rash and you have high liver enzymes or so, you have to hold immunotherapy, give systemic steroids, and maybe restart if the patient improves. There is something known as a hyper-progressive disease on atezolizumab and bevacizumab. This patient is very rapidly increasing. Can you predict it? Yes, if the NLR is more than 3 or 8. So here you can see that a patient who is rapidly progressive, early enough, you can take this patient on alternative therapies. Can we expand the scope of ICIs? Yes, you can do local stimulation and activate local cytokines in this. And this is done when you do TACE, microwave, or sometimes SBRT. There is a release of tumor antigen. These antigens are picked up now by APCs, and CTLs will come and kill it. And also, the different kinds of cytokines are taken. So we are inducing our innate and adaptive response. This is my last slide to show you the carry home message is a patient who has got an advanced disease B but has infiltrative liver disease and portal vein or an advanced stage 3. This is where we will use systemic therapies. First drug choice is atezolizumab, bevacizumab, or if there is a high risk of bleed, varices are big, durvalumab and tremelimumab. These are not available and very expensive. Hopefully, we can get them. If these are not feasible, can't afford, of course, lenvatinib is superior to sorafenib and should be tried. If there is a failure or you can't tolerate these drugs, patient, then you will give regorafenib, cabozantinib, and others. And finally, remember that we have to convert a cold tumor to a hot tumor by SBRT or by TACE or microwave, immune activate, and then try different combinations. I would also request you to consider joining APASL Kyoto March 27 to 31, 2024 to the best of hepatology. Thank you for your kind attention.